Sir, 3 judges for oral paper and 3 judges for poster presentation. For oral presentation, sir, you are there, Dr. Haren sir and Dr. Anupam sir.
So I think we all three are there, candidates are there. Can we start?
Yes, sir, we can start.
So we can start, sir. Wait.
You, sir, 3 judges for oral paper.
They will not be representing, right? They would just be answering our questions.
Okay.
Will they be presenting the paper again? Dr. Asutosh?
Yes, sir.
Will they be presenting their paper again, or will they just be answering our discussion part?
They will be presenting again, sir. I guess, matlab, we will be presenting the video again.
Is it required? Dr. Anupam Haren?
It is up to the judges, sir.
Dr. Anupam, have you seen those videos?
Few of them I have seen.
Dr. Haren?
Let it be live for everyone, all other participants also, sir.
I think so. You are right. Yeah.
Fine. So start then.
Okay.
Good morning, everyone. I am Dr. Rashmi. I welcome you all to the oral paper presentation session. As you all know, yesterday we had screened all the paper presentations that we have received, and out of those, top 10 were selected. Those were presented again today for the final result. For this session, the panel of judges includes Dr. Ranjan Agrawal, sir, Director Postgraduate Teaching, Professor in HOD Department of Pathology, Rashtriya Medical Research Institute, Bareilly. Dr. Haren Kumar sir, Associate Professor, Department of Pathology, Sarojini Naidu Medical College, Agra, and Dr. Anupam Vashne sir, Professor, Department of Pathology, Muzaffarnagar Medical College, Muzaffarnagar. For this, our first candidate is Dr. Vidyavati.
Yes, ma'am. Good morning.
Good morning, Dr. Vidya. You can start.
Vidyavati, I think you can start. Please continue, Dr. Vidyavati. Share your screen, and I think you can continue with your presentation.
Sir,
We will be presenting the video, sir.
Fine, please do it.
Okay.
Yes.
अरे नीचे आओ यार क्या
Hello everyone, myself Dr. Vidyavati presenting paper presentation on immunohistochemical study of P63 in prostatic lesions. Introduction. Three main pathological processes that affect the prostatic gland are inflammation, nodular hyperplasia and tumors. The benign nodular enlargement is the most common, followed by prostatic carcinoma. The prevalence of BPH with or without prostatitis ranges from 20% at the age of 40 years to
technical error. I'll be playing the video again.
Hello everyone, myself Dr. Vidyavati presenting paper presentation on immunohistochemical study of P63 in prostatic lesions. Introduction. Three main pathological processes that affect the prostatic gland are inflammation, nodular hyperplasia and tumors. The benign nodular enlargement is the most common, followed by prostatic carcinoma. The prevalence of BPH with or without prostatitis ranges from 20% at the age of 40 years to 90% by age of 80 years. Prostatic carcinoma is globally the second most frequently diagnosed cancer and the sixth leading cause of cancer deaths in males. Based on Globacon 2018 estimates, 7.1% of all cancers in men were prostate cancers. In India, it constitutes about 5% of all male cancers. The diagnosis of prostatic adenocarcinoma is usually readily made on morphological grounds. The separation of well-differentiated adenocarcinoma from vast number of histological cancer mimics, which are sometimes reported as atypical small acinar proliferation or morphologically ambiguous lesion of prostate, including atrophy, atypical adenomatous hyperplasia, basal cell hyperplasia, and high-grade prostatic intraepithelial neoplasia. Recognizing small foci of cancer in needle biopsies can be difficult without an accurate diagnostic marker. Considering P63, it has similar applications as those of high molecular
All of
weight
you, please mute
cytokeratins in the
yourself.
diagnosis of prostatic.
Oh, you please continue. There are a lot of background noise. For them, I'm requesting, please mute yourself. You please continue.
What? তুমি মানতে শুরু করছো তোমার কি না না আগে নির্মাণ শুরু করতে সব চেঞ্জ করছি
The results, graph 1 pie chart representing the year-wise distribution of the cases. Most common presenting cases range from the age of 60 to 88 years. Table 1 representing the year-wise distribution of the cases as per histopathological diagnosis. Majority of prostatic adenocarcinoma cases occurred in the time period of 2019 to 2020. Table 2 representing the age-wise distribution of the cases as per histopathological diagnosis. Majority of the prostatic adenocarcinoma cases occurred at the age of 61 to 70 years. Therefore, no statistically significant difference of incidence between the patients of BPH, PIN and prostatic adenocarcinoma was accepted. Table 3 represents duration of study was 3 years, 2 years of retrospective and 1 year of prospective. These are the results. Graph 1, pie chart representing the year-wise distribution of the cases. Most common presenting cases range from the age of 60 to 88 years. Table 1 representing the year-wise distribution of the cases as per histopathological diagnosis. Majority of prostatic adenocarcinoma cases occurred in the time period of 2019 to 2020. Table 2 representing the age-wise distribution of the cases as per histopathological diagnosis. Majority of the prostatic adenocarcinoma cases occurred at the age of 61 to 70 years. Therefore, no statistically significant difference of incidence between the patients of BPH, PIN and prostatic adenocarcinoma was accepted. Table 3 representing the distribution of prostatic adenocarcinoma cases as per Gleason score and grade, where most of the cases were Gleason grade 4. Correlation of histopathological diagnosis with immunohistochemical staining profile. This table shows 39 cases which had an intact basal cell layer on histopathology were BPH and PIN, and they were P63 positive. And with the absent basal cell layer, as per the histopathology, the diagnosis was prostatic adenocarcinoma and they were P63 negative. Table 5, comparing the P63 staining characteristics encountered in the previous studies compared to present study. This above table shows that all the studies had a statistically significant difference in the staining profile of BPH, PIN and prostatic carcinoma cases. Table 6 showing the correlation of PSA levels with P63 immunostaining profile. It shows 37 cases were P63 positive and majority had a PSA levels of less than 4 nanogram, and P63 negative cases showed a PSA values ranging from 7.1 to 14 nanogram per ml. This is a photomicrograph showing benign nodular hyperplasia of prostate with a glandular hyperplasia, and the same is shown on P63 IHC where the basal cells are showing positive reaction. The prostatic intraepithelial neoplasia showing a focus with gland with a nuclear overcrowding and high NC ratio with the basal cell intact, and P63 is positive here. This is the photomicrograph showing prostatic adenocarcinoma with Gleason pattern 3+3 with discrete well-formed glands, same focus showing negative in all the glands. These are the different variants of the photomicrograph showing prostatic adenocarcinoma with Gleason pattern 3+3 with discrete well-formed glands, same focus showing negative in all the glands. These are the different variants of the prostatic adenocarcinoma showing P63 negative in all the variants. Conclusion: P63 immunohistochemistry can be emerging adjuvant staining modality to distinguish morphologically ambiguous lesions of the prostate into benign and malignant lesions. These are my references. Thank you.
Over to the judges for questions now.
Dr. Vidyavati, it was a nice presentation,
Thank you, sir.
but your slides were too congested, the theory part.
Okay.
And one more comment was regarding the references. They were either too old. One was 1943, right? And then you are looking into the latest classification. Right? Asha, one thing in one of your slides, you mentioned that you have taken 3+3 positivity,
Yes,
right?
sir.
But
Yes.
your P63 was negative.
Yes, sir.
Is that so? So what could be the reason for that?
PIN cases and intermediate intermediate category cases are 3+3 with P63 positive.
How did you identify PIN? I mean, what category did you use? What was your criteria to label it as PIN?
4+3 with a Gleason score of 7 and 3+4 with a Gleason score 7 and showing P63 basal cell positivity, sir.
So did you find any difference in 3+4 and 4+3?
No, sir.
No. Okay. And you used which classification?
ISUP 2014 classification.
Okay, because there has been modification after that also.
Yes, 2016 is the recent modification.
Okay, fine. Other judges, please.
Dr. Vidya, is there any entity regarding the P63 positive adenocarcinomas? If you have a P63 positivity,
With like
you know which is P63 positivity.
yes. No, in adenocarcinoma, P63 is negative, sir.
Usually it is
A
negative.
few mimickers like if there is any hyperplasia or PN grade, these may.
Anything else in which you can have a P63 positive adenocarcinoma?
I will
Never heard about that. Never heard about it. It's a rare existence of a P63 positive, and which biological behavior is different from the usual P63 negative. You should go through the text also.
Okay.
And what in the two of the cases of your benign conditions, you have negative pattern. P63 negative was there. What were those cases?
Atypical adenomyomatous hyperplasia.
And how did you
look
confirm
for other areas for an underlying malignancy?
Sir?
Did you look out for other areas, or did you do an extensive biopsy?
Extensive post post radical prostatectomy specimen was there, sir.
So you subjected that to the entire biopsy?
Yes, sir.
You have gone through the other areas also?
Yes, sir.
Any other IHC marker you have used?
I had compared study of a prostate specific antigen with P63, sir. Not
prostate specific in biopsy or in the serum?
No, sir, in serum, sir.
And that was negative, or that was low?
It was around the value was around 4 to 7 in benign conditions, sir. It was approximately varying from 7 to 14 PSAs in prostatic adenocarcinoma cases.
Fine.
Okay, thank you, Dr. Vidya.
Thank you.
Dr. Harind, any questions?
No, sir. Thank you.
Thank you.
I'd like to apologize again for the technical glitch. Now we'll be having second presentation. Dr. Chayanika Kala.
Net cable.
Direct net cable है ना तो attach कर दो laptop.
तो कहा था कि एक नया तारा देगा.
Hello everyone, myself Dr. Chayanika Kala, Assistant Professor, Department of Pathology, GSVM Medical College, Kanpur. And I'm going to present my paper on application of international system for reporting serous fluid cytology for diagnosis and risk stratification of the serous fluid cytology. The study was conducted in Department of Pathology, GSVM Medical College, Kanpur, with the purpose to apply ISR SFC at our institute so as to calculate overall sensitivity, specificity, and risk of malignancy in each categories, and to promote uniformity in reporting of serous fluids. Total 2,318 cases of serous fluids were studied retrospectively in a period of 6 years. Cases were reclassified as non-diagnostic, negative for malignancy, atypia of undetermined significance, suspicious for malignancy, and malignant categories. And the final diagnosis were correlated with radiology, cell block histology, immunohistochemistry of fluids, and final excision biopsy wherever available. Total 2,318 cases were evaluated, with male being 1,329 versus 993 females. Overall sensitivity reported was 58.3%, with specificity and positive predictive value both 100% and negative predictive value of 80.9%. So this is a cumbersome table showing distribution and risk of malignancy of cases in different categories of ISR, SFC. In category 1, 1 out of 4 cases turn out to be malignant in final diagnosis. So risk of malignancy was 25%. In category 2, 315 out of 1,756 cases turn out to be malignant. Hence, the risk of malignancy was 17.9%. In category 3, 8 out of 12 cases turn out to be malignant. Hence, the risk of malignancy was 66.7%. In category 4, 43 out of 57 cases turn out to be malignant. So, the risk of malignancy for this category was 75.4%. Similarly, in category 5, 472 out of 489 cases turn out to be malignant. Hence, the risk of malignancy for this category was 96.5%, and the overall risk of malignancy was 36.2%. Here, I am showing few photographs of the cases of different category. Here, in non-malignant category, we can appreciate reactive mesothelial cells along with lymphocytic infiltrate in all the photographs. In AUS category, here we can appreciate atypical cells lying singly as well as in small cluster. In suspicious or malignant category, here we can appreciate highly suspicious cells forming cell balls, ill-defined acini-like structure. In malignant category, here in photograph A, we can appreciate bizarre cells along with abundant vacuolated cytoplasm, occasional cells showing intracytoplasmic mucin. So most likely it is a metastasis from colonic carcinoma. Here, the atypical cell cluster, most likely metastasis from adenocarcinoma lung. Here we can appreciate ill-defined acini-like structure and clusters of atypical cells. It's a case of metastasis from carcinoma breast. Our study data showed comparable results with the studies conducted by Claudia et al., Rodrich et al., Teng et al., and Pinto et al. And in a study conducted by Ferhani et al., they reclassified 34,941 samples, and the risk of malignancy calculated was 17.4%, 20.7%, 65.9%, 81.8%, and 98.9% respectively for each category. And finally, we concluded that ISR SFC is a 5-tier system which places fluid cytology into well-defined categories that limit possibilities of false negative and false positive cases, and thus provide risk stratification for each category, which further aids to the better management of cases. Thank you all for your patience listening. Thank you. Have a good day.
Open for questions now, sir.
It's very nice presentation, ma'am.
Thank you, sir.
Can I ask you one thing? Did you apply any IHC on these like cell blocks or anything?
Yeah. Yes, we have applied IHC on cell blocks, especially where we suspect metastasis from breast. Then we apply ER, PR, and in some cases from lung carcinoma metastasis, we apply PPF1.
Okay. So,
what were the sites of the serous fluids?
Sir, out of 2,318 cases, pericardial fluids were 102, peritoneal 650, and pleural fluid 1,601 cases.
Okay. It's a nice presentation.
Thank you,
and,
sir.
Which classification system have you used?
So this is the international system for reporting serous fluid cytology, cytopathology.
The latest one?
Yes, the latest one, which has published in 2020, November 2020.
Fine.
Are you aware about any Indian IAC guidelines
Yes,
of
yes, sir.
reporting through cytology?
Indian Academy of Cytology also proposed a system for reporting, which is categories are similar to this international system.
It has also been published.
Yes, sir. In Journal of Cytology, it has been
Yes,
published in Journal of Cytology.
yes, last year.
Yes.
No, not last year, this year only. I think in the January issue.
Yeah, I have read that classification in Journal of Cytology.
It's available on their website as well.
Yes, sir. Yes.
Dr.
What
Anupam,
was the
anything?
gold standard? What was the gold standard for the confirmation of your cytological diagnosis?
So gold standard
For your confirmation of your cytological diagnosis. How did you confirm your diagnosis?
So gold standard, if we have this cell block, then immunohistochemistry on that cell block is the gold standard for final confirmation of diagnosis.
Is it so?
I think so, sir.
Okay, fine. Thank you, doctor.
Thank you, sir.
Let's continue, sir.
Oh, fine, I think the next one.
Okay, sir. Third candidate is Dr. Rohini Mukhashi.
Good morning, sir.
Yeah, good morning, Dr. Rohini.
Good morning.
Please start.
Good morning, everybody. I'm Dr. Rohini Mukhashi. I'm presenting paper on spectrum of lesions in cerebellar-pontine angle region with comparative study of squash and histopathology in diagnosis of cerebellar-pontine angle tumors. Introduction. Cerebellar-pontine angle tumors are the most commonest tumors in the posterior fossa. They account for 5 to 10% of all intracranial tumors. Cerebellar-pontine angle tumors are mostly benign, slow-growing tumors with low potential for malignancy. That's about 1%. The clinical significance of cerebellar-pontine angle stems from the variety of lesions that involve this region and present with myriad of non-specific symptoms. Most common symptoms are headache, sensorineural hearing loss, tinnitus, and dizziness. Aims and objectives of this study were to study about various lesions in the cerebellar-pontine angle region to show the correlation between the squash cytology and histopathological findings of the lesions. Materials and methods. Present study comprises of 18 cases of cerebellar-pontine angle lesions from 2017 to 2021. Results. Out of 18 cases, 7 were of schwannoma, 5 were of meningioma, in which 3 were of meningothelial meningioma, 1 was fibroblastic meningioma, and 1 was clear cell meningioma. 4 cases were of epidermoid cyst, 1 was of malignant peripheral nerve sheath tumor, and 1 was choroid plexus papilla. The following two tables show the history of all 18 patients, where we can see age was ranging from 4 years to 60 years, and male to female ratio was 7:11. That's maximum patients were cerebellar-pontine angle lesions in our study were of females. If you go through squash diagnosis and histopathological diagnosis, almost all patients' squash diagnosis very well matched with histopathological diagnosis except one. This patient, where squash diagnosis was given as ependymoma and histopathological diagnosis revealed choroid plexus papilloma. These are photomicrograph of patients with schwannoma, where we can see in squash hyper and hypocellular area. Hypercellular area composed of slender wavy spindle nuclei with moderate amount of eosinophilic cytoplasm, and most probably diagnosis was given as schwannoma on squash, which very well correlated with the histopathological report. Here we can clearly appreciate hypo and hypercellular area with verrucate bodies. These are photomicrographs of patients with meningiomas. In squash hypover, we can see plump spindle cells with moderate eosinophilic cytoplasm, cells well spread out, and diagnosis was given as meningioma on squash, which very well correlated with histopathology. But in histopath, we could identify different types of meningioma. This patient had spindle cells with abundant clear cytoplasm, and diagnosis was clear cell meningioma. This patient had spindle cells arranged in syncytial and whirling pattern, and diagnosis was given as meningothelial meningioma. This patient had tumor cells arranged in fibrous sheets with dense collagen bundles, and diagnosis was given as fibroblastic meningioma, and all were EMA positive. These are photomicrographs of patients with epidermoid cyst, where in squash we can see clusters of anucleate squams. In high power, we can see one cluster with anuclear squams, and diagnosis was given as epidermoid cyst on squash, which very well correlated with the histopathology reported, where we can see lamellated keratin flakes in low and high power both. These are photomicrographs of malignant peripheral nerve sheath tumor, where we can, on squash we can see hypercellularity of slender wavy spindle cells. On high power, squash showed pleomorphic nuclei with hyperchromasia and increased mitotic activity. The diagnosis on squash was malignant peripheral nerve sheath tumor, which very well matched with histopathological report, where we see uniformity of slender wavy spindle cells with hyperchromasia and increased mitotic activity. These are photomicrographs of choroid plexus papilloma. On squash, the papillary pattern, and on high power, the round towards cells arranged in papillary fashion made us give most probable diagnosis as ependymoma. Later, histopathology revealed well-formed papillary architecture of choroid plexus lined by single layer of cuboidal to columnar monomorphic cells. Discussion. Schwannomas are the most common tumors in cerebellopontine angle region, followed by meningiomas and epidermoid cyst. Rare tumors encountered in cerebellopontine angle in this study were malignant peripheral nerve sheath tumor and choroid plexus papilloma. Squash cytology was concordant with histopathological report in 17 out of 18 cases, accounting for 94.5% accuracy. Squash smear cytology proved to be simple, inexpensive, rapid, intraoperative neuropathological technique of diagnosing CNS lesions. Conclusion. Preoperative neuroimaging studies cannot confidently distinguish various lesions in cerebellopontine angle region. An algorithmic approach to differential diagnosis aided by limited histochemical and immunohistochemical panel can allow the practicing pathologist to make these distinctions with confidence. One of the most important advantages of squash cytology is that very tiny specimens are suitable for smear preparation, which is extremely important in intracranial lesions. Squash cytology findings, if interpreted with clinical picture and radioimaging findings, will help to reach an accurate and rapid diagnosis of rare intracranial tumors. These are my references. Thank you. Hello.
Hello.
Yes, sir.
Dr. Rohini.
Yes, sir.
You diagnosed one case on square cell ependymoma, which turned out to be choroid papilloma.
Yes, sir. Yes, sir.
So, did you find any atypia on square cytology?
Yes, sir. The hyper was showing.
The cluster which you showed was in monomorphic population. And what about any papillary architecture on that square cytology?
Yes, sir. Low power did show papillary architecture. I mean,
didn't show.
I showed my
low
low
power
power.
Didn't show in the this thing squares. There
Yes,
was
sir,
no
it did
papillary
show.
pattern.
There was, sir. I did put the picture of that. I have put the picture of that. It was showing papillary architecture, and round two cell arranged in papillary fashion made us give as ependymoma as provisional diagnosis. But then when we
on the
got
squash, it is typically like a papilloma with a choroid plexus papilloma.
So choroid,
it's not looking
because
like
of the round.
ependymoma rather.
So, I mean, we didn't get those papillary architecture. We were not having, sir, very clear. So only that round two oval cells in papillary fashion we made us give. But then
it's okay. It's okay. Fine.
I think
in squash, could you identify
rather than directly giving the ependymoma and square cytology,
yes,
rather than giving directly the ependymoma and square cytology, you could have given papillary tumor lesion or papillary tumor with some atypical feature or something like that. You could have saved your diagnosis, defended your diagnosis. Yeah.
Yes.
So because it's one is benign, one is malignant.
Yes,
and did you did any? I put any IHC on ependymoma to confirm the diagnosis? Like sorry,
not,
it was turned out to be choroid plexus. What are the IHC? Okay, it was choroid plexus, so you didn't diagnose it.
Yes, sir. That moment we didn't do it.
We may not have done.
Yes, sir.
Okay, so
squash, could you identify the subtypes also?
Otherwise, I'll like what are the channel which you.
Hello. Sorry, sir.
Dr. Harin, you were saying something.
Sir, your voice is muted.
No, sir.
Yes, sir.
Continue, sir. I'll ask.
In squash, could you identify the subtypes also?
In meningioma, we could identify subtypes, sir.
Okay.
Choroid plexus was that it was a grade 1 type.
No, leave that particular case. In
yes,
other
sir.
cases, could you identify the subtypes?
Yes, meningioma, we could identify all three types of the tumors. Clear cell meningiomas, fibroblastic and meningothelial meningioma, we could identify, sir.
So do you recommend that replacing of the squash replaces your histopathology? Because in your last line, you said ki it provides an accurate diagnosis, complete diagnosis, everything.
Sir, in this study,
so are
94,
you recommending squash cytology instead of histopathology?
I won't say it replaces, but for an immediate diagnosis for surgeons to manage intraoperatively, this is a good technique. I mean, fast and quick intraoperative management for the surgeons, neurosurgeons.
Have you read the recent article on WHO classification 2021 CNS tumors? Because that recent it is have been published in article the CNS classification 2021, which has reclassified many things. Okay, so ependymoma is further classified in supratentorial or supra or posterior fossa tumors, and posterior fossa again divided on the type A and B based on the some genetic mutation, positivity or negativity. So have you read that topic?
I had gone through, sir, but I'm not able to remember the classification, but I went through,
Okay,
sir.
no problem, no problem.
I've seen that.
Okay.
Yes.
Okay, thank you.
Yes. Thank you, sir.
Thank you, Dr. Rohini. Next candidate is Dr. Manjari.
Good morning, ma'am.
Yeah, good morning, please.
Good morning. I'm Dr. Manjari. I'm here to present a paper on application of the proposed Sydney system for lymph node fine needle aspiration cytology, a pilot study. FNAC of lymph nodes is a useful diagnostic tool for evaluating lymphadenopathies. Though the technique is widely accepted, there is no uniformity in reporting due to lack of prescribed guidelines and a cytopathological classification. In 2020, the Sydney system has been proposed by an expert panel to bring standardization into reporting of lymph node cytopathology, but still it is underutilized and there is limited data in literature. Hence, this study was undertaken as a pilot study to attempt applying Sydney system of classification to lymph node diseases based on cytomorphological features on FNAC. The study included 250 lymph node FNACs performed in patients presenting with lymphadenopathy over a period of 2 years. The original diagnosis of these cases were reviewed and assessed according to the first diagnostic level of the Sydney system of classification, that is L1 to L5. In order to assess the diagnostic accuracy, cytological diagnosis were correlated with corresponding histopathological diagnosis wherever available. Coming to results, the study includes a total of 250 lymph node FNACs. The age of the patients ranged from 13 months to 85 years. Males predominate females. The most common group of lymph node involved is cervical group, followed by inguinal and then the axillary group of nodes. This table shows diagnostic categorization according to the Sydney system of classification. L1 includes 4.4% of the total number of cases, L2 42.4%, L3 0.4%, L4 1.2%, and L5 the predominant diagnosis 51.6%. So these are the cytomorphological features of the various categories: reactive lymphadenitis, acute suppurative lymphadenitis, chronic granulomatous lymphadenitis, non-Hodgkin's lymphoma, metastatic deposit in a known case of carcinoma breast. Out of 250 cases, histopathological correlation was available in only 62 cases. This table shows that histopathological diagnosis was available in only 2 cases in L1 category, 4 cases in L2, 1 case in L4, and 55 cases in L5 diagnostic category. No histopathology diagnosis was available for correlation in L3 diagnostic category. The risk of malignancy was calculated for each diagnostic category in all those cases where histopathological diagnosis was available. It is 100% in L4 and L5 categories, 50% in L1 and 25% in L2 diagnostic category. Coming to the discussion, the maximum number of cases were recorded in the age group of 41 to 60 years. Males marginally predominated females. Cervical lymph nodes were the most common group of lymph nodes involved. Majority of the cases were categorized as L5 followed by L2, which is in correlation with the studies done by Viglier et al. And Gupta P et al. The high proportion of malignant diagnosis in our study might be due to the fact that our hospital is a teaching hospital and also a referral center for selected group of patients, particularly oncology cases. L2 category, the second most common diagnosis in our study, most of the cases were advised clinical follow-up along with medical management. In L4, 3 cases were included which were suspicious for either Hodgkin's lymphoma or non-Hodgkin's lymphoma. Lymphomas, particularly low-grade non-Hodgkin's lymphoma, are a diagnostic challenge, hence additional diagnostic studies are required in such cases. 11 cases belong to L1 category. These lymph nodes were either subcentimetric or difficult to sample. The risk of malignancy was remarkably high in our study. This might be due to the smaller number of histological controls available. The lone case of L2 category diagnosed as granulomatous lymphadenitis both on FNAC and histopathology was later diagnosed as B-cell NHL on IHC. Relook of the slides revealed coexistence of both the lesions, suggesting that one pathology might mask the other. To conclude, the clinicians still are skeptical about usefulness of lymph node FNAC as there is no universally accepted guidelines in reporting. Hence, the application of a standardized reporting system as in the other fields of cytopathology enables to limit inter-observer variability and also helps to communicate clinically relevant information in a reproducible manner. Rarely, two pathologies may coexist, one dominating the other. Such cases require diligent examination. To conclude, this study, it shows that Sydney system appears to be a user-friendly system that is helpful in bringing standardization in reporting lymph node FNACs. These are my references. Thank you.
Over to judges now.
Hello. Hello, Dr. Manjuri. Is there any criteria of adequacy in the system?
Nothing as such, sir.
So how did you label it as non-diagnostic?
Yes,
so
sir.
how will you
So
decide
if,
the non-diagnostic category?
Sir, if the material was scant or if no opinion was possible because of very low cellularity, so we have categorized them as L1, sir.
And they have undergone histopathology in L1 category, na? Two of your cases of L1, and one came out to be malignant. One came out to be malignant.
One case came out to be malignant, sir, and the other case was benign, sir.
So did you correlate radiologically for that excision biopsy done?
Sir, actually, this is a retrospective study, sir. So we could not get the entire data. Okay. So I mostly relied on the FNACs and the histopathological aspects, sir.
On this, yes, it's a retrospective study.
Yes, sir.
Okay. Thank you.
How many cases of multiple lymphadenopathy did you find?
Sir,
you have labeled only everything as single group of lymph nodes.
Yes, sir. So actually very minimal, sir. It was only 2 cases, sir.
Did you find any dual pathology like a granulomatous along with malignancy?
Yes, sir. One case. So we had one
in which
case
category
where,
did you label them?
I'm sorry, sir.
In which category then you labeled those cases?
Sir, earlier it was diagnosed as granulomatous lymphadenitis, sir, both on FNAC as well as on histopathology. So, but since there was a suspicion from the clinician side, we have gone further and we have done an IHC. There we came to know that it is a case of non-Hodgkin's lymphoma. So then we again went back, we had a relook of all the slides, and then we found that granulomatous lymphadenitis was associated with malignancy, sir.
So then you
so that is the only one
case?
case. I'm sorry, sir.
Any association of granuloma with metastatic lesion also?
Yes, sir. This is the only case where we had both granulomatous inflammation associated with non-Hodgkin's lymphoma.
You had a good amount of histopathological discordant cases. What could be the reason for that?
Sir, we had a very low number of histological controls available, sir. To say there were only 62 cases out of 250 cases. And
lymph node biopsies, the clinicians, they take out lymph nodes normally.
Yes, sir. Excision biopsy, sir.
Excision biopsy is quite common for lymph nodes. For other organs, they might leave it, but now for lymph nodes, fine. Okay. Thank you, Dr. Manjuri.
Thank you, sir.
Dr. Haren, anything?
No. Thank you.
Thank you, sir.
Moving forward, we have our next candidate, Dr. Malik.
Good morning, everyone. Hello. Good morning, judges and teachers. Good morning, respected teachers and judges. I, Dr. Umra Malik, Junior Resident, Department of Pathology, is presenting a paper on the topic of a clinical pathological study of VEGF expression, plasma fibrinogen, and D-dimer in breast carcinoma. Now coming on to the introduction. Breast cancer is the most frequent cancer among women, impacting 2.1 million each year. Hemostasis and angiogenesis both may be critical in the three interrelated features of tumor progression, that is growth, invasion, and metastasis. The aims and objectives of my study are to study and analyze the expression of VEGF in breast carcinoma, to study the role of D-dimer and the role of plasma fibrinogen in patients of breast carcinoma. Now coming on to the materials and methods, this prospective study was conducted on the diagnosed case of breast carcinoma presenting with breast lumps in Department of Pathology and Surgery. All these specimens were processed routinely and immunoexpression of VEGF was performed. Preoperative blood samples of the patients were evaluated for D-dimer and plasma fibrinogen. Now coming on to the evaluation of immunohistochemistry. The expression of VEGF was evaluated using the immunoreactive scores according to the staining intensity and percentage of positivity stained tumor cell. The staining intensity was graded as 0 for negative, 1 plus for weak, 2 plus for moderate, and 3 plus for strong. The percentage of positivity stained tumor cells was graded as 0 for negative and 1 plus for 1 to 50% of the positive cells and 2 plus for 51 to 100% of the positive cells. An immunoreactivity score of 0 to 2 was considered low and the score of 3 to 6 was considered high. Now coming on to the results. Levels of plasma D-dimer was raised in all the cases of breast carcinoma, with the maximum number of cases having the D-dimer level in the range of 0.5 to 1. The tumor size was correlated with the D-dimer level, and it was seen that in the T2 stages, 60% of the cases fall and mean D-dimer level was 1.3. It was also correlated with the lymph node involvement, and it was seen that in 74% of the cases, the lymph node involvement was present and mean D-dimer level was 1.4. Then histological grade was also correlated with the plasma D-dimer levels, and it was seen that in grade 3, that comprises of 34% of the cases, the mean D-dimer level was 2. Now coming on to the levels of plasma fibrinogen in patients of breast carcinoma, it was seen that 85% of the cases have the fibrinogen level of more than 4. It was correlated with the tumor size, and in the stage T4 comprises of 16% of the cases with the mean fibrinogen level of 7.1. Then it was also correlated with the lymph node involvement, and it was seen that 76% of the cases had lymph node involvement present and the mean fibrinogen level was 6.6. Histological grade was also correlated with plasma fibrinogen level, and 53% of the cases that lie in grade 2, they had the mean fibrinogen level of 5.8. Now coming on to the immunoexpression of vascular endothelial growth factor in relation to the grade of the tumor, it was seen that in the grade 1, the immunoreactivity score was low, and in the grade 2, it was low to high, and in grade 3, it was high. The immunoexpression was also correlated with the tumor size, and it was seen that in the T2 stage, the immunoreactivity score was low to high, and in the T3 and the T4 stage, it was high. It was also related to the lymph node status, and it was seen that in N1 and N0, N1 and N2 stage, the immunoreactivity score was low to high, and the N3 stage, it was high. Now coming on to the VEGF immunostaining. This is the H&E stain section, which is showing sheets of atypical cells having hyperchromatic nuclei and prominent nuclei along with lymphocytes that are evading the stroma. Here we can see weak VEGF intensity and giving it an immunoreactivity score of 2. This is another case where we can see sheets of atypical cells having hyperchromatic nuclei that is invading the stroma, and here we can see a strong intensity of staining, and it's covering more than 50% of the tumor cells, giving it an immunoreactivity score of 6. Now to summarize our study, it was seen that plasma D-dimer was raised in 100% of the cases and fibrinogen in 85% of the cases. Plasma D-dimer level showed an increasing trend with increase in grade of the tumor. D-dimer and fibrinogen level both correlated with lymph node involvement. High level of fibrinogen was found with increasing tumor size. VEGF was expressed in 100% of the cases with varying intensity, with immunoreactivity score low in grade 1 and high in grade 2 and 3, and low to high in T2 lesions and high in T3, T4 lesions, low to high in N0, N1 and N2 stage, and high in N3 level of lymph nodes. To conclude my study, we have found that plasma D-dimer and fibrinogen along with VEGF expression can be used as a diagnostic, prognostic, and a predictive marker in breast carcinomas. These are the references. Thank you.
Over to you, sir.
What made you choose these two markers like D-dimer and ferritin?
Fibrinogen, okay.
Yeah. D-dimer and fibrinogen you use.
So, because
what
they
made
are
you think about that?
So because they are easily available and they are in non-invasive methods for prognosis, and it's easy. So we can for prognostic thing I chosen them because they are easily available and non-invasive. So for a better prognostic and predictive biomarkers, we can select them. They are blood investigations.
Did you find any correlation of D-dimer along with the grade or metastatic lesions?
We found a correlation with the grade. It was increasing with the grade. In the grade 3, the levels were high. It was more than 2.
And what about the cases that showed metastasis to lymph nodes or anywhere else?
So there were no cases having mets to different organs, but yeah, lymph node was present. Lymph node involvement was present. And in the cases where lymph node involvement was present, both fibrinogen and D-dimer were raised.
Fine. Thank you, Dr. Bra.
Thank you, sir.
Other judges, please.
Any correlation with ER-PR and HER2 are done? Because if VEGF done, then ER-PR will also be done.
No, sir, I haven't done any correlation.
So it is used. No correlation was done.
No,
but definitely ER-PR HER2 will be definitely performed on those blocks, na?
Yes, sir. It was performed.
So you are labeled as. So they were independent predictive and prognostic markers.
Yes.
So no correlation with ER-PR or HER2 status.
Yes. Yes.
Okay. So you can do that in further studies. You can correlate with ER-PR and HER2, so they can have some association established and can be done. Okay. Thank you, doctor.
Thank you, sir.
No questions, sir. Thank you.
Thank you, sir.
Thank you, Dr. Umra. Our next candidate is Dr. Mona Singh.
Good morning, judges.
Good morning. Please continue.
A very warm good morning to all. Myself, Dr. Mona Singh from Gandhi Medical College, Bhopal. The title of my paper is Expression of S100 protein and CD1A marker in the lesions of leprosy. As very famously known, leprosy is also known as Kushta-roga, which is one of the most ancient described diseases that is known to man. It is a non-fatal chronic infectious disease that is caused by Microbacterium leprae, affecting the skin and the peripheral nervous system mostly. Clinical diagnosis of early leprosy lesions has, however, always been a challenge to the dermatologist, and therefore histopathology is considered as the gold standard of diagnosis. However, presently, immunohistochemistry is an upcoming ancillary technique to further accentuate the diagnosis, predict progression, detect early diagnostic indeterminate leprosy cases, as well as monitor the treatment of the patient. The macrophages from the lesions of the polar, subpolar, and the borderline lepromatous leprosy has seen to be showing the expression of S100 protein intensely and constantly. In contrast, the other spectrum, which is the polar, subpolar, tuberculoid leprosy, have very few cells that are immunoreactive to S100 protein. CD1A is a marker of Langerhans cells, which are the antigen-presenting cells in the skin and are responsible for mediating the cell-mediated immunity in case of leprosy, and therefore As the immunity of the patient towards the tuberculoid spectrum is better, it is seen to express towards the tuberculoid spectrum. The main objective of the study is to use the immunoreactivity for S100 protein and CD1A to determine the spectrum of the disease. Skin biopsies from 20 cases of clinically suspected leprosy were received in the Department of Pathology, Gandhi Medical College, Bhopal. Histopathological assessment was done based on morphology, and further IHC was performed using S100 and CD1A marker. Distribution of cases was as followed. 12 cases were of indeterminate leprosy, 2 were of borderline tuberculoid, and 3 each of lepromatous and tuberculoid leprosy. These are the images of the IHC markers that I got. And the first image here shows that there is a CD1A expression in case of tuberculoid leprosy showing diffuse linear epidermal positivity staining the Langerhans cells. Whereas this is the close high power view of the same image showing Langerhans cells in the epidermis of the skin. And this is a low power view of S100 positivity seen in case of lepromatous leprosy, giving both cytoplasmic as well as nuclear positivity. These two are the low power and high power image of a case of indeterminate leprosy. Here we see S100 expression focally seen there, and this is the high power view of the same. Therefore, predicting the future of this case, that if left untreated, it's most likely to progress towards the lepromatous spectrum of the disease. This is the table representing the distribution of the markers as they were expressed. In case of lepromatous leprosy, we found that 100% of the cases gave S100 positivity. In tuberculoid, 66.67% cases gave CD1A positivity and 33.33% cases gave dual positivity. In case of indeterminate leprosy, 33.33% cases were positive for S100, 25% for CD1A, and dual positivity was seen in 41.67% cases. In borderline tuberculoid, we saw equal, that is 50 and 50% positivity of CD1A as well as dual positivity. Overall positivity as concluded was S100 gave 40% cases gave S100 positivity, 35% cases gave CD1A, and 25% cases gave dual positivity. To conclude, as per the study, S100 expression was diffuse, strong, and constantly seen in case of lepromatous cases, whereas it was absent towards the tuberculoid side of the disease. CD1A expression was seen to be focal or diffusely positive in case of tuberculoid leprosy. However, it's possible that even in the case of tuberculoid leprosy, there may not be CD1A positivity seen as such. It completely depends upon how many Langerhans cells are recruited in the epidermis of the skin to express the cell-mediated immunity. Therefore, CD1A has lower sensitivity than S100 protein in determination of the spectrum. In cases of indeterminate leprosies, which are a very early lesion of leprosy and are difficult to be assessed morphologically on simple H&E staining, here it's seen that predominantly which marker is expressed, we can conclude or we can predict a prognosis of such a patient as to which spectrum will this person progress to if it's left unchecked. Thank you.
Dr. Muna, a good presentation.
Hello.
Yes, sir. Thank you, sir.
But I think 20 cases is quite a small number to conclude or arrive at a diagnosis. I prefer that you could have included some of the retrospective cases as well, because leprosy is fairly quite common that way.
Sir, actually, I did take cases from the past as well, but the thing is that since the skin biopsies are very small, the blocks had faded away actually, and they were not giving very good results on IHC as such. And second of that, because of the onset of COVID, the cases became very lesser actually. That's the reason why the sample size is a little bit small.
I agree to that. That's a comment basically. It's a good effort and all. But use of ISC in leprosy has not been much documented that way. Because of the immunological variations and so many other factors, use of ISC in an inflammatory condition is not very well documented. So have you taken up any of the references into consideration?
Sir, actually, I read several articles that have been conducted in the Middle East as well as UK and in Southeast Asian countries where leprosy is predominantly seen. And
That's
majority of the
But
studies, so majority of the studies actually gave very important conclusions, especially to S100 protein marker.
But not in India, right?
Sir, in India, there have been fewer studies. Most of
That's
the
the reason,
studies
because
have
in
been
Indian
from the outside.
pattern or Indian scenario, the immunological pattern and the reactions are very, very different. We label them as leprosy, agreed, but it's a very huge difference. And secondly, you have not correlated anything with your AFB strain, right? AFB for lepra, that I think you have not done.
Yes, sir. I have not performed that.
Okay. And one more question, just you have labeled one case as indeterminate leprosy, giving a positivity.
Yes, sir.
So what was your pathogenesis or your hypothesis related to that?
Sir, majority cases in the study, as we could see, was of indeterminate lesions. Such patients, sir, it's very difficult to actually label even on histopathology because there is no as such specific morphology that's seen. So in such cases, I conducted the study and I could see that S100 macrophages were positive, whereas at the same time CD1A labeling Langerhans cells were not there, wherein which is an indication that the cell-mediated immunity that should have been undergoing in this patient is highly less, and therefore non-functional macrophages were being expressed that were labeled as S100, and hence if left unchecked, such a patient can actually progress towards the lepromatous spectrum of the disease.
Lepromatous or the tuberculoid one?
So lepromatous, because S100 macrophages are being present,
S100.
whereas Langerhans cell positivity was absolutely zero, sir. So cell-mediated immunity is not up to the mark in this patient particularly.
Fine. Other judges, please.
Anupam sir will ask because he's a dermatopathologist.
Dr. please. So where do you take this S100 role of S100 in tuberculoid pole of leprosy and other granulomatous disease of skin? How what is the role of that?
Sir, if suppose on normal H&E stain, we have labeled a lesion as tuberculoid morphologically, and in such cases, we suppose we are receiving S100 positivity around the granulomas. As per several studies that have been conducted, that shows that such a patient is in the transition phase, and he is transiting from the tuberculoid towards the lepromatous spectrum.
You didn't get my question
perineural
here.
invasion.
Dr. Mona, my question is, how do you differentiate other granulomatous diseases of skin from tuberculoid leprosy in which there can be a granulomas? What is the role of S100? Whether it is useful in differentiating granulomas, other granulomas of skin disorders and tuberculoid leprosy? Because you say there is negative. आपके हिसाब से tuberculoid pole पे S100 positivity was not there.
Yes, sir.
Yeah, but
as
how
per
will you?
The study, sir, yes, yeah.
As per your study. As per your study, na? While there is a definite role of S100, you can get fragmented Schwann cells positivity. And that is the role of S100 in differentiating granulomatous disease and with tuberculoid pole. So you need to do S100. Role of S100 is definitely there, especially in cases of granulomatous disease and tuberculoid pole. So you see fragmented positivity, right?
Yes, sir.
So you cannot get negative results for there. There can be due to any other reasons. Your blocks may be old, some other reasons will
Yes,
can
sir.
be there.
Possible.
So there is a definite role of
Yes, sir.
S100 in diagnosing tuberculoid pole and differentiating with other granulomatous diseases, right?
Yes, sir. Yes, sir.
Okay.
Sir,
Thank you.
actually, yes, sir. Okay.
Yeah, tell me.
Thank you.
Check.
Sir, actually, as per as per the studies, why we did not consider Schwann cells was because, sir, because we were considering macrophages as the only
For
positive
S100.
markers in the study.
For S100.
Sir, basically, sir, to lineate the spectrum, we were considering only the macrophages positivity for S100 here. However, yes, it shows positivity for Schwann cells as well and for melanocytes also, which was there. Fragmented positivity was there towards the tuberculoid also, but we did not consider that into the study because we were concentrating as per leprosy. We were concentrating only on the role of macrophages, sir.
Okay, fine.
Yes, sir.
Thank you.
Thank you, sir.
Which other IHC you can use for the dermal dendrocytes?
Sir, for dermal
CD1A?
Yes, sir. For dermal dendrocytes, sir, we can also use HLA-DR, sir, CD68, neuraminidase, factor 13A also in certain studies that have been.
Factor 13, I think you can use.
Yeah, factor 13A, sir, specifically has been used.
13A.
Yeah, factor.
13A.
Yes, sir. For histoid leprosy, it has been used, sir, in several studies.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Mona. Next candidate is Dr. Garima Shukla.
Good morning, everyone. I'm Dr. Garima Shukla, and this is my title of paper presentation. Started with the introduction, gallbladder cancer represents 80 to 95% of biliary tract cancer worldwide. Gallbladder cancer develops over 5 to 15 years when metaplasia progresses to dysplasia, carcinoma in situ, and then invasive cancer. Gallbladder lesions of two types, non-neoplastic and neoplastic lesions. Lack of specific signs and symptoms lead to delay in diagnosis. The prognosis of gallbladder carcinoma is extremely poor when detected in advanced stage. Development of potential diagnostic and prognostic markers for the gallbladder disease will yield screening opportunities for those at risk and diagnosed cases of carcinoma gallbladder. During the past few decades, the RBB family of receptors have been recognized as crucial participants in the process of carcinogenesis and disease progression in different types of cancers. Several studies from other countries have demonstrated the expression of EGFR in gallbladder cancer. P53 tumor suppressor gene point mutation is one of the most characteristic single change in different type of cancers is seen. Role of both EGFR and P53 has been studied in connection with gallbladder carcinoma staging and prognosis. However, literature related with their usefulness is limited. Objective of the study are as follows. Material and methods, cross-sectional observational study done at Eras Lucknow Medical College and Hospital, Lucknow. Formalin fixed paraffin embedded non-neoplastic and neoplastic tissue samples were taken. Inclusion and exclusion criteria are as follows. EGFR and P53 expression was assessed by ISC staining using a horseradish peroxidase method. EGFR was considered positive when more than 10% tumor cells are stained with complete membranous staining of 3+ intensity. P53 is considered positive and more than 50% of tumor cells are stained for nuclear staining of 2+ and 3+ intensity. Result of the study, out of 50 specimens included a total of 25 were adenocarcinoma, while remaining 25 were obtained from non-neoplastic lesions. Non-neoplastic lesions comprises of 10 cases from chronic cholecystitis, 5 cases from chronic cholecystitis with metaplasia, 6 cases from chronic cholecystitis with hyperplasia, and 4 cases from chronic cholecystitis with dysplasia. Age of the study ranged from 25 to 68 years. Patient of more than 40 years of age was significantly higher in neoplastic as compared to non-neoplastic group. In neoplastic group, 88% were females and 12% were male. Female was significantly higher in neoplastic lesions as compared to that in non-neoplastic lesions. Histopathologically, all the neoplastic group patients were identified as adenocarcinoma. Most common adenocarcinoma type was pancreatobiliary, followed by rest of the cancers. A total of 3 cases could not be differentiated further. Histopathologically, majority, that is 18 cases were well differentiated as shown in figure A, while 3 cases were moderately differentiated as shown in figure B, and 4 cases were poorly differentiated as shown in figure C. Lymphovascular invasion as shown in figure D and perineural invasion as shown in figure E, seen in 4 cases each. A total of 10 cases showed tumor infiltrating lymphocytes as shown in figure D. Among associated lesions, chronic polycystitis, as shown in figure A, was the most common associated cancer, followed by metaplasia, as shown in figure B, and followed by dysplasia, as shown in figure D. There was one case with hyperplasia, as shown in figure C, is also seen. EGFR expression was seen in all the neoplastic lesions, as shown in figure B, as compared to only 15 cases out of 25 of non-neoplastic lesions. Among neoplastic lesions, a total of 8 cases each had 1+ and 2+ positivity expression, while 9 cases had 3+ positive expression. In non-neoplastic lesions, 9 cases had 1+, 2 cases had 2+, and only 4 cases had 3+ positivity expression. Statistically, there was a significant difference seen between two groups with respect to EGFR expression and its intensity. More than 10% of tumor membrane expression was seen in 64% of neoplastic lesions and 40% of non-neoplastic lesions. EGFR positivity was seen in 36% of neoplastic lesion as compared to only 12% of non-neoplastic lesions, showing significant difference with p-value of 0.0047. Prevalence of p53 positivity was significantly higher in moderately and poorly differentiated cancers as compared to well-differentiated lesions. Lymphovascular invasion also showed a significant association with p53 positivity with p-value of 0.002. Except for association of lower pathological stage PT1AB with EGFR positivity, neither EGFR nor p53 positivity showed a statistically significant association with different clinical pathological factors. Conclusion of the study: the present study compared 25 neoplastic lesions of gallbladder with 25 non-neoplastic gallbladder lesions for immunohistochemical expression of EGFR and p53. The present study showed that both p53 and EGFR have a differentiating role in discriminating neoplastic from non-neoplastic gallbladder lesions. As far as the role in characterizing the gallbladder cancer is concerned, the present study had the limitation of sample size, and hence the number of correlation could not be established. Further studies and larger sample size are recommended to evaluate the role of these immunostains with respect to these characteristics. Thank you so much. This is all from my side. Thank you.
What was the study duration of your case presentations and everything?
Good morning, sir. So study duration was 6 months. I started from the January, and due to COVID stopped for the 2 months, and again I started. This is an intramural study. This is not the thesis.
Agreed. So 50 cases in 6 months.
Yes, sir. So started from the January, because this in our center we get gallbladder very common specimen in our center.
Yeah, but 25 malignancies in 6 months is very high number.
Often
50 cases in 6 months.
Yes, sir.
50,
but
right?
Out of the 25 were malignant and 25 were non-malignant, right?
Yes, sir. 25 were non-malignant. In that, A calculus.
So that those 25 you could have taken. Those 25 you could have taken as control, or this is the total number of cases.
These are the total number of cases. 50 is total number of cases, out of which 25 was non-neoplastic and 25 was neoplastic.
So it's not a chance finding that equal number is there.
No. Yeah, in with 6 months, only 20 out of 50 gallbladders, 25 malignant, and only 25 non-malignant is a very like data is little to be aside.
I have taken that only.
No, we are not saying that you have done anything wrong. Basically, what our apprehension is, 50% cases of gallbladder turning out into malignant lesion is very unheard of.
Even this high incidence of malignancy in this North India belt between the Ganga and Yamuna, this belt has the highest prevalence in India of gallbladder malignancies, but it is not that high that it will turn out to be 50% of cases of
Is
total
it a
whatever you
referral
receive.
center that way?
Like,
Yes, sir. So defined cases was there, no? So it.
Maybe referral center, but referral for only malignant. It's oncology center.
That's quite
oncosurgery setup or routine surgery. It's a oncosurgery department we have taken cases from, or it's a surgery department?
This is the inter-collaboration
general surgery department. These
study.
registrations were operated.
Yes, sir.
No, you received. I mean, you received in your department received specimens from the oncosurgery or the general surgery department.
So both.
And what were these non-malignant cases?
Chronic cholecystitis. So chronic cholecystitis is metaplasia and chronic acalculous cholecystitis and chronic cholecystitis.
Incidence that way is too high that way. Too high that way. Chalo. My next question is.
There were more cases of chronic cholecystitis, but I have taken only 25%.
Okay. My next question is are you there, Dr. Garima?
Yes, sir.
You have labeled EGFR in 15 cases of your 25 cases in the non-neoplastic category.
Yes, sir.
That too in non-neoplastic, you have said that these EGFR is positive, right?
I have seen in my
that
study.
Rate again is very high. Chalo. Other reviewers, please. Other judges.
No, please. It's all done. It's all done. I suppose there is some data.
Some calculation error.
Calculation error is there. I suppose.
You missed out on
I'll
something.
find out because this is a transmittal study. And
no, I agreed. You missed out on something.
Okay,
Either the
so surely
you probably selected only those 50 in which you were interested that way, or in which you applied markers and all. The number of cases must definitely be high or low. No issue. You go back and you recheck them. Okay.
You have
mentioned
some hyperplastic. Okay.
Sorry, sir. Can you please repeat it? Yes, sir.
I wanted to tell that you have mentioned that plasia was associated with one of your cases. How many metaplasia? Maybe the dysplasia might have been.
Voice is cracking, Dr. Harin.
So I'm not getting it clearly. So voice is not clear.
So your voice is not very clear.
Or the metaplastic change.
You can type in the chat box, I think, that way.
Okay, this may be. No, I think it's okay.
Voice break is there.
We can go to next case. No problem.
Thank you, sir.
No problem. Thank you.
Thank you, Dr. Garima. Moving on, our next candidate is Dr. Arif Khan.
Good morning, respected judges and other participants. Good afternoon, all. I am Dr. Arif Khan from Pulmonary Medicine Department. Title of my paper presentation is Study of Relationship between Blood Group Susceptibility and Severity of COVID-19 Infection. Coming to background, the novel coronavirus disease COVID-19 caused by SARS-CoV-2 has spread rapidly across the globe. It has been reported that a variety of indicators can predict the progression of COVID-19 disease. Biological factors that determine susceptibility to SARS-CoV-2 and severity of COVID-19 are yet to be fully understood. The ABO blood grouping may influence the susceptibility of COVID-19 and the severity of the disease. The study aimed to establish a relationship of the blood groups to susceptibility and severity of COVID-19 disease. The objectives of my study are to enroll RT-PCR confirmed cases, to find out the blood groups of RT-PCR confirmed cases, to assess severity of COVID-19, to find out a relationship of blood groups to susceptibility and severity of COVID-19 disease. Now the materials and methods It is an observational study conducted on 155 RT-PCR confirmed patients from Teerthanker Mahaveer Medical College and Research Center, Muradabad from March to April 2021. Patients' demographic details, admission details and blood groups were collected. Patients without confirmatory RT-PCR test or pregnant females were excluded from the study. Blood grouping was determined using forward and reverse blood grouping method. Severity of COVID-19 was assessed. Statistical analysis was done using SPSS software version 24. Comparison between the groups was analyzed using chi-square test and the level of significance was set at less than 0.05. Coming to the results, most common blood group found to be affected by COVID-19 is A positive. B positive is the second most common blood group found to be affected by COVID-19. Most common blood group in India is O positive, which is the least common affected blood group by COVID-19. The study shows a relationship between ABO blood groups and COVID-19 susceptibility and severity. This bar chart depicts the relationship between the blood groups and COVID-19 susceptibility and severity. Here, red bar indicates A positive blood group, which is most susceptible to COVID-19, followed by B positive, which is shown by green bar. This slide shows tabular form of result of the study. A positive blood group is the most susceptible to COVID-19, having highest percentage than other blood groups, which is 41.2% in asymptomatic and mild cases, 33.3% in moderate cases, and 29.0% in severe cases. Now, the discussion. A number of risk factors for COVID-19 infection, morbidity, and mortality are known, including age, sex, and a number of comorbidities and laboratory findings. The ABO blood grouping may influence the susceptibility of COVID-19 and severity of the disease. There are 34 recognized human blood groups and hundreds of individual blood group antigens and alleles. The variation in blood group system leads to variation in host susceptibility to many infections. Laguico found that in people with O blood group, anti-A antibodies inhibit binding of glycosylated SARS-CoV-2 protein expressing cells to angiotensin converting enzyme 2 on cell surface. So these antibodies may block the interaction between the virus and its receptors, thereby providing protection. Gullian et al. Argued that either a monoclonal anti-A antibody or natural plasma anti-A antibody in blood group O specifically inhibited the SARS-CoV-2 protein or ACE2 dependent addition to ACE2 expressing cell lines, substantially reducing SARS-CoV transmission. Severe outcomes could also be explained by higher level of von Willebrand factor and factor VIII in group A individuals. Von Willebrand factor is an acute phase reactant with infection inducing even higher levels in group A individuals. Now, the conclusion. In this study, increased incidence, severity of COVID-19 infection is seen among non-O blood types. People with blood group A have a higher susceptibility and severity, whereas people with blood group O have a lower one. Consistent with the previous observations, we have also found that blood group O has least risk. The application of these relationships in clinics should be explored in future studies. These are the references. Thank you.
Over to the judges.
Did you find any correlation with any other factor of COVID positivity?
Sir,
any
in my
race, any gender, any other thing?
No, sir. I have taken a blood group only for comparison, for rule out the susceptibility.
And you chose only RT-PCR positivity, not antigen or any other method?
No, sir.
155 cases in 1 month approximately, right?
Yes, sir.
Okay. Because there has been a lot of variation in the blood groupings pattern and COVID Few studies they say A, somebody says O, some say even a negative blood group, they are more common. So there have been varying studies.
Yes, sir. So many studies are there, but most of the studies are which I have read, they are showing result to blood group A. I read one study in that blood group B was most common.
Then what is your theory that people with O blood group, they are also infected? What could be the reason? Anything you could specify or?
Sir, it is the least common blood group, and some theories have been postulated. Like one theory is there that receptor binding domain of coronavirus is known to bind blood group antigens, and in O blood group, it is least susceptible, sir, least likely to be bind to the cell linings which are affected the most, like respiratory epithelium. Yes, sir. Good morning, sir.
Yeah, good morning. Dear, what were the total number of cases out of 155? How many of were blood group O? How many A? How many B?
Sir, I have taken the cases, sir, but currently I don't remember the numbers. It is in percentage, sir.
Approximate O and non-O. You can take it as O and non-O. How many of O blood group and how many of non-O blood group?
Sir, overall, O positive was 18%, and the overall.
Rest one non-O.
Yes, sir.
Almost 80 and 20 ratio was there.
Yes, sir.
So what are the percentage of other blood groups? A, B?
A, B were rest, sir. Around 80% included A and B in respective RH negativity and positivity, sir.
Thank you.
Thank you, sir.
Thank you. I think we can go for next. Yes.
Okay,
next
sir.
speaker.
Next candidate is Dr. Faiza Samin.
Thank you all.
Thank you.
Good morning, everyone. I am Dr. Faiza Samin, and I'd like to present my paper on the topic immunohistochemical expression of E-cadherin and vimentin in oral squamous cell carcinoma and the correlation with lymph node metastasis. I'll start with the introduction. Head and neck malignancy account for approximately 9 lakh cases worldwide and more than 4 lakh deaths annually. Squamous cell carcinoma is the most common cancer of oral cavity. Epithelial to mesenchymal transition has been implicated in local invasiveness and metastatic potential of epithelial cancers, and it refers to loss of epithelial morphology and acquisition of mesenchymal features by tumor cells. During epithelial mesenchymal transition, tumor cells show downregulation of adhesion molecules and upregulation of mesenchymal marker. So this study is conducted to evaluate if E-cadherin and vimentin can be used as molecular biomarker of invasion and metastasis in oral squamous cell carcinoma, which is a major cause of cancer morbidity and mortality in India. Our objective is to compare the study expression of E-cadherin and vimentin in oral squamous cell carcinoma and to compare the expression of E-cadherin and vimentin in different histological grades and to compare the expression of E-cadherin vimentin in cases of with and without lymph node metastasis. Cases having radiological and cytological features of lymph node metastasis were taken as positive nodal status. 6 benign lesions of oral mucosa was taken as control. Section of 4 micrometer was taken from all 28 cases and subjected to H&E staining and categorized into well-differentiated, moderately differentiated, poorly differentiated squamous cell carcinoma. Immunohistochemical staining with E-cadherin and vimentin was done. Evaluation of immunoreactivity was done. Immunoreactivity score was calculated by intensity score into proportion score. Intensity score 0, negative, 1 weak, 2 moderate, and 3 strong. Proportion score 0, negative, 1 less than 10%, 2 10 to 50%, 3 50% to 80%, and 4 more than 80%. Total score ranged from 0 to 12. Final score 0, negative, 1 to 4 low, and more than 4, 5 to 12 was considered high immunoreactivity. The correlation between expression of E-cadherin and vimentin with different grades of oral squamous cell carcinoma and nodal status was analyzed by chi-square test and independent t-test. P-value of less than 0.05 was considered statistically significant. Total 28 cases of oral squamous cell carcinoma was taken, of which 17 with lymph node metastasis, 19 well differentiated, 8 moderately differentiated, and 1 poorly differentiated. Majority of them were male with mean age of 54.7 years. Tongue was most common site involved, followed by buccal mucosa. Out of 6 benign cases, 100% showed high immunoreactivity with E-cadherin, and vimentin expression was absent in all of them. Out of 19 well differentiated, 12 showed high immunoreactivity and 7 showed low immunoreactivity with E-cadherin. Vimentin expression was seen low in 9 and high in 9 cases. P-value came out to be significant in cases of E-cadherin, but it was insignificant in cases of vimentin. Out of 17 cases with nodal metastasis, 12 showed low immunoreactivity and 5 showed high immunoreactivity with E-cadherin. It was just opposite in cases of vimentin. 5 showed low immunoreactivity and 12 showed high immunoreactivity. So p-value was just significant in cases of E-cadherin and vimentin with or without nodal metastasis. In benign oral mucosa, E-cadherin immunoreactivity score was high, but in vimentin it was negative. In well-differentiated squamous cell carcinoma without lymph node metastasis, E-cadherin immunoreactivity score was high and vimentin score was low. In well-differentiated squamous cell carcinoma with lymph node metastasis, E-cadherin expression was low, but vimentin was high. In cases of moderately differentiated squamous cell carcinoma with lymph node metastasis, E-cadherin came to be negative and vimentin score was high. Downregulation of E-cadherin and upregulation of vimentin is turning point in tumor progression, invasion, and metastasis. In our study, E-cadherin came to be significant, but vimentin was insignificant. Liu et al. Conducted study in which E-cadherin and vimentin both were significant in different grades of oral squamous cell carcinoma. Akhtar et al. Conducted study in which E-cadherin and vimentin both came to be significant. Comparison of E-cadherin and vimentin immunoreactivity in oral squamous cell carcinoma cases with and without nodal metastasis in different studies. And in our study, it was just significant in cases of E-cadherin and vimentin. In niche camp study also, it came to be significant in E-cadherin and vimentin. Liu et al., it was insignificant, and Balsundaram also, it was insignificant. Downregulation of E-cadherin expression and aberrant vimentin expression may be associated with poor histological differentiation and regional metastasis. Hence, E-cadherin and vimentin can serve as useful prognostic marker. Therefore, we emphasize the need of further studies with large sample size. These are my references. Thank you.
Thank you, Dr. Feza.
Good morning,
what was
sir.
the control that you used for your study, especially in the 6 cases?
So 6 benign oral mucosa cases. So it was a keratosis case and lichen planus.
Are you sure there was no dysplasia or malignant counterpart in them?
Yes, sir. Dysplasia was present.
Still, then, would you like to use them as a control?
Sir, because in benign cases, it has been already established that E-cadherin was high and vimentin is negative. So I have taken these benign cases so that I can compare that IHC is working or not. For that, I have taken these benign cases.
And this scoring system was your own, or you have taken it from somewhere?
Sir, I have taken it from Balsundaram study in 2016.
He has carried out his study in Sir E. Catherine Bimantine and beta-catenin. He used
Because
this.
last year also in 1920 also there have been many studies which have been using different categories with slight modifications. That's the reason why I asked.
Sir, I have taken this from Balsundram studies. He has taken sir, immunoreactivity score by calculating intensity score into proportion score. Like proportion
Any
was
correlation? Any correlation with your lymph node status?
Yes, sir. It was just significant in both of the cases. That's why we need to do the study in large scale so that we might get this study significant.
Fine. Other judges, please.
Dr. Faiza, any exclusion criteria have taken in your study? Like recurrent cases or post-chemotherapy, radiotherapy cases? Have you taken those cases also, or they were excluded in your study?
No, sir, I haven't excluded them. So I have taken the medical records, scene of medical records, and those cases with positive lymph node status were taken, with radiological and cytological positive cases were taken. So,
any of your cases have a recurrence?
Sir, I haven't
any recurrent
followed
lesion you have taken? Any recurrent lesion you have taken?
Sir, I haven't followed up these cases, so.
You didn't get my question, dear. Were any of your case have a recurrent SCC?
No, sir.
Or they were primary SCCs? All were of primary SCCs. None of them were recurrent.
She is not getting your question properly.
Yeah.
So, we didn't take any such criteria.
You have not taken, and no exclusion or inclusion criteria was there. All
Yes,
the cases which came to you, you have taken them.
Yes, sir.
Okay, no exclusion criteria. There is a definite, before doing a study, there is definite inclusion and exclusion criteria.
Especially for head and neck cancers.
You need to get them through.
Okay, sir.
No issues. Check. Dr.
Harin, anything?
No, sir.
So the final one, Dr. Shikha.
Yes, sir. The last candidate is Dr. Shikha Agarwal.
Yes, ma'am.
Good morning, everyone. Myself, Dr. Shikha Agarwal, is presenting paper on topic scrape cytology in ovarian mass lesion and observational study in 37 cases. Introduction. Scrape cytology technique is useful for rapid intraoperative diagnosis of ovarian mass lesion and as an adjunct to frozen section examination. Intraoperative evaluation of suspected neoplastic lesion is becoming an essential tool in deciding further management of patient by giving a rapid diagnosis and preventing unnecessary radical surgery. Ovarian tumors are classified on the basis of their characteristic microscopic finding on histopathology. The present study has been designed to evaluate the role of scrape cytology in variety of ovarian mass lesion. My objectives are to study the cytomorphology of all types of ovarian mass lesion which were being sent to our hospital and to evaluate the role of scrape cytology technique in correctly diagnosing ovarian lesion, taking histopathological diagnosis as gold standard. Material and methods. We conducted a prospective observational study on 37 cases of ovarian lesion over a period of 1 year. Smears were prepared by scraping the representative surface of ovarian mass. The smears were stained with HNE, PAP, and Mg Giemsa stain and were examined. The cytological diagnosis was compared with histopathological diagnosis, taking later as gold standard. Based on the data sensitivity, specificity, positive predictive value, negative predictive value, and diagnostic accuracy were determined. The result. The mean age of patient who participated in the study was 35.32 plus minus 15.7 years. The chief complaint was abdominal mass followed by abdominal pain. Majority of the lesions were solid 60 in 43.2% of cases. The epithelial tumor were 64%, germ cell tumor were 21.6%, 6-cord tumor were 10.8%, and a case of stromal edema was also there. Sensitivity was 95%, specificity was 100%, positive predictive value was 100%, negative predictive value was 87.05%, and accuracy was 96.3%. This is a graph showing age relation with various tumors. This is a pie chart showing the chief abdominal complaint of chief abdominal mass 57%, abdominal pain 23%, followed by premenstrual bleeding 11% of cases. This is a distribution of cases. Total 37 cases were taken. Among them, 23 were epithelial, GCT were 8, sex cord tumor were 4, and others were 1. This is distribution of cases on the basis of histopathology. This picture shows on the left is a scrape cytology, on the right is of histopathology. On scrape cytology, we can see the monomorphic sheet of cells in serous cystadenoma. In mucinous cystadenoma, we can see the sheet of columnar cells with mucin on apex. In dermoid cyst, we can see the hair follicle and anucleated squamous. In dysgerminoma, we see the cells with prominent nucleoli and the presence of lymphocyte in between them. In fibroma, we can see the mesenchymal fragment showing spindle cells. This is a picture of serous cyst adenocarcinoma and mucinous cyst adenocarcinoma, and the accuracy was 89.6%. This is a borderline mucinous cyst adenoma. A pitfall in this, we see high cellularity with scattered and clusters of mucin secreting cell, and there was cellular overlapping in scrape cytology. This is a case of massive ovarian edema in which we see paucicellular smear with sparse ovate spindle nuclei. Discussion. Many previous studies have compared the diagnostic accuracy of scrape cytology and frozen section with his final histopathological diagnosis. The benefit of intraoperative diagnosis by cytomorphology over frozen section have also been described. Scrape cytology are less time consuming, inexpensive, and lack freezing artifacts. In addition, adipose and necrotic tissue are easier to examine on scrape cytology as these are difficult to embed in frozen section. Cytology of ovarian neoplasm is difficult to interpret alone, hence require extensive study of cytomorphological pattern. The diagnosis which is frequently missed is of mucinous adenocarcinoma, as it has been mainly due to the sampling error, that is due to the multiplicity of heterogeneous areas, especially in mucinous tumor, due to the fact these are large in size. Hence, multiple smears from heterogeneous areas on gross should be sampled. Various studies have been compared, and in this study, 96.3% of cases were diagnosed correctly on frozen section. Conclusion, the diagnostic utility of scrape cytology is excellent for rapid diagnosis of malignant lesion. It is a simple, rapid, accurate, inexpensive, and useful technique, especially in resource-limited setting. Scrape cytology of ovarian lesion can give quick and reliable diagnosis, proper training of cytopathology, and more of research is needed in this field. Thank you.
Thanks, Dr. Shikha. A nice presentation. For scrape, how did you take it? Per-operatively or in the department?
So in the department.
So they were not fixed in formalin?
Yes, sir, they were fixed. Immediately after the sample were received, they were scraped and they were fixed.
Other judges, please.
Hello, Dr. Shikha.
Yes, sir.
Did you use this for reporting also? Routine reporting was done?
No, sir. This was only an observational study. It is just to look the sensitivity of the test, and we compared our study with histopathology, and the accuracy was 96.3%.
Did you compare it with the frozen section also?
No, sir. Only histopathology.
Only histopathology you correlated. So what is your hypothesis? What is your recommendation?
Sir,
do you recommend this scrape cytology to be used as a adjunct or a diagnostic modality?
As scrape cytology is very less time consuming and inexpensive procedure, especially in the limited resource limited area. So we have to just train our eyes and we can
so it can replace frozen section. So it can replace frozen section.
So it can act as an adjunct to frozen section.
So what was the TAT in scrape cytology?
So it is it requires less time and limited resources. We just have to train up.
Because it does not require a fixed specimen, na? for scraping and for frozen, you need fresh specimens.
Yes.
You need not to get fixed specimens and need to have a good TAT. Then only it can replace or it can be used as an adjunct to frozen section, right?
Okay, sir.
But how will you differentiate between borderline cases of mucinous cyst adenocarcinoma and malignant cyst adenocarcinoma?
Sir, there's invasion on scrape cytology. Borderline are always very dicey, but on the basis of invasion, we can judge.
So how will you decide that invasion on cytology? A borderline case and a malignant one. Did you give your in your borderline cases, 2 of your cases were borderline, and you have given as on cytology?
Sir, in all the cases, CA 125 was elevated.
So your study says CA 125 was also taken in your study, correlated with that.
Sir, I have just seen the pattern that CA 125 was elevated.
So it can decide what is the difference between borderline and malignant. Is there any cutoff to limit that के इतना value है तो malignant है उतना है तो borderline है for CA 125?
Sir, less than 5 millimeter in its greater dimension. Stromal invasion of less than 5 millimeter.
In cytology, how will you decide invasion? Chali, koi nahi. Okay, Dr. Shikha. Nice presentation. Thank you.
Prepare this question. We'll ask you during your MD exam.
So examiner आप जा रहे हैं?
That is not to be disclosed, sir.
Okay, thank you.
Okay, thank you, Dr. Shikha.
Thank you, sir.
With this, we come to the end of oral paper presentation session. I would like to extend my gratitude to our esteemed judges by felicitating them through e-certificate.
Thank you, Dr. Rashmi.
Thanks, team.
Thank you, sir.
Thank you for giving us this opportunity.
Thank you, Dr. Seema, Dr. Rashmi, Dr. Ashutosh.
And the entire team.
Entire team, no doubt.
Thank you.
Thank you, dear.
We'll continue with our poster presentation session. For this session, we again have 10 candidates who were chosen after screening of over 100 posters that were presented yesterday. For this session, our judges are Dr. Kachnar Verma, Professor, MLN Medical College, Prayagraj, Dr. Nitesh Mohan, Professor, Rohilkhand Medical College and Hospital, and Dr. Ramnamal Rao, Professor, SGPGI, Lucknow. I welcome you all.
Good morning, everybody. At the outset, I would like to thank Dr. Seema, Dr. Ashutosh, and the organizing team for inviting me here to be judged for this session. Good morning, Dr. R.N. Rao, sir, Dr. Anupam, sir, and all others who are present here.
Okay. Shall I start, sir?
We can wait for Dr. Kachnar to come. She is here.
Sir, she'll be joining in 5 minutes. She has told us to begin the session, if it is okay with all of you.
Okay, Rao, sir, can we start, sir? Sir, you have to unmute your this one.
Yes, we can start.
Thank you, sir.
Yes.
Thank you.
Sir, Kachnar ma'am is there. Kachnar ma'am, can you hear me? Ma'am, are you there, ma'am? Sir, we'll be starting with our presentations. Before that, I'd like to request the judges that candidate number 5, Dr. Anju Shukla, she'll be presenting at first number due to some urgent circumstances, if it is okay with you.
Yeah, no problem with me. Yeah.
Candidate number 5, Dr. Anju Shukla.
Okay. Go ahead.
Good morning. Title of my paper is Cytomegalovirus colitis in a patient with COVID-19. This is my poster. As we know, COVID-19 caused by SARS-CoV-2 virus, a pandemic disease, and only 5% patient of COVID-19 with various risk factors develop ARDS, septic shock, multi-organ failure, resulting in high mortality. This case is of CMV colitis in a patient with COVID-19 with waxing and waning viral status. 68-year-old male presented with cough, cold, fever, and breathlessness for 10 days. As a protocol for admission, COVID-19 RT-PCR was performed, which came out positive. Thus, patient was shifted to the COVID ward. And on examination, his vitals were stable, PO2 maintained, and bilateral chest clear. But inflammatory parameter IL-6, CRP, D-dimer, LDH, and ferritin were deranged. He was treated as per COVID protocol, and after 15 days, his COVID PCR report came negative, and patient was discharged. But after 12 days, that is 27th day of illness, patient had rectal bleeding, and repeat PCR came positive. Colonoscopy revealed edematous fibril mucosa with interspersed pale yellowish area, hemorrhagic erosion and linear ulceration suggested of ischemic colitis. But the histopathology revealed cytomegalic cells and characteristic basophilic intranuclear inclusions, that is Cowdrey body. Even the RT-PCR for CMV DNA on tissue came positive. Inflammatory parameters started rising again. Patient was put on ganciclovir with other conservative management for COVID and responded well and discharged after 10 days with negative PCR report. As we know, latent CMV is carried by 70 to 90% of adult population, and inflammation and especially COVID-19 may lead to reactivation of CMV infection. Immune dysregulation triggered by IL-6 release, profound lymphopenia, use of IL-6 monoclonal antibody, and immunosuppressive therapy are the causes for CMV reactivation. Overt CMV infection complicated COVID-19, rarely reported in the literature, and only handful report of CMV colitis with COVID-19 reported so far. But my purpose of presenting this case in this poster session is to raise the question as how many COVID-19 patients with latent CMV to complicate their mortality rate. Again, the need for prospective study to assess superinfection of CMV in the setting of IL-6 inhibitor. COVID-19 and CMV should be interpreted with reference to the immune system. Thank you.
Dr. Anju?
Yes, sir.
I must say you presented the case well and you covered most of the points related with CMV. Can you tell me what is CMV tropism, which tissues?
CMV generally pulmonary tissue and the gastrointestinal tract tissue.
Generally, yeah. And in your case, what is the most plausible?
Rectal bleeding and the rectal. It was a GIT.
Okay. And in COVID positive, okay, your case is of a COVID positive, this one.
Yeah.
Generally, how does it present if it is not a COVID positive patient, CMV?
Generally, CMV can present as a bleeding or ulceration, like in the colonoscopy finding, they generally resemble that of ischemic colitis. And
in those cases,
what?
Okay, in those cases, what might be the plausible causes?
Generally, it is the immune dysregulation everywhere. Generally, it is seen in older patients, and the profound lymphopenia may be the cause of CMV reactivation. And we can see, especially in our hospital ICU setting, around many patients, like 10% of ICU patients, they develop CMV infections. Because all this waning immune response flourish the latent CMV infection.
Yeah, so what is happening in COVID is that the immune response is going down, and that is why the latent CMV is coming.
Basically, sir, whether it is a hen or it is an egg, whether the CMV is the cause of this immune dysregulation, because in the CMV, as we know, all the T cells, they are busy in keeping the CMV at the bay. So at the cost of, and the naive T cell pool decreases. So it makes it difficult the older CMV positive individual to generate an adequate immune response to combat new infection like SARS-CoV-2, or vice versa, that SARS-CoV-2, because of profound lymphopenia and profound why I presented this poster session, whether it is the egg or it is a hen or it's an egg, which causes.
Okay, so what are the investigations you can do for confirming CMV?
CMV actually, as a protocol in our hospital, every biopsy when we suspect like massive ulceration, erosion, and things, so we perform this CMV testing in house, CMV PCR testing. So it is the or we can do the immunohistochemistry on the tissue section.
You can go for any serological tests.
Yeah, we did not perform any serological test in this case because on the PCR the CMV came positive. That is why. Otherwise, we can retrospectively. Actually, in the latent CMV infection, generally IgG came positive. As we know, the 70 to 90% of adult population or requiring ICU, they generally have the CMV infection. So the IgG generally came positive in those patients.
Ramnaval, sir.
Yes. Are you confirmed these cases by the ISC, the nicomegaly?
Yes, ISC not. We generally perform the PCR on the tissue section. We take the biopsy separate for the PCR testing.
So you have not done the ISC in this case?
No, we have not done ISC, but the characteristic inclusion bodies were visible on the tissue
confirmed by the biopsy.
Yeah.
ISC.
No, no, we did not confirm.
Okay, thank you.
Welcome, Dr. Kashnar. You need to unmute, please. You need to unmute. Kashnar ma'am, you need to unmute.
I said I must apologize for being a little late. Actually, I was not earlier knowing this. But anyway, it's a pleasure joining you all. And I think we can continue. Dr. Ramnaval, sir, hello.
Yes, thank you. Hello. Good morning.
Good morning to everyone. Okay.
So do you want to ask any questions?
Actually, I missed the presentation. If Dr. Anju could just summarize your presentation, because you have presented quite well. You could just summarize, give me the summary of the presentation, because I didn't listen to the initial part. Dr. Anju, yes?
Yeah. It was a patient, he came with a breathlessness fever, and as a routine protocol for the admission, that was the time of COVID. So as a protocol for the admission, his RT-PCR was performed, which came positive. The patient was shifted to the COVID ward. All the inflammatory parameters of the patient were deranged, and he was treated as per the COVID protocol and discharged well after 15 days with negative RT-PCR report. But 12th day after the illness, that is 27th day, he had a rectal bleeding. Colonoscopy performed, suggestive of ischemic colitis. Again, RT-PCR came positive. Inflammatory parameter again started rising, and on the tissue, it came out to be the CMV colitis.
Okay. Were there any other changes, Dr. Anju, on your endoscopy? Were there some changes of, let's say, IBD or something? Like we can totally say.
No, it was just a massive erosion, ulceration, linear ulceration. It was a very bad looking mucosa.
Okay.
Or only one episode of rectal bleeding was
Any
there.
evidence of chronicity? No, nothing. The Krebs.
No evidence of chronicity. Yeah.
No, it was acute colitis with superimposed. Yeah. That's you would say. Okay.
Yes, acute colitis with the characteristic changes in this stromal cell and the endothelial cell.
Right. So, what is the literature search? What does it say? It was the immunocompromised.
They say like in the COVID with the CMV colitis with COVID is rarely reported in the literature so far. Right. Only in the Times of India report, one report says 5 cases of reported from the Gangaram hospital, but this is the Times of India report. Only few cases of acute hemorrhagic colitis reported from one from Italy, and other 2-3 reports, they say CMV colitis because of the use of IL-6 inhibitor.
Okay. IL-6 inhibitors. Okay.
Yeah.
So used in this patient?
No, it was not used in this patient.
Because I think we cannot totally conclude that the CMV infection was secondary to COVID, right? It could be some other immunocompromised status. I think that if the history, but anyway, interesting case. I think we can go to the next.
Actually, whatever cases are coming up, they are related to drug-induced CMV, which has come post-COVID. Most of the cases that have come up. So here in this case, I didn't see any.
Waxing and waning type of COVID PCR status. First, the COVID PCR came negative, then COVID PCR came positive.
That happens most of the time.
That happens. That has nothing to
that
do
happens
with
also.
That doesn't has to do anything, I guess, with the.
As far as the manifestation of CMV is concerned, most of the cases that are reported in literature are post drug therapy in COVID cases.
Yeah.
So in your case, it is not there. Maybe that leaves a question. Okay, so Ranaval sir, can we move on? Or?
Okay, no, go ahead. Next.
Sir. Thank you, Dr. Anju.
Thank you.
Now we'll be having our presentations in sequence, starting from number 1 candidate. But before that, I'd like to request all the candidates to please switch on their video while answering the questions of the judges. First candidate is Dr. Silky Rai.
A very good morning to all the teachers. A very good morning to all. I, Silky Rai, third year pathology resident from ERA's Lucknow Medical College and Hospital, would like to do my poster presentation under the guidance of Dr. Nirupma Lal ma'am. I am going to present a rare case report with the title 45-year-old female from Indo-Gangetic Basin with adenosquamous carcinoma of the gallbladder. Starting with the case, adenosquamous variant of gallbladder carcinoma is a rare malignancy characterized by presence of squamous elements constituting a substantial part of the tumor, that is more than 25%. So, I herein describe a meaningful case diagnosed as gallbladder adenosquamous carcinoma, a rare histology type. The case details of the patient are: she was a 45-year-old woman from Indo-Gangetic Basin, admitted in general surgery department with a short history of pain and a palpable lump in the right hypochondrium. All the routine investigations were within normal limit. However, ultrasonography and CT scan revealed a circumferential wall thickening in the neck and proximal body of gallbladder, along with sludge of tiny calculi within, causing dilatation of distal body and fundus. Her clinical diagnosis of cholelithiasis was made, for which the patient underwent cholecystectomy. Intraoperatively, gallbladder mucocele was found, and the resected specimen was sent for histopathological examination to our department's laboratory. Grossly, the gallbladder had an area of grey white, solid, localized wall thickening alternating with cheesy necrotic areas extending from neck to proximal body and measuring up to 5 into 3.5 into 2.8 centimeters. Also, brownish fluid was noted in the lumen. Microscopically, the gallbladder showed invasive squamous cell carcinoma component with beautiful keratin fold formation constituting 65% of the tumor, along with glandular type invasive component. Also, areas of necrosis and atrophic mucosa in the fundus was noted. The histomorphological diagnosis was consistent with invasive, well-differentiated adenosquamous carcinoma of gallbladder invading the perimuscular connective tissue on the peritoneal side without involvement of the serosa. The patient was given a pathological TNM of PT2A, N not applicable, M not applicable. Lymphovascular invasion was also identified with background gallbladder having chronic cholecystitis. Now coming on to the discussion, gallbladder cancers are more frequent in women with more than 50% of cases being diagnosed incidentally at a late stage. Also, proximity to river Ganga and cholelithiasis are potential risk factors. Even the present case was also clinically diagnosed as cholelithiasis, for which cholecystectomy was successfully performed. However, histopathologically, a highly rare and aggressive variant of gallbladder cancer was reported, making adenosquamous variant a completely incidental and unusual finding. Hence, I would like to conclude that this exceedingly rare case highlights the challenges which teamwork of pathologists and surgeons face, especially in almost an acute setting like this, when the disease manifests in varied presentations and pathologist report is the only way to diagnose, making the pre-treatment diagnosis extremely imminent. These are my few references. Thank you so much.
Dr. Silky. Dr. Silky?
Yes, sir.
You're here?
Yes, sir.
Yeah, okay. Am I audible now? Okay, so in your case, you reported this case as adenosquamous carcinoma of the gallbladder.
Yes, sir.
Can you tell me what are gross changes in this case and how usually adenosquamous carcinoma in gallbladder is different from routine carcinoma gallbladder grossly?
Sir, grossly, gallbladder carcinomas, they are flat lesions. They are gray white, gritty, a granular sort of thickening in the wall is observed. But in majority of the cases, sir, even grossly, just the wall thickening is present, and we cannot, we tend to miss all the, most of the cases grossly. Sir, and in adenosquamous carcinoma, sir, nothing specific morphology, but then, sir, it will be like, it was in this present case, there was at the neck, from the neck till the body, proximal body, there was wall thickening with areas of necrosis, which I could identify, which I thought it might be a GB cancer. But grossly also, I wasn't confident enough that it will turn out to be a cancer only, sir.
So in this case, what is happening is there are two components. You have a squamous component and an adeno component. That is what now?
Yes.
So why does it happen? What is the histogenesis for these cases?
Sir, from sir, adeno component, sir, first due to the inflammation, there will be metaplasia and then further dysplasia. And sir, squamous component, it arises abruptly. Sir, adenosquamous component in a glandular organ, squamous cell carcinoma, they arise abruptly. However, if it is arising elsewhere, it goes through that phase of metaplasia and dysplasia.
How common is adenosquamous carcinoma and how common is squamous metaplasia in gallbladder?
Sir, the incidence is noted to be 5 to 7%.
So how many of these cases might go on and form squamous carcinoma in the gallbladder?
1%.
Reported?
Sir, from the book, I read the incidence of pure squamous cell carcinomas are 1% and adenosquamous was written 7%.
Okay, so did you go for IHC in these cases?
No, sir. No, sir. Only histomorphologically, we made this diagnosis.
If you want to go for IHC, what markers would you use?
Sir, for the adeno component, we will go for CK7, P53, CA19-9, CA, and sir, for squamous cell carcinoma, CK5, 6, sir, P40, P63.
Why do you think this is important to see how much of it, what percentage of it is squamous cell and what percentage of it is?
Squamous differentiation, it makes it a more aggressive tumor presenting at a very late stage, and sir, hence worse prognosis. So because if a squamous cell carcinoma is arising elsewhere, we can give radiotherapy and cure it. But sir, in a glandular organ, if squamous cell carcinoma is arising,
you can't give radiotherapy there.
Sir, surgical excision is done, sir, and plus.
So poorer prognosis, right?
Yes, sir.
Don't say that you cannot give radiotherapy there. Yes. But yeah, poorer prognosis. That is. What about nodal metastasis? Did you look for nodal metastasis, or
yes,
why do you look for?
Sir, they had just operated it for cholecystectomy, so just gallbladder came. So, sir, we could not find any lymph node even at the neck region. There was no lymph node.
Do we go for nodal metastasis in these cases? Is there any significance of seeing nodal metastasis? You reported LVI, right?
Yes, sir. Lymphovascular invasion was seen there.
Yeah. So, is there any importance of nodal metastasis? Say we have a lymph
There
node
will be
here.
early progression.
Yours was as an incidental finding. Maybe that is why it didn't go for lymph node resection.
Yes.
Sir? Sir, ma'am?
What is the criteria to call it a squamous cell carcinoma? Suppose, how much should be the squamous component?
Sir, ma'am, if it's less than 5%, we call it just focal squamous differentiation. If it is 25 to 99% of the tumor is a squamous component, then we say it's a squamous, adenosquamous carcinoma.
Okay. Any other variants of gallbladder cancer which have worse prognosis?
Yes, ma'am, clear cell carcinoma has a worse prognosis.
Clear cell carcinoma. What are the IC markers that you put for clear cell carcinoma?
Ma'am, okay.
Any pre-malignant lesions of the gallbladder, you can tell me?
Ma'am, there are non-tumoral carcinoma in situ and ma'am, mucinous neoplasm.
Mucinous neoplasm.
Mucinous neoplasm?
Can you go for proliferative markers in this? Is it important in immunohistochemistry in this case?
Which are the proliferative markers? The sir is asking.
Ki67, P6.
Is it important in this case?
Yes.
If yes, how? So yours is a very simple case, right? You get a squamous cells, you get a lot of keratin pearls, you get obvious tumor cells in the squamous origin within an adenocarcinoma. So it's very obvious. Then how do you work this up, right? So you have to know what is the importance of finding squamous cell carcinoma within an adenocarcinoma. So Ki67 plays a very important role in these cases. Okay. But the case is nice. Thank you, Dr. Sethi.
Our third candidate is Dr. Akansha Singh.
Good morning. I, Dr. Akansha Singh from the Department of Pathology, would like to present my poster on the topic sarcomatoid carcinoma, a rare variety of urothelial carcinoma. Now, introduction. Sarcomatoid urothelial carcinoma is defined by the World Health Organization as biphasic tumor consisting of malignant epithelial and mesenchymal elements. It is aggressive neoplasm which is associated with poor prognosis. It usually presents with painless hematuria, sometimes associated with frequent urination and acute urinary retention. Clinically, it occurs more commonly in older males with male-female ratio of 3:1. It presents in advanced age with mean age of 63 years, rapidly growing polyploidal mass. Exact etiology is not known, but association with radiation and cyclophosphamide exposure has been described. Most common location is lateral walls of the bladder. Now, case details. Herein, we report a case of 60-year-old male presented with hematuria and pain in hypogastrium region since 18 months. Investigations. Cystoscopy revealed a solid mass and a papillary bladder tumor on lateral wall. Now, transurethral resection of bladder tumor was done. Grossly, multiple grayish-brown soft tissue pieces measuring 9 into 8 cm in aggregate was received. Microscopy. H&E stain sections showed tumor arranged in papillary architecture exhibiting complex and fused papilla with highly atypical nuclear features. Foci of atypical spindle cells with admixed chondroid and osteoid material and osteoclastic giant cells are also present. Stroma and muscle invasion is present. On immunohistochemistry, Cytokeratin is positive for both urothelium and spindle cells, and vimentin is positive for the spindle cells. Now, in the first image, we can see the fused papilla, presence of the fused papilla. In the second image, we can see the osteoid material. In this slide, in the first image, the arrow is showing the presence of the giant cells, and the second image is showing the presence of the chondroid material. Here, in the first image, we can see the presence of the osteoid material and giant cells, and in the second image, there is the presence of atypical spindle cells. Diagnosis: high-grade sarcomatoid urothelial carcinoma. Conclusion: sarcomatoid urothelial carcinoma is a rare neoplasm and has poor prognosis. Early diagnosis is important as it is highly aggressive neoplasm and immunohistochemistry plays an important role in establishing the diagnosis. These are the references. Thank you.
Dr. Kanchan.
Good afternoon, sir.
Good afternoon, Dr. Kanchan. Nice case. Can you tell me differential diagnosis that you considered in this case?
So, pleomorphic sarcoma or sir metastasis.
Metastasis from?
So, maybe it's a testicular region.
How do you get in urothelial carcinoma? How common are these?
So, urothelial carcinoma, the sarcomatoid variant is very rare. It ranges from 0.1% to 0.3%.
So when you started thinking about a sarcomatoid variant, what all did come to your mind? You have to rule out certain deities now. So since the presentation that you are getting, so considering that presentation,
yes, sir.
what all would you like to rule out in such cases?
So mainly in this carcinoma, mesenchymal origin, sir, atypical spindle cell was present.
Yeah. So what are spindle cell lesions that you want to rule out?
So spindle cell sarcoma, and so melanoma, so solitary fibrous tumor.
Okay, so
I'm interrupting here. In the pictures which I saw, was it a collision tumor? Because your urothelial carcinoma areas were quite distinctly seen, and the stromal elements, like the sarcomatoid elements, were clearly differently seen. So how was it in microscopy? Were they intermixed areas, or it was a collision tumor? What both the components? Yes.
Ma'am, it was both. It was intermixed also.
Intermixed areas in between those urothelial components, you saw the sarcomatoid area.
Yes.
The other thing you said, grossly, it was papillary completely. So on gross, were only papillary areas present, or did you see some sarcomatoid nodules also? Something grossly, you just saw papillary areas. Yes.
Yes, ma'am.
Dr. Nitish, please continue. I was just a bit.
You went for immunohistochemistry for cytokeratin and vimentin. What other markers would you like to subject this case to?
So for urothelial carcinoma, we also use the GATA3. And so CK7 is mainly for urothelium. So CK20.
Any other
P63, P40.
Did you see any myxoid areas?
No, sir. Myxoid areas was not present there.
Ramnavan sir, you wanted? Sir, you need to unmute.
What is carcinosarcoma?
Good afternoon, sir. So carcinosarcoma, it basically involves the epithelial component as well as the mesenchymal component.
Your ISC finding is the CK and vimentin both are positive. Why not carcinosarcoma?
Sir, because an atypical spindle cell was present, which was vimentin positive.
Okay. So how will you confirm this case? It is pure sarcomatoid carcinoma or carcinosarcoma?
It was sir CK positive and vimentin positive, and sir, there was other materials, the chondroid material, osteoid material was present there, and so giant cell too.
No problem at all.
What
Okay,
was
thank you so
what
much.
was the rate of
Okay,
mitosis?
yeah.
Dr. Akansha?
Yes, ma'am.
Necrosis, mitosis, because you were saying there were giant cells, even the chondroid areas were looking benign, right? Couldn't be
Yes,
a metaplastic change? Because those malignant areas, which was the sarcomatoid areas you are explaining, what was the mitosis? Was the necrosis present? You are totally classifying it as a sarcoma, but in the histology you haven't mentioned why a sarcoma. Could it be just be a metaplastic?
Ma'am, actually necrosis was not present there.
What was the rate of what was the mitotic index that you found here?
My mitotic index was 5 to 6 per high power field was present there.
Because seeing giant cells and these were looking very benign.
Yes, ma'am.
That should have been worked up further.
Okay.
Thank you, Akansha.
Okay.
Thank you, ma'am.
Thank you,
Thank you,
Akansha.
sir.
Thank you. We can move ahead.
Thank you, Dr. Akansha. Our next candidate is Dr. Divya Tiwari.
Good morning, everyone. I am Dr. Divya Tiwari from MGM Medical College and LSK Hospital, Kishanganj. Today, I am presenting my poster on lupus malaris disseminated fasciitis. So basically, it is a rare chronic inflammatory dermatosis, which is signalized by multiple disseminated reddish brown to yellow papules over the central face, particularly the periorbital and the perioral area. Nevertheless, extrafacial manifestations are also common. Now here we document a 16-year-old male patient who presented to our dermatology outpatient clinic with asymptomatic multiple reddish brown papular lesions over right and left intraorbital region, forehead, and more intensely over central face involving nasal bridge, persisting for more than 3 months and gradually increasing in number. There were no history of fever, weight loss in our patient, and the past history was insignificant. Now the investigations done for this patient was a punch biopsy, and the diagnosis was made on the basis of histopathological examination, which revealed epithelioid cell collection centered by large area of caseous necrosis surrounded by dense granulomatous infiltrates. Also noted were multinucleated Langhans type of giant cells. Zeal-Nielsen staining for acid-fast bacilli was negative, and these findings were finally consistent with the diagnosis of lupus malaris disseminated fasciitis. Here we can see the microscopic pictures. The figure 1, which shows us atrophic epidermis. The second figure demonstrates the collection of the epithelioid cell forming granulomas. Third, we can hear the focus is on the Langhans type giant cells, and the fourth is the caseous necrosis. Now, lupus malaris disseminatus fasciitis, it was first described by Fox in 1878, and approximately 200 cases have been reported till date, which makes it as a rare entity. Now, it is a rare granulomatous inflammatory chronic disease, which is mostly seen in young adults and affects both sexes equally. Particularly is characterized by multiple reddish yellow to reddish brown, primarily over central face, periorbital, and the perioral area. Although the histopathological findings may change according to the stage of lesion, epithelioid cell collection is centered by large area of caseous necrosis, which is a characteristic of lupus malaris disseminatus fasciitis. These are my references. Thank you so much.
A very good morning, everyone. I'm myself Dr. Divya Tiwari.
Good morning, Dr. Divya. Okay, so you had in your case classical clinical features or clinical presentation. So while
Yes,
reporting this case, what are the differentials that you considered?
So the overlapping features or the differentials which we can think of are most importantly, it can be granulomatous rosacea. The others can be lupus vulgaris and also histoid leprosy. These are the few differentials which come firstly in our mind when we see the histological pictures.
Okay, so how did you rule out lupus and leprosy?
So in lupus, there's very slight to almost no caseous necrosis, which is a very characteristic feature when it comes to lupus disseminatus malaris fasciitis. So one of those, and again, AFB, the Zeal-Nielsen stain for acid-fast bacilli is again, we found it negative here, while for lupus vulgaris, it will be like positive.
In all cases of lupus vulgaris, give positive ZN stain?
No, sir, not unnecessarily.
So then that can again add to the confusion.
Yes, sir, but then we have few more stains like the modified Zn stain, which we use, that is 5-ferroco stain, and then we can also do the tuberculosis test. So these are the few
Okay,
tests
good.
like, yes, sir.
Could you have considered a diagnosis of sarcoidosis here?
No, sir. In sarcoidosis, we'll again not get a caseating necrosis because naked granuloma, what we get identically or specifically in sarcoidosis.
Okay, so what type of giant cells did you get here?
So what we got in this slide was Langhans type of giant cell.
Okay, what about associated findings like associated fungal infection, or if there is a fungal infection, what would you have done, or did you look for any fungal infection?
No, sir. We were getting the characteristic features to make a diagnosis, so we didn't go beyond the histopathological. But if necessary, we can do special stains like the periodic acid skiff if you want to see the fungal presence.
Generally, you should always work up a case. You should go for ruling out fungal infection and other chronic inflammatory. What are other chronic inflammatory granulomatous inflammatory lesions?
So the lymphocytes, neutrophils, and we can also mainly the lymphocytes and the neutrophils.
What might be the etiology of this case?
So etiology, as it is not there. We don't have any established etiology, but yeah, the studies have proposed etiopathogenesis, which says that there may be an autoimmune reaction towards the pilosebaceous unit, or maybe due to any damage to the epidermal cyst.
Agree to that. Yeah. Ma'am, sir.
Yeah. Divya, the sole reason for ruling out lupus vulgaris was getting a Zenith stain negative. And as sir has said, what is the percentage of positivity of Zenith stain in a skin biopsy? In how many cases do we get it positive? What is the percentage it comes positive? Yes.
I'm sorry, I don't know the exact percentage.
Yes.
Yeah.
So if you look at the histopathological features, right, then what are the features which were favoring your diagnosis in comparison to lupus vulgaris? Because we saw the Langerhans cells, we saw the caseous necrosis. So histologically, could you think of any features to differentiate coming to your diagnosis of LMDF in comparison to the Zenith staining, which you thought was the
negative in this case? Yeah.
That was if that was the only reason, then making a rare diagnosis, as we always talk about things, it's always better to think of a common diagnosis than a rare diagnosis, right?
Yes, ma'am.
Please justify your diagnosis in comparison to.
Or was it based or biased by clinical symptoms? Because classical clinical presentation is there.
Yes, sir. And also, sir, when we see a lupus vulgaris case, when we see the epidermis, so basically there are morphological changes in epidermis, which was not very prominent here in the LMDF. So that was also one reason. There was no epidermal changes as such.
But a better thing would be keeping the differentials and letting the clinician take their own decision in this case, instead of we coming to a diagnosis just based on a negative Zenith stain. Okay. Dr. Ramnavan?
Any other variant of granulomatous rosacea? Close granulomatous rosacea.
So the perioral prepubertal rosacea is also one of, I don't think I'm getting to the exact name, but something related to the perioral prepubertal rosacea.
Okay.
Okay, thank you so much. You have read your references well, it seems.
Thank you so much, sir. Thank you, sir.
He has read the case.
We'll quickly move on to the next case, please.
Next, we have the presentation of Dr. Gunjita Singh.
Good afternoon, everyone. I am Gunjita Singh, a pathology resident in TMMC&RC, Moradabad. The title of my poster presentation is Leiomyosarcoma of uterine cervix, a rare entity. Cervical sarcomas account for mere 1% of cervical cancers. Though cervical leiomyosarcoma is the most common primary sarcoma of the cervix, very few cases have been reported worldwide. So much so is the rarity of this tumor that the protocol for treatment still remains unclear. Premenopausal and postmenopausal women are commonly affected and usually present with vaginal bleed. Herein, we report a case of 52-year-old female who came with a complaint of vaginal bleed and mass coming out through the introitus on straining since 4.
We can't hear. Is it audible to everyone? Because
No. I think it's gone up.
Sorry for the network interruption. I'll start it again.
Good afternoon, everyone. Cervical cancers. Though cervical leiomyosarcoma is the most common primary sarcoma of the cervix, very few cases have been reported worldwide. So much so is the rarity of this tumor that the protocol for treatment still remains unclear. Premenopausal and postmenopausal women are commonly affected and usually present with vaginal bleed. Herein, we report a case of 52-year-old female who came with a complaint of vaginal bleed and mass coming out through the introitus on straining since 4 months. Investigations, MRI revealed a large ill-defined mass arising from the cervix measuring approximately 10 into 8 into 6 cm. Pan-hysterectomy was done. These are the gross images. Grossly, large polypoidal soft mass with irregular outline was seen arising from the posterior lip of cervix. Now coming to microscopy. This is the scanner view which clearly shows the tumor along with area of necrosis. Second image is of low power view which shows interlacing fascicles of smooth muscle. Third image shows marked pleomorphic oval to spindle cells with large atypical hyperchromatic nuclei. Significantly high count of mitotic figures per 10 high power field and many tumor giant cells were also seen. Now coming to IHC, which forms an important aspect in diagnosis, and it showed the following. The tumor cells were negative for MyoD1. SMA and CalDesmon showed tumor cells with cytoplasmic positivity. Tumor cells were also positive for P16 and P63. On the basis of above mentioned investigations, a diagnosis of cervical leiomyosarcoma was made. Conclusion: caution should be exercised before designating cervix as the primary site for leiomyosarcoma, and the origin in lower uterine segment must be excluded. And it is rightly said that the diversity of histological subtypes and variable biological behavior, along with the small number of patients and different stages at presentation, results in an unclear protocol for the treatment of cervical sarcomas. These are my references. Thank you.
Dr. Gunjita?
Good afternoon, sir.
Good afternoon. Yours was again a straightforward case. I'll just ask one question. What effect do you think will this leiosarcoma have on cervical presentation? If you have leiomyosarcoma in cervix, what effect or how does it affect the patient?
Sir, as compared to the uterine leiomyosarcoma, it is a very aggressive. We see a very aggressive nature in the cervical leiomyosarcoma. So, and sir, we cannot. So this is the main reason, and very few cases have been reported. So, sir, we are not very sure what the treatment protocol is, and sir, and what stage of presentation when the patient presents because of very aggressive nature, it can have very poor prognosis. So, sir, this is the major concern where how it is more different than our uterine leiomyosarcoma.
Okay, thank you. Dr. Krishna, Dr. Ravi. Ramnaval, sir.
Dr. Gunjita, right?
Yes, ma'am. Good afternoon, ma'am.
Yeah, good afternoon. What are the prognostic features of a leiomyosarcoma of the cervix?
Ma'am, first of all, to say it as a leiomyosarcoma, we have to consider
Prognostic
three,
features I'm asking. What are the prognostic features that you have considered here? Because definitely compared, and how is the prognosis compared to the conventional carcinoma, CS cervix?
Ma'am, if there is, if microscopically, if we see, if there is a lot of cytological atypia, if it is severe atypia, if we see lot many pleomorphic cells, nuclear hyperchromatism is seen. If more mitotic figures are seen, then we can see say it as a,
give me a number, more name, Gunjita.
Usually more than 10 mitotic figure per 10 high power field is a very alarming sign. But here, ma'am, in this case, we are seeing more than 20 mitotic figures per 10 high power field. So it is definitely a very aggressive tumor here.
Okay.
What we are
You're already reporting this as a sarcoma, right, and not a carcinoma.
Yes,
so that makes it prognostically bad. Ma'am was
Yes.
asking what other patient-wise, if you look at patient, what other prognostic factors can be there in such cases, not this particular case, in such cases. So maybe tumor size you can say, or maybe
yes, sir.
age
The large
presentation.
tumor size. So the large tumor size is definitely more than 8 to 10 centimeters. So here, so not just in this case, but in general, if we see a very large tumor size with the itself is a very bad prognostic feature.
And how do these tumors behave in comparison to the conventional CS cervix? I mean, metastasis, extra ovarian spread, extra uterine spread, all these factors compared to your CS. Yes, Gunjita?
And this has a propensity towards the nodal metastasis. So
it has a higher or a lower propensity towards?
Ma'am, it has a higher propensity.
Check again, Gunjita. Okay.
Ma'am, it has a higher propensity.
That is okay. Okay, Ramnaval sir, if you want to ask.
What was the grading in this tumor? Grading क्या था?
So you were not audible. Sorry.
Sir is asking what is the grading of this tumor? What grading of this tumor?
Have you done ISC?
Yes, sir. Done ISC. Sir, done ISC. So ISC. Sorry, sir.
Sir is asking what is the grade of this tumor? How did you do grading, and did you do IHC on this tumor?
Yes, sir.
What can be the IHC? What can be IHC? What all markers can you put?
Sir, all smooth muscle. Two different. Sir, to say it as a smooth muscle tumor, sir, all the smooth muscle. Cal Desmond, Sir then Sir Desmond. So these were done to tell whether the tumor is smooth muscle origin. And sir, Mayo D1 was done because we had to differentiate it from other tumor of mesenchymal origin. And sir, so this one, so and Sir Cal Desmond was also.
Okay, no problem. No problem.
One of the IC panel.
Okay, thank you. So we'll move on to the next case.
Okay.
Next candidate was Dr. Anju Shukla, who has presented already. So we'll be moving with Dr. Pooja Gupta.
Good morning, everyone. Myself, Dr. Pooja Gupta from the Department of Pathology, Teerthanker Mahaveer Medical College, would like to present poster on the topic pleomorphic rhabdomyosarcoma and rare entity in adult nasal cavity. Starting its introduction, rhabdomyosarcoma are rare soft tissue malignancies which arise from myogenic cells. These are most commonly occur in pediatric population. The subtypes of RMS is even more rare in adults. The most common subsites of RMS is the head and neck region. In the head and neck region, parameningeal rhabdomyosarcoma, which include nasopharynx, nasal cavity, middle ear, paranasal sinuses, have been recognized as unfavorable tumors and are associated with poor prognosis. Its case details is 45-year-old female is presented with complaint of left nasal mass from 3 months. In the investigations, grossly it presents as a multiple grayish-white soft tissue pieces measuring about 5 into 2.5 into 1 centimeter. On microscopy, H&E stained sections shows tissue beds lined by respiratory epithelium having focal squamous metaplasia. Deeper, they are mostly hypercellular and focal hypocellular myxoid areas. Hypercellular areas showing seeds and cords of round, stellate, and spindle cells with scanty eosinophilic cytoplasm, round to oval nuclei, finely granular chromatin, and inconspicuous nucleoli, along with large rhabdomyoblast having abundant eosinophilic cytoplasm, eccentric pleomorphic nuclei, coarse chromatin, prominent nucleoli, and tadpole cells having elongated tails of cytoplasm. Few foci showing entrapped mucus-secreting glands with areas of squamous metaplastic change and dilated blood vessels. So this section shows tissue beds lined by respiratory epithelium having focal squamous metaplasia. Here in this picture we can also see the hypercellular and focal hypercellular myxoid areas. Hypercellular areas comprised of pleomorphic stellate to spindle-shaped cells which are arranged in sheets and cords. This picture shows having abundant eosinophilic cytoplasm, eccentric pleomorphic nuclei, coarse chromatin, prominent elongated tails of the cytoplasm. So the diagnosis is sinonasal rhabdomyosarcoma pleomorphic type. The conclusion, although rhabdomyosarcoma, especially the pleomorphic variant involving the sinonasal region are rare, but because of its rapid progression and unfavorable outcomes in adults than children, it is important to consider this entity in differential diagnosis of nasal or sinonasal masses in adults in order.
Over to the judges now.
Honorable sir, you can go ahead.
Good afternoon, sir.
Ramnava sir, you want to unmute, sir. Sir. Kashnar ma'am?
Yes, Pooja.
Yes, ma'am. Good afternoon.
How rare are these? Because rhabdomyosarcoma are otherwise known to have to be involving the head and neck region, right? So you say it's
Yes,
why do you think it's a rare tumor?
ma'am, actually, rhabdomyosarcoma, especially the pleomorphic variant, which is very it is more common in adult, but it is rare. Especially the subtype of rhabdomyosarcoma.
What was the age of your patient?
I'm 45-year-old female.
Okay. Right.
Can you tell me the immunohistochemistry markers for this test?
Yes, sir. So desmin, myod1, and myogenin.
Any
Thank you.
differentials you considered apart from pleomorphic rhabdomyosarcoma? Any differentials do you consider in this?
Ma'am, pleomorphic liposarcoma, and also we can consider in this embryonal or alveolar rhabdomyosarcoma.
Okay, Pooja.
Okay,
Thank you. That's all from my side. Next, please.
Okay. Candidate is Dr. Shamaila Samin.
Good afternoon, everyone. A very good morning to respected judges and dear colleagues. My name is Dr. Shamaila Samin, and I am going to present my poster on rare cytological findings in ascitic fluid of a patient of periampullary mass. Bile peritonitis in adults is a rare entity. An accumulation of significant amount of bile in the peritoneum results in bile peritonitis, which is an acute and serious condition. It is associated with high mortality in adults. Ascitic fluid in biliary peritonitis has not been reported extensively to the best of our knowledge, and here we present rare cytological findings in a patient with periampullary mass. This is a case of a 52-year-old female that presented with yellowish discoloration of eyes that she ignored for 9 months, and then she presented with abdominal distension for 20 days. When clinically investigated, she showed anemia, leukocytosis with deranged liver function test, and hyperbilirubinemia. A CT abdomen of the patient revealed a periampullary mass with stricture formation, gallbladder hypertrophy, left-sided nephrolithiasis with small contracted kidney. Careful examination of the ascitic tab showed an unusual greenish-brown fluid, and the cytospin smears were prepared of this fluid, and the slides were stained with H&E. Microscopic examination. On low power, extensive brown to yellow deposits were seen. These deposits were present both extracellularly and intracellularly. On higher magnification, we saw extracellular deposits of golden yellow amorphous bile, along with bile-laden golden yellow amorphous bile deposits, which have been engulfed by macrophages, are clearly visible in this pictomicrograph. When the higher magnification was carefully examined, we saw extracellular bile deposits in needle-like forms. Bile pigment deposit in the ascitic fluid is a rare finding, and it indicates bile leakage into the peritoneum. Gross examination of the sample or the fluid received is as important as microscopic examination. Cytopathology reporting of biliary peritonitis has not been described extensively. Al-Sheikh et al. Reported a similar case in 1996 by identifying bile-stained macrophages and extracellular bile deposits. In 2005, Gupta et al. Examined a green-brown peritoneal aspirate under polarizing microscope and reported several birefringent bile crystals. Reporting such entities like bile pigment, bile-laden macrophages, extracellular crystalline structure in ascitic fluid further confirms and strengthens the suspicion of the rupture of the biliary system, and this forewarns the surgeon of possible complication. When we see brown deposits in macrophages, the differential diagnoses apart from bile are hemosiderin and melanin. These are my references.
Good afternoon, judges.
Good afternoon, Dr. Shamaila.
Yes.
I just want to ask you, okay, you already gave your DD when you got a green colored ascitic fluid tap. So you already gave your DD. So how do you confirm apart from microscopy?
So first of all, we have to examine the gross fluid. I wanted to emphasize that gross examination is as important as microscopy. So when we looked at the gross, it was not just brown, it was green-brown. So that indicated our suspicion towards bile. Further, on microscopic examination, we have golden pigment, which is hematoidal, which is specific for bile. And sir, if we want to confirm bile, we can always use the Hall's method, which is the Fauchet's reagent, and oxidize this bile to biliverdin, which gives an emerald green color.
Did you do those tests? Did you confirm the diagnosis?
No, ma'am, I did not do this because we have this circumstantial evidence with us that it was green, and we also further found a rupture in the CBD system.
That must be radiologically that you found, right?
That was, no sir, it was not present radiologically. It was found when the ascitic tap was done, and they saw biliary fluid. Then they did a emergency laparotomy, and they found a rupture in the CBD.
Just out of the way question, can you tell me the biochemical composition of these crystals?
So these crystals they can be made of calcium oxalates, and sir, these which are present in the
calcium oxalate.
So there is also a component of the bilirubin called the microspherulites of the bilirubin, which are present here.
Okay, thank you. Ma'am, anything else?
And how did it affect the prognosis in your patient? Well, your patient was operated, right?
Yes, the patient was operated. A pancreatoduodenectomy was performed. It was a case of periampullary carcinoma of pancreatobiliary type, which has a very worse prognosis. Also, this patient presented with acute abdomen with bile, which in itself is a serious and acute condition.
Okay.
We can go to the next case, Dr.
Yeah. Thank you, Dr. Shamala.
Thank you, sir. Thank you, ma'am.
Next candidate is Dr. Nishant Mitra. Next candidate is Dr. Nishant Mitra.
Morning, everyone. I am Dr. Teerthanker, Mahaveer Medical College. I am here to present my in a patient of chronic pneumonitis pyelonephritis with nephrolithiasis, renal stone masquerading renal malignancy. As renal cell carcinoma is rarely associated with tuberculosis, while the incidental discovery of renal cell carcinoma in a tuberculous kidney is well described. The discovery is tuberculous lesions after nephrectomy for cancer is exceptional. The most common type clear renal cell carcinoma only rarely having a papillary architecture and vice versa. Primary renal cell carcinoma with both papillary architecture and clear cell type may be a diagnostic challenge. Smoking, high consumption of fatty food, hypertension, diabetes mellitus, obesity are considered to be the risk factors for renal carcinoma. Chronic inflammation has proven to promote tumor growth, as chronic renal stone disease has been shown to be associated with renal cell carcinoma, and renal tumors have been found to be more frequent among patients with renal stone. A case of 70-year-old male was presented with a 6-month history of lump in a right lumbar region, which was insidious in onset and gradually progressive, associated with dull aching pain, and relieves on medication. There was no aggravating factors, and complaint was also associated with intermittent urinary history. On peritoneal examination, swelling was 9 to 6 centimeters as in right lumbar regions, which was non-tender, found non-compressible with irregular margins and no movement with respect. Coming to investigation, ultrasound for abdomen was suggested for right-sided broad hydronephrosis with the right pelvic aortic junction calculi, which was 28 mm in size. CCT for abdomen suggestive of right pelvic calculi, 17.2 to 7 cm, causing severe hydronephrosis. DTPA again suggestive of less than 10% of functional kidney. Coming to histopathology examination, on gross we received grayish-brown specimen of right kidney with attached peripheral fat measuring approx 9 into 6.5 into 6 cm. Outer surface was multilobular, capsule cannot be stripped off easily. Holes and leaves on medication. There was no aggravating variance as in right lumbar regions, which was non-tender, found non-compressible with irregular margins and no movement with respect. Coming to in size, CCT for abdomen suggestive of right pelvic calculi 17.2 to 7 cm, causing severe hydronephrosis. DTPA again suggestive of less than 10% of functional kidney. Coming to histopathology examination, on gross we received grayish-brown specimen of right kidney with attached peripheral fat measuring approx 9 into 6.5 into 6 cm. Outer surface was multilobular, capsule cannot be stripped off easily. Holes were not identified. On cut section, multicystic areas filled with yellowish white fluid were seen. Cortical medial HNE stain shows malignant tumor of tubular epithelium arranged in S and sheet with round nuclei, few nuclei showing presence of nuclei at higher magnification along with clear cytoplasm as shown in figure 4. On foci of encapsulated area was also showing epithelium arranged in papillary structures. These cells having round to oval nuclei with stipple to clump chromatin and inconspicuous nuclei as shown in figure 5. Other section specimen shows interstitial fibrosis, intense inflammatory infiltrate, thyroidization of tubules along with multiple epithelioid cell granuloma with Langerhans giants. This study was to report our pathological findings in nephrectomy specimen from patients treated for non-functioning hydronephrotic kidney due to renal pelvic stone disease. As in functioning kidney, renal tumors may mimic urolithiasis and renal colic pain, so they get easily diagnosed. But in case of non-functioning kidney, it is difficult to diagnose renal cell carcinoma. Therefore, for treatment of non-functioning kidney, simple nephrectomy is usually performed. Renal tuberculosis is also known to have a varying presentation with its symptoms and signs varying in both intensity and duration, and most tubercular non-functioning kidney requires nephrectomy. The conclusion of this study is that we should consider the possible malignancies in a non-functioning kidney, especially in a nephrectomy specimen with renal stones. Thank you. Good afternoon, judges.
Good afternoon, Dr. Nishant. We are already running short of time. So I'll keep this short. What are the what is the pathogenesis? What is the carcinogenesis or the cause of carcinogenesis? Or what is the carcinogenesis for renal cell carcinoma in this case?
Renal cell carcinoma, sir, in basic clear renal cell carcinoma, there is a defect in a chromosome 3, which is von Hippel-Lindau mutations, which further leads to the clear cell renal cell carcinomas.
What might be the cause for this multiple presentation of a background of inflammation and carcin and calculus?
Sir, sir, there are many studies in which it has been done that there is a finding in tuberculous nephrectomy specimen of renal cell carcinomas. But in renal cell carcinomas, when the nephrectomy was done, the chances of tuberculosis was less. But in the case of, and also with the renal stool nephrectomy specimens, the chances of squamous renal cell carcinomas are already studied. But in this case, all the rare findings, all the rare cases like nephrectomy specimen done for the renal stone, we diagnose renal cell carcinomas along with tuberculosis. Tuberculosis.
Okay. Thank you. Kashal ma'am, Ramnaval sir.
No, we can go to the next presentation.
Thank you.
Thank you. We can go on to the next presentation.
Our next candidate is Dr. Nida Ehsan.
Good morning, respected judges and teachers. My name is Dr. Nida Ehsan, and I'm a junior resident in the Department of Pathology, JN Medical College, AMU, Aligarh. The title for my poster is Xanthogranulomatous appendicitis, a rare entity. Now coming on to the introduction, xanthogranulomatous inflammation is an uncommon form of chronic inflammation which is first reported in the genitourinary tract. It can involve any organ, but the most common sites are kidney and gallbladder. It is an extremely rare phenomena in the appendix. According to a study conducted by Sami Agbulad et al., published in January 2021, only 29 articles involving 38 patients of xanthogranulomatous appendicitis have been reported so far. Here, I'll be presenting a case of a 20-year-old female who came to the surgical OPD with high-grade fever, right lower quadrant abdominal pain, loss of appetite, and vomiting for 8 days. On clinical examination, she was found to have rebound tenderness and pain over the McBurney's point. Her labs showed raised WBC counts and raised C-reactive proteins. On ultrasound, an impression of inflamed appendix was provided. So based on the clinical presentation, physical examination, labs, and radiological findings, she was diagnosed as a case of acute appendicitis and appendicectomy was performed. On gross, we received an inflamed appendicectomy specimen measuring 4 into 0.5 centimeter. There was no perforation or gangrenous change which was noted. The external surface was dull and congested, and one section from tip and base was taken. Microscopically, H&E stained section from the appendicectomy specimen showed an ulcerated mucosal lining, submucosal lymphoid aggregates, transmural mixed inflammatory infiltrates, and many foci of aggregated foamy macrophages and occasional giant cells were seen. So based on the history and microscopic picture, a diagnosis of xanthogranulomatous appendicitis was rendered. In conclusion, I would like to reiterate the fact that xanthogranulomatous changes are extremely uncommon in the appendix. Sometimes it may mimic features of malignancy in the right colon. Therefore, a careful clinical, radiological, and pathological correlation is extremely important to come to a proper diagnosis. Thank you so much for your time.
Dr. Nida?
Yes, sir.
Okay, so what might be the pathogenesis in this case?
So the exact pathogenesis is known, but a few hypotheses are done. The most important one is that there might be a defective lipid transport. Other hypothesis which was taken was that there might be immunological disorders, like there might be disturbance of in the macrophages or polymorphonuclear cells. Another hypothesis.
So while diagnosing xanthogranulomatous, what you saw were the foam cells. Can you do anything about foam cells to confirm them?
To confirm it,
Any
we could have
special
done
strain,
an
any
IHC
IHC?
with CD68, which are specific for macrophage.
Any negative markers that you want to apply to this case?
So negative markers, we could have done Von Cossa or Pearl stain to rule out malakoplakia.
Anything else that would like to see in this case? Any other TT or any other sections or anything just to rule out anything else that might be present in a background of xanthographitis?
20% of the cases of Crohn's also sometimes show features of acute appendicitis. So we could have used that also as a differential.
The appendix is very notorious. You have to rule out carcinomas also.
Colon cancer.
Thank you from my side.
Nida, you mentioned something, malakoplakia. So what are the other findings and the characteristic finding in malakoplakia?
Ma'am, Michelson-Gutman bodies.
What are these?
Ma'am, these are calcico-spherical concentric intracytoplasmic inclusions, which are mainly include calcium and iron deposits.
What is the special stain you can do for that?
Ma'am, Von Cossa and Pearl stain. Von Cossa for calcium and Pearls for iron.
Thank you, Doctor. Thank you. We'll go on to the next case.
Yes. The last candidate we have is Dr. Shama Tiwari.
A very good morning to everyone. Myself, Dr. Shama Tiwari, Associate Professor in Motilal Nehru Medical College, and I'm presenting my poster on the topic of primary plasma cell leukemia, which is a very rare entity, and it presents itself in two ways. One is primary plasma cell leukemia, which presents de novo, and second develops during the course of multiple myeloma, which is known as secondary PCL. Incidence of primary PCL is reported to occur in less than 1 in a million, and the diagnosis is based on the Kyle's criteria, which says that clonal plasma cells in peripheral blood should exceed 20% of the total leukocyte count, or it should be more than 2 into 10 to the power 9 cells per liter. According to a survey, PPCL may account for about 60% and secondary PCL for about 40% of the cases. Average age of affection of primary PCL is 55 years old, which is slightly younger than that of secondary PCL, which is approximately 66 years. Now here is the case of 48 years old male patient who came to the emergency OPD with chief complaint of acute renal failure and moderate hepatosplenomegaly. His biochemical investigations showed markedly increased serum urea and creatinine. With this much information, the patient came to Department of Pathology. We have done hematological investigations which showed that the patient is quite anemic with a hemoglobin of 4.5 gram per deciliter and total leukocyte count is marginally raised, 17,000 cells per cubic mm. The real diagnosis clinched on general blood picture, where it showed that plasma cells along with plasmacytoid lymphocytes constitute almost 56% of the differential leukocyte count, and platelets were grossly reduced by this. On bone marrow examination, it shows that hypercellular marrow predominantly showed plasmacytoid cell population consisting chiefly of plasmablasts and abnormal plasmacytoid cells. All other cell series lineages were basically reduced. Here is the microphotograph of Leishman stained peripheral blood smear, which shows clearly plenty of plasma cells having eccentric nucleus and intensely basophilic cytoplasm. This is 100x. Now coming to the discussion, plasma cell leukemia is important to recognize because of its rarity of occurrence and unusual presentation. It has two types, and the likelihood of myeloma patients developing secondary PCL is very low. It is estimated that 1 per million of the general population are diagnosed with primary PCL each year, while approximately 1 in 100 melanoma patients will go on to develop secondary PCL. Very few cases have been reported in literature, like one by Abid Jamil, a case of 51-year-old male patient with history of fever and altered sensorium and having peripheral blood plasma cells of 24%. Similar case was another case was studied by Singh et al., who reported a 70-year-old male patient with weakness in cervical lymph nodes, and again here showed plasma cells and plasma blasts in bone marrow. Similarly, John et al. Also reported a case of primary plasma cell leukemia having pleomorphic morphology of plasma. In a nutshell, this case is important because of the rarity of this entity. Secondly, the age of presentation of the patient was only 48 years, which was quite younger than what is documented. And presence of organomegaly in form of hepatosplenomegaly in absence of lytic lesions of bone, which further showed that patient has primary plasma cell leukemia, excluding the possibility of secondary plasma cell leukemia. Thank you.
Good morning, sir. Good morning, ma'am.
Yeah. Good morning. Since we are already running out of time, I have to limit my question answer sessions to one question only. Okay. How can you just list out, how can you further work up this case? You have based your diagnosis on morphology of peripheral smear and bone marrow.
Further we can, to exclude multiple myeloma, we should have done a full body X-ray of the patient so that we can rule out the presence of osteolytic lesions. We have further also add serum calcium, all that CRAB criteria, sir. And then for just to rule out the multiple myeloma, sorry. And for reactive, we should also do flow cytometry to rule out the reactive, so to prove the monoclonality of the plasma cells.
What all markers you can go for?
Dr. Sharma, you will do the flow cytometry to.
Good morning, ma'am. Yes, sir.
Yeah, good morning.
Yes,
flow cytometry to prove the monoclonality or something else?
Ma'am, basically we should do CD markers for flow cytometry. We use CD markers like ma'am CD38, CD138. These are the very characteristic which we can get positive in plasma cells. And in primary plasma cells, ma'am, we do not get a CD56 marker, which is very much which is more common in multiple myeloma, ma'am.
Any other marker which rules out or which goes against your diagnosis, which will come negative or no positivity?
Sir,
apart from CD56 that you said.
Yes.
Sir, cytogenetics के लिए जा सकते हैं sir.
Directly है.
Flow marker.
Flow marker.
Yeah.
Okay, no. Can you go for CD117?
Yes, CD117. Yes, sir. We
CD9.
can go for that. Sir, we can. For sir,
Okay,
secondary PCL, sir, we can go for CD28 also, sir. If I'm not wrong.
Yes, I'm already suggesting.
Yes, ma'am.
Any morphological differentials? If we see plasmacytoid cells in the yes. So
yes,
so what else can we think of? You know, any other difference?
Ma'am, plasma.
Yeah.
Ma'am, we can think of, ma'am, in cases, ma'am, bone marrow, especially we can go for Kala Azar because we get most of the time very reactive plasma cells there, and malaria also. But ma'am, plasma, we are getting proper plasma. Peripheral smear, ma'am, plasma cells in peripheral smear, ma'am, multiple myeloma is the most common. Usually when we think about neoplastic, in non-neoplastic, ma'am, we can go for Kala Azar, not that common. Or ma'am, any lymphoid neoplasm, ma'am?
Like which lymphoid neoplasm? That is what I wanted to ask.
Ma'am, ma'am, we can go for hairy cell leukemia. Ma'am, hairy cell leukemia, we can get those labs.
Actually, this is one case where we can keep on asking you questions for another 4 hours.
I know. I think we can. This is the last case, Dr. Agarwal?
Last case, and Seema ma'am is like, okay, finish it off. Why are you talking it?
Thank you, sir. Thank you.
Thank you so much. Thank you.
Taking out their times. We are continuing with the inauguration ceremony. Thank you, sir. Thank you, ma'am.
Thank you. Thank you so much for meeting us. Thank you. From the whole team of judges. Thank you.
Yes. Thank you to the participants and also the judges.
Thank you, ma'am. Thank you, ma'am. Thank you. We'll continue we'll start with the inauguration ceremony in another 2 minutes. I'll request you all to be online.
TMU हम हैं विश्वास से भरे TMU आगे और ऊंचा बढ़े TMU हम हैं विश्वास से भरे TMU आगे और ऊंचा बढ़े। नींव में है जिनकी सिद्धांतों का दम, सत्य की शरण और अहिंसा ही धर्म, वो ही करेंगे देश का निर्माण। रोशनी के रस्तों पे रखते हैं कदम, ज्ञान का उगा सूरज निकली है किरण। हम हैं विश्वास से भरे TMU आगे और ऊंचा बढ़े।
Heartiest good afternoon to all. Thanks to each and every one of you being here with us today. We are pleased to welcome you all here. Today marks the 28th annual conference of UP Chapter, Indian Association of Pathologists and Microbiologists. And we are proud to host it today at this wonderful place with all of you. The UP-PATHCON is advancing to one of the most prestigious, vibrant and cultural universities, Teerthanker Mahaveer Medical College and Research Center, Moradabad. The Department of Pathology extends a warm invitation for you to experience their culture, highlights, networking, hospitality, and skilled academics. Together, these unique aspects give us the privilege to host this conference. We shall be offering you with a multitude of events, including latest research papers, poster presentations, advancement in medical sciences, informative seminars, and cases. Thank you all the office bearers for giving us opportunity to host this conference. It was a great honor bestowed on us, and at the same time was a big responsibility to be shouldered by us.
Someone very rightly said, "Remember me and I will be alive always." It's hard to see tomorrow when someone you love is gone. It's hard still to realize that your life still go on. The Lord won't give you burdens He knows you cannot bear. He will not leave you comfortless. You will always find Him there. We are all our Father's children on earth and up above. Your loved ones walking close to God, surrounded by His love. Although no words can ease the loss of our respected, beloved Dr. Raj Mehrotra sir and Dr. Lahiri sir. You are close in our thoughts and prayers. Our prayers and fond memories are what we must remember of our dearly departed. Our most heartfelt condolence. Before initiating further, we would like to extend a warm welcome to our head of TMU family, Honorable Chancellor and Chief Guest of the day, Shri Suresh Jain sir, a model of dedication and perseverance for all of us. And our guest of honor, Vice Chancellor of TMU, Shri Raghuveer Singh sir. I would like to extend a warm welcome to Group Vice Chairman, Shri Manish Jain sir, Governing Body, TMU, Shri Akshat Jain sir, and to the Director Administration, Shri Abhishek Kapoor sir, and Registrar Aditya Sharma sir. We welcome you, sir. I owe much gratitude to the past President, Dr. Ranjan Agrawal sir, Dr. Shamoli Datta ma'am, Dr. Anil Agrawal sir, Dr. Nuzhat Hussain ma'am, Dr. Mahendra Singh sir, Dr. Dwijen Nath sir, Dr. Ashutosh Kumar sir, Dr. S.H. Arif sir, who have contributed in so many ways to turn the events into a smoothly running meetings with many interesting presentations and posters and a very good atmosphere for discussion and networking, and pave the path for us to follow. I want to express my gratitude to our esteemed seniors who have been so kind to grace the occasion. Dr. Padam Kumari ma'am, Dr. R.K. Gupta sir, Dr. P.K. Singh sir, Dr. Rajiv Mishra sir, Dr. Ashutosh Kumar sir, Professor S.C. Gupta sir, Dr. P.A. Singh ma'am, Dr. Mamta Singh ma'am, Dr. Deepti Bisht ma'am, Dr. S.L. Tilvarsan sir, and other senior pathologists present on this platform. We wholeheartedly welcome you, sir and ma'am. And we would also like to recognize the presence of our office bearers from our national body, IEPM, Dr. Vatsala Mishra ma'am, President of IEPM and Professor and Head of Department of Pathology at Motilal Nehru Medical College, Prayagraj, who needs no introduction, has well-renowned name. She is known for her work and publication at national and international level. Dr. Hareen Kumar sir, Joint Secretary of IEPM, Dr. Ranjan Agrawal sir, Editor-in-Chief IGPM, in Official Journal of IEPM. Thank you all for sharing your valuable time for gracing the occasion. We wholeheartedly like to extend a warm greeting to the office bearer of UP Chapter IEPM, President Dr. S.H. Arif sir, Vice President Dr. Pradyuman sir, Treasurer Dr. Ram Nawal sir, and Joint Secretary Dr. Anupam Vashne sir. We would sincerely like to thank and greet our Principal TMMC&RC, Dr. Shamoli Datta ma'am, and Vice Principal Dr. S.K. Jain sir, Medical Superintendent Dr. Ajay Pant sir, Deputy Medical Superintendent Dr. V.K. Singh sir. Now, our regards to Almighty and wish for the success of this event. The best way of projecting so is by eternal lamp lighting, and it's our only tradition to worship our goddess Saraswati before any important event. So let's dedicate our prayers to Ma Saraswati.
Ya kundendu tusharahara dhavala, ya shubhra vastravrita, ya veena varadanda vanditakara, ya shweta padmasana, या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा। शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहाम्। हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्।
Due to COVID and travel restriction that is brought along, it indeed has become a dream for us to hold this conference. Without physical presence of all the esteemed guests, but nonetheless couldn't stop from blessing your essence. and that of this conference in our university campus. Let me show you all my guests how excited we are to have all of you with us today. For that, we are giving you a virtual tour to experience and visit our department.
Hello everyone, I, Dr. Ariba Nasir from the Department of Pathology here at Teerthanker Mahaveer Medical College and Research Center, Moradabad, and is your tour guide of the day. I'm here to walk you through the incredible complex of pathology department that our college acquires, nothing less than an ideal block, fully devoted to providing professional, resounding, theoretical knowledge of pathology to the medical students, clinicians and researchers. We are starting our journey from the entrance of the medical college. This is the ground floor, which is the base of the medical college. Firstly, starting with the Honorable Principal Office, Dr. Shamoli Datta ma'am. We are lucky to have our own principal as a pathologist, a governing body from where we all are being guided, commanded and permitted in several aspects of our profession fronts. From here, let's move to our second floor, which is graced by our pathology department. Now we have come to the second floor, which is our Department of Pathology, Center of Medical Facilities, that's the Diagnostic and Learning Pathology Center, run by a profound pathologist of all the grades of assistant to professor and head. Now let's move to our histopathology lab. We have a grossing area where sectioning of the tissues are done. Now let's enter our histopathology lab. These are the various instruments which are needed for preparing slides. These are the specialized stains and immunohistochemistry. This is our departmental library, which is organized primarily to serve the need of academic areas. Let's give a quick recap to our MBBS time, where we used to be curious to know about the specimen. That is one and only museum, an institution with educational use. This unit surely manages to captivate the eyes and soul of all the enthusiastic students with its diversity. It is loaded with perfectly preserved, well-mounted specimens. Respected Dr. Seema Avasthi ma'am. She has a dynamic personality with a broad vision.
Good morning everyone. I am Dr. Seema Avasthi, Professor and Head, Department of Pathology, Teerthanker Mahaveer Medical College and Research Center. This is my proud privilege to introduce you to the Department of Pathology here in Moradabad. I can very proudly say that department here is well equipped with the modern instruments and an example of automation in various sections of pathology for the excellent teaching of postgraduates and undergraduates. Here in our department, we have a state-of-art museum with more than 400 specimens for the detailed teaching, blood bank with the component and the apheresis facility, fully automated histopathology laboratory, decahead and pentahead for the excellent teaching of undergraduates and postgraduate students. Thank you.
Moving ahead with the virtual tour, hello, I am Dr. Akansha Singh and will be covering the diagnostic sections of our department. This is our hospital where the important sections of our department, that is cytopathology and hematology, is situated. Now let's move towards our department. Now let's move to the much needed room in any hospital. Most of the burden lies in this room, and that is none other than our hematology lab. Here the pathology facilities are provided. Further, we move to our cytopathology lab. This is the area where the processing of the slides are done. A pentahead is installed here, which enlightens the postgraduates regarding the slide discussion with our respected faculty members for proper teaching and acquiring knowledge. This is a section where FNAC is done by the postgraduates and faculty members. Blood donation is an art of selfless service by a donor. With this, we have reached our blood bank. This is the reception area. This is the phlebotomy room where the blood collection is done. This is apheresis room. This is the apheresis room. Moving ahead with the procedures and techniques of a blood bank, we have a serology lab where the different various tests are done. This is a transfusion transmissible disease lab where the various tests are conducted. This is the blood component preparation room where the blood components are prepared and stored. So this is all about the virtual tour of a department. I hope you all enjoyed, and thank you all for devoting your precious time. Thank you.
Now, I must appreciate the ultimate effort put in by our respected organizing chairperson, head of department of pathology, Dr. Seema Awasthi ma'am, who has not only been our guiding light, but has always continued to be an epitome of dedication and our strongest support. Kindly enlighten us with your words of wisdom, ma'am.
Don't be pushed around by the fears in your mind. Be lit by the dreams in your heart. Good morning, one and all present here in this beautiful morning. And it's my proud privilege to welcome all dignitaries and delegates to the 28th Annual Conference of IAPM UP Chapter 2021 at Teerthanker Mahaveer Medical College and Research Center. Instead of worrying about what we can't control, shift your energy to what you can create. Yes, the pandemic has taught us this very well in last 1.5 years, as well as has opened new horizons in almost every field of life. So is the education. So here we are on virtual platform sharing knowledge and experience with the enthusiastic audience, and I am delighted to welcome our delegates for their overwhelming participation and response. Thank you so much. I welcome you all. We are fortunate to have with us the visionary chief guest of today's function, Shri Suresh Jain sir, Honorable Chancellor Teerthanker Mahaveer University, who has always been a driving and guiding force for organizing such events. I wholeheartedly welcome you, sir. I welcome Group Vice Chairman Shri Manish Jain sir and thank him for the continuous encouragement and support. Our guest of honor, Shri Raghuveer Singh sir, Vice Chancellor Teerthanker Mahaveer University, is a great academician and a perfectionist in his life, and I welcome him for his gracious presence in today's ceremony. Shri Abhishek Kapoor sir, Director Administration, has always been a catalyst for such events, who provides
such a quick and prompt solution to all our queries and problem. Thank you so much, sir, for always being there. Sharing the responsibility and delegating the work according to one's competency is an art. And I owe this learning to our very own principal, Teerthanker Mahaveer Medical College and Research Center, Dr. Shyamali Datta, ex-HOD Pathology. I welcome you, ma'am, on this platform. I wholeheartedly welcome Professor Ajay Pant, Medical Superintendent, Teerthanker Mahaveer Hospital, Vice Principal Dr. S.K. Jain sir, Deputy Medical Superintendent Dr. V.K. Singh sir, and heads of various departments for sparing their valuable time and extending much needed support at every step. Welcome you, sir. As we all know, disease is a thief which robs the most important thing from us, that is our health. And before any judgment comes, it's us, the pathologist and microbiologist, who catches it. So we are the police. Continuing with this, I welcome Dr. Vatsala Mishra, President, IAPM, for her continuous support. Ma'am, in spite of her busy schedule, she was always guiding, responding, motivating and advising us at every step of the preparations. Dr. Harendra Kumar, Joint Secretary IAPM, Dr. Ranjan Agrawal, Editor-in-Chief, Journal of IAPM, has always been so supportive and motivating in all our endeavors. I also welcome Office Bearers of State Executive Body, President Dr. S.H. Arif, Secretary Dr. Pradyum Singh, Joint Secretary Dr. Anupam Vashne, and Treasurer Dr. Ram Nawal for believing in us and giving us this huge responsibility. Success of any conference is majorly attributed to its speakers and the topics. And I take this opportunity to welcome our esteemed guest speakers of national and international reputes who are presenting and discussing the topics of very practical and relevant subjects. Organizing a conference is a huge responsibility, but it all becomes easier when you are showered with the blessings of the pioneers. With great respect, I welcome Dr. Padam Kumari ma'am, Dr. R.K. Gupta sir, Dr. Rajiv Mishra sir, Dr. P.K. Singh sir, and other seniors present on this platform. Thank you, sir and ma'am, for gracing the occasion. No student could stand taller and wiser without the blessings and of the guiding teachers. And I welcome my mentors and teachers from the alma mater, Dr. Nuzhat Hussain, Dr. Madhumati Goyal, Dr. Ashutosh Kumar, and Dr. U.S. Singh sir. I hope we will be good hosts to you all, and our meticulous team efforts in such a short span of time will reflect in our executions. Don't just learn, experience. Don't just read, absorb. Don't just think, ponder. And don't just change, transform. Thank you everyone. I welcome once again everybody. Jai Hind.
Thank you so much, ma'am, for your wonderful words. Next, to greet us with his warm and inspirational words, we have amongst us our Vice Principal, Dr. S.K. Jain, sir. Sir, kindly enlighten us with your graceful words.
A very good morning to all. This side Dr. S.K. Jain, Vice Principal, TMMC&RC, welcome you in PATHCON 2021. It gives me an immense pleasure that Department of Pathology is organizing UP Chapter Conference under the leadership of Dr. Seema Awasthi, who is head of the department. I welcome Dr. Vatsala Mishra, who is President IAPM, and I also welcome all other office bearers of UP Chapter IAPM. I congratulate the organizing team, participants, and eminent pathologists on this platform. Hope presence of you all will make this conference a big success. Thank you.
Thank you so much, sir, for your graceful words. Next, we have our respected medical superintendent, Dr. Ajay Pant, sir. Sir, kindly grace the occasion with your wonderful words.
It is indeed a matter of great pride and accomplishment that our Department of Pathology is organizing the PATHCON 2021 this year in our institution. The Department of Pathology holds a very significant position in our institution because in the past they have organized many scientific events with good amount of success. The team of Professor Seema Avasthi and Professor Ashutosh Kumar, they have worked very hard in the past. Noteworthy work has been done by them and they hold to their credit many accomplishments. And in this endeavor of theirs, I wish them all success and I am very confident that this event also will be a stupendous success. I wish them all the best. Thank you.
Next, now we request our Honorable Principal, Dr. Shamali Datta ma'am, to address the gathering and to give her valuable inputs. You have motivated people by sharing your expertise and knowledge. Kindly grace the occasion with your wonderful words, ma'am.
I congratulate the Department of Pathology for once again taking up the challenging task of organizing UP-PATHCON 21 on 30th and 31st of October 2021, this time in online mode. My blessings to the most capable organizing chairperson, Dr. Seema Avasthi, and her brilliant team comprising of energetic organizing secretary, Dr. Ashutosh Kumar, along with Dr. Rajneesh Kumar, Dr. Fayaz Ahmed, Dr. Ankita Mittal, Dr. Deepti Arora, Dr. Rashmi Chauhan, and their obedient battalion of postgrads. I must add that the pillar of support for organizing conferences has always been none other than the inspiring persona, Mr. Abhishek Kapoor, the Director Admin of our institution. Delegates will be enlightened by the latest concepts, views in the different branches like histopathology, cytology, and hematology by a galaxy of eminent speakers. Dr. Teerthanker Singh, who has written numerous books on hematology, which has been read by one and all pathologists having interest in hematology. A senior member of our fraternity, Dr. Vatsala Mishra, needs no introduction. She is known for her work and publications at national and international level. And then there's a series of learned facilitators whose students are found in India and abroad alike. Dr. Nusrat Hussain from RML Lucknow, Dr. Pradyuman, Dr. Fauzia Siraz, Dr. Arunama Mishra, and Dr. Atul Gupta, whose talks on various subjects are so much adored by students and teachers alike in pathology. I am confident that all the delegates will enjoy interesting, innovative, and intellectual feast for 2 days and will have the golden opportunity to interact with these speakers. Richard Stallman wrote, "Sharing knowledge is the most fundamental act of friendship because it is a way you can give or spread knowledge." I enclose my best wishes to the organizing team of UP-PATHCON 21. Thank you.
Now, we request the President of UP Chapter, Dr. S.H. Arif, sir, kindly grace the occasion with your wonderful words, sir.
Honorable Dignitaries, Organizing Chairperson, Professor Seema Avasthi, Honorable Dignitaries, Organizing Chairperson Professor Seema Avasthi, Organizing Secretary Dr. Santosh Kumar, Resource Person, participants, a very good morning to all. The memories of 2019 November are still fresh when we were gathered at JNMC&RC Aligarh. The weather was amazing, winter has just started, and beautiful and vibrant flowers are blooming over the garden of the Sir Syed. Everybody was full of joy and gaiety and enjoyed the academic and cultural feast to the fullest. And little did we anticipated that we were about to face the darkest time of our life, the difficult year of 2020, when we decided to declare it as a null year due to pandemic. During those challenging 15 months of the pandemic, the large number of pupils are died off, including our near and dears. Medical fraternities suffered a lot too, and we lost about 800 doctors apart from nursing and paramedical staff. My heartfelt condolence to all of them, with the hope and prayer that we'll face no such type of calamities in future. But as every dark cloud has a silver lining in it. This pandemic opened a new avenues and taught us innovative online mode of teaching and training. We organized and attended so many seminars on online mode, CME and conferences, right from the comfort and safety of our life at our home. And our UP chapter annual conference is one of them. This is being organized online this year to ensure our utmost safety. We have a rich lineup of sessions and wonderful speakers spread over 2 days schedule. Major systems like breast, heart, lung, hemopoietic system will be covered by excellent speakers, and I request all of you to attend each session with concentration and get benefited from the deliberation. I am sure that participants are also looking forward to attend the session of scientific writing by Professor Vatsala Mishra, and this will help them a lot in enhancing their writing skills and publishing their scientific work. The UP chapter is also a nice platform for the young and budding pathologists to present papers and poster and get opportunity for the sharp mind to showcase their talent in the quiz. My best wishes to all of them. I congratulate the organizing committee of UP-PATHCON 2021 Department of Pathology, Teerthanker Mahaveer Medical College, for working so hard and putting so much effort in organizing this academic feast in online mode. Really, it is very tough to organize such type of conferences, but I am sure that pain taken by the organizing secretary and chairperson Professor Avasthi and his whole team will be worthwhile. I wish them all success, and I pray that the event will be a huge success. Thank you.
Next, we request our respected President of IAPM, Dr. Vatsala Mishra ma'am. We are privileged to have you with us, ma'am. Kindly grace the occasion with your wonderful words.
Good morning, everyone. My good wishes to Honorable Chancellor, Mr. Suresh Jain, Honorable Vice Chancellor, Professor Raghveer Singh, President UP Chapter, Dr. Arif, Joint Secretary IAPM, Dr. Haren, Secretary UP Chapter, Dr. Prajum, Principal TIMU, Dr. Shamoli Datta, then Organizing Chairperson of this conference, Dr. Seema, and Organizing Secretary of this conference, Dr. Ashutosh, and all other team members and dignitaries of TIMU. It is my proud privilege to address you all in this conference, which has been organized by Dr. Seema and her team on a very short notice. Now, as you all know, keeping abreast with the recent advances is very important for all of us, especially the young budding pathologists and our postgraduates. As we can see that for last 1 year, due to this unfortunate corona pandemic, all these conferences and CMEs were put to a halt. And due to this, there was a decrease in the scientific activity. But now, with the control in the pandemic, we have again come back. We are here together to present our work. Our PGs and budding pathologists have chance to present the abstract and also get acquainted with the work done in other medical colleges, other parts of the state, and also at the national and international level. A good list of expert speakers is there in this conference who will share their work done in various fields, and I hope all the delegates will benefit extremely by their expertise in their subject. Now, it was a very short span of time which was given to the organizing team, but I am happy to see that there is a tremendous response in the abstract submitted and the number of registrations done for this virtual CME. And that shows that we are all keen to learn and make ourselves abreast with the advances in our field. And therefore, this virtual platform is going to give them all a good exposure to various changes made and recent advances last 1.5 years. So without taking much time, because there is a long academic program waiting for us, I will like to once again congratulate the whole team of TIMU along with Dr. Seema, Dr. Ashutosh, and a large number of those who are working behind the curtain for a grand success of this conference, and hope that all the delegates who have registered for this conference will immensely benefit from this excellent virtual conference organized by the team of Teerthanker Institute of Medical Sciences. Thank you, and thank you all.
Now, we request our respected Dr. Harendra Sir, Joint Secretary IAPM. We are fortunate to have you with us, sir. Kindly grace the occasion.
Honorable Chief Guest, dignitaries on dais, and dear delegates, on behalf of IAPM, I welcome you all to the annual Pathology Conference of UP Chapter, UP-PATHCON 2021, which is being organized by Teerthanker Mahaveer Medical College, Moradabad. I sincerely thank organizing chairperson Professor Seema Avasthi for inviting me to speak in front of you. I hope this conference will be very useful to all delegates, especially young postgraduates. As a Joint Secretary of IAPM, I would like to request all delegates to be a life member of IAPM along with the state chapter. Postgraduates should be encouraged for regular oral and poster presentations at various platforms. Let me inform you that few state chapters of IAPM are doing extremely well by conducting regular academic activities. So I request UP state chapter executives, all HODs and faculty members present here to do more academic programs in future for the betterment of postgraduates and everyone. One more thing I would like to inform you all that voting for IAPM elections for the post of President, Vice President, Editor-in-Chief elect are open from 28th October to 31st October midnight. All life members, I repeat, all life members are requested to cast their votes. At the end, I wish the organizing committee of UP-PATHCON 2021, a grand success of this conference. Thank you all. Jai Hind.
Next, we welcome respected Dr. Pradyuman Singh Sir, Secretary IAPM. Kindly share your thought about the occasion, sir.
Good morning, ladies and gentlemen. Honorable President, IAPM, Professor Vasla Mishra, Editor-in-Chief, IJPM, Professor Ranjan Agarwal, Joint Secretary, IAPM, Dr. Harendra, President, UP Chapter, IAPM, Professor S.H. Arif, dignitaries on dais from Teerthanker Medical University, Honorable Chancellor, TMU, Honorable Vice Chancellor, TMU, Principal, TMU, Organizing Chairperson, Professor Seema Avasthi, Organizing Secretary, Dr. Ashutosh Kumar, respected guest speakers, faculty, dear delegates, and members of the organizing team. On behalf of the executive body of IAPM UP chapter and my personal behalf, I extend a warm welcome and express my gratitude to all attending this 28th annual conference of the UP chapter of IAPM, that is UP-PATHCON 2021, being organized by the Department.
Now, we request to grace the occasion by a respected Vice Chairman, Sir, Shri Raghuveer Singh, Sir.
ये पूरा ऑनलाइन चल रहा है कि वहाँ भी कोई है?
It's a matter of great pleasure that Teerthanker Mahaveer Medical College and Research Center is organizing UP-PATHCON 2021, the 28th annual conference of IAPM UP chapter on October 30 and 31st, 2021. The knowledge of pathology and microbiology is crucial to the understanding of the mechanism of disease formation. I congratulate the organizers for their assiduous efforts in providing the platform for this interaction through UP-PATHCON 2021, in which the renowned experts and researchers are going to be ponder over the intricacies of the conference theme. I convey my best wishes to the success of this conference.
Next, we request our Honorable Chancellor Sir, Shri Suresh Jain Sir, to enlighten the occasion with your delightful words.
नमस्कार, मैं सुरेश जैन, चांसलर तीर्थंकर महावीर यूनिवर्सिटी मुरादाबाद, IAPM यूपी चैप्टर के 28वें वार्षिक सम्मेलन के उद्घाटन की घोषणा करता हूँ। इस सम्मेलन का आयोजन तीर्थंकर महावीर मेडिकल कॉलेज के पैथोलॉजी डिपार्टमेंट द्वारा 30 और 31 अक्टूबर 2021 को किया जा रहा है। तीर्थंकर महावीर मेडिकल कॉलेज मुरादाबाद कमिश्नरी एक बड़े 5 जिले जो इसके अंतर्गत आते हैं उसके स्वास्थ्य की चिंता करता है, उसके स्वास्थ्य का इलाज करते हैं हम लोग, और साथ ही क्वालिटी ट्रीटमेंट देने का भी प्रयास करते हैं।
अंग्रेजी में सारे यही पीते हैं,
सम्मेलन
अंग्रेजी में जो है
क्षेत्र में
यही पीते हैं।
तमाम प्रतिष्ठित विद्वानों और वैज्ञानिकों के साथ जो जानकारी उपलब्ध होगी और उसे जो जिसको सुनने वाले और देखने वाले डेलीगेट्स को जो उसमें उनका ज्ञान वर्धन होगा और जो उनके विचारों का आदान प्रदान होगा, वो सभी को एक उत्कृष्ट मंच प्रदान करेगा और लोगों को काफ़ी जानकारी हासिल करने का मौका मिलेगा। मैं सभी वक्ताओं और डेलीगेट्स का तीर्थंकर महावीर यूनिवर्सिटी की ओर से उन सबको बहुत बहुत शुभकामनाएं देता हूं, उन्हें आशीर्वाद देता हूं उनके अच्छे भविष्य के लिए। और इस सम्मेलन की ऑर्गेनाइजिंग चेयरमैन डॉक्टर सीमा अवस्थी जो डिपार्टमेंट में प्रोफेसर एंड हेड हैं पैथोलॉजी में, और उनके सेक्रेटरी जो डॉक्टर आशुतोष कुमार हैं जो प्रोफेसर हैं इसी डिपार्टमेंट में, उनको भी बहुत बहुत बधाई देता हूं और उम्मीद करता हूं कि उनके द्वारा जो ये प्रयास किए जा रहे हैं इनके बहुत अच्छे रिजल्ट्स आएंगे। और जो IAPM यूपी चैप्टर के 28वें वार्षिक सम्मेलन में के जो लोग भी यहाँ आए हैं उन सबके अच्छे भविष्य की कामना करता हूँ और इस आयोजन के सफलतापूर्वक समाप्त होने की शुभकामनाएं भी देता हूँ और आशीर्वाद भी देता हूँ। नमस्कार।
Now, I must appraise and would like to comment the extreme effort and hard work put in by our organizing secretary, Dr. Ashutosh Kumar sir, who put his heart and soul into making this event possible. Sir, please share your thoughts with our delegates.
Warm greetings to all the esteemed delegates on this academic feast of PATHCON 2021, the annual conference of IAPM 28th. I feel privileged to extend the vote of thanks on special day on behalf of the organizing team to all of you, without whose kind support this conference could not have been possible. Any event of such magnitude with close to 500 participants, that too in a completely new online platform, needs meticulous planning and support from all corners to make it a success, and we are thankful to each one of them. I will beg your pardon if I miss on some of them. Let me first start by giving glory to Almighty for making today's event a resounding success and keeping all of us healthy and fit to interact with each other. Words may not be capable of communicating our deep sense of gratitude to our chief patrons, Honorable Chancellor Sir, Sri Suresh Jain Sir, Honorable Group Vice Chairman Sir, Sri Manish
तो हमारे लैब से तो बस वही 2 आदमी का जाता है,
member
एक को तो आदमी
governing
कहा
body
है
of TMU. Without whose
मान
support,
का
such an event would not have been possible. Chancellor Sir, thank you for blessings as our chief guest. May their blessings continue to lighten our path and inspire us for the future endeavors. We are thankful to Honorable Vice Chancellor Professor Raghuveer Singh Sir for accepting our invitation as guest of honor, sparing his valuable time for this CME. Sir, your presence has truly glorified this occasion. We also extend our heartfelt gratitude to Director Administration Sri Abhishek Kapoor Sir, who despite his busy schedule is always available for us in all possible ways possible. Sir, we are obliged to you. We feel privileged and thankful to our governing body IAPM UP chapter, particularly Dr. Pradyuman Singh Sir, for trusting us and giving us the opportunity to hold this event for the second time. The credit for which goes to none other than our own principal madam, Professor Shamali Teerthanker, our ex-HOD, whose experience as organizing president in UP-PATHCON 2012 was always there as a constant light to drive us through. We are sincerely thankful to entire governing body of IAPM UP chapter led by Professor S.A. Arif Sir as the president. It is indeed a proud moment of Uttar Pradesh that 3 of the office bearers from our own state, Dr. Vatsala Mishra Ma'am, President IAPM, Dr. Harendra Kumar Sir, Joint Secretary IAPM, and Dr. Ranjan Agrawal Sir, Chief Editor IJPM, our own reputed journal. Ranjan Sir, we are particularly thankful to you for always being there to solve very basic to complicated problems. Sincere thanks and sorry to keep you disturbing at every stage of preparation. We are also thankful to Medical Superintendent Professor Ajay Pant Sir and Vice Principal Dr. S.K. Jain Sir for taking out their precious time for the event and supporting it wholeheartedly always. We would like to extend our warm regards to guest speakers from different reputed institutions across India who have kindly agreed to enlighten us with their kind words and wisdoms. We are sincerely thankful to you, all of you, sir and ma'am, for taking out your valuable time for this academic feast. Behind any successful event, there is guiding light, and we are fortunate enough to have such an active and dynamic team leader, Dr. Seema Awasthi, ma'am. Thank you, ma'am, for trusting me to be part of this event as an organizing secretary. Your personal attention to all the intricate details made it a success. Last but not the least, we are lucky to have a team of dedicated and highly motivated colleagues, residents who shared our responsibilities and worked tirelessly to make this event a reality. So a loud cheers to the team PATHCON 2021. The scientific committee led by Dr. Fayaz Ahmed and Dr. Rashmi Chauhan have been working tirelessly so that the delegates can present their scientific papers and posters in a completely new platform in a seamless manner, that to a huge number of them. The souvenir committee led by Dr. Rajneesh Sir Kumar sir and Dr. Deepti Arora have always been on their toes all the time so that the souvenirs are ready on time for all the delegates. I am thankful to Dr. Ankita Mittal, Dr. Vivek Singh and Dr. Prachi Singh for taking up the responsibility as treasurer, registration and coordinating the inauguration and many other roles which were given to them. Last but not the least, I would like to thank the real workforce behind the event, our postgraduates students. Anamika, Nishant, Akanksha, Ariba, Faiza, Neha, Gunjita, Nilisha, Pooja Jain and Pooja Gupta, whose role was amoeboid, that is filling into any role just like an amoeba. I am also thankful to Mr. Anul Tandon, our Assistant Registrar for Efficient Communication with UP Medical Council, which granted us 6 credit hours. I am very thankful to our background workforce website team led by Mr. Akash, designers Sakshi, Nazar, technical support by Mr. Vaibhav, Mr. Bhupendra, our office support Mr. Umesh, Mr. Alok, Mr. Chandrasen and photography unit. I am also thankful to media and print. In the end, I would like to add a quote by Cicero. Gratitude is not only the greatest of the virtues, but parent of all others. And I am sincerely grateful to all of you. Thank you.
Shortly, we will be resuming our first session of the day. With this, we have come to an end of our inaugural ceremony. I request everyone to stand up for the national anthem at their respective places. Now, we begin with the academic session of the day. First, to chair the session, we would like to introduce our first chairperson, Dr. Madhumati Goyal, ma'am.
Am I audible? Hello?
Yes, you're audible.
Thank you for calling me to
Dr.
chair this
Madhumati
session.
Goyal, ma'am, Director, Pathology and Laboratory Medicine, Vedanta, Lucknow. Ma'am has served institution as faculty since 1983 and superannuated in November 2019. During her long tenure at TMU, she has also served as Pro Vice Chancellor, Professor and Head, Department of Pathology, and Dean College of Nursing, and is an honorary librarian. She has a long teaching, research, and diagnostic experience of 39 years in histopathology, cytology, immunohistochemistry, and molecular pathology. We welcome you, ma'am. Now, I would like to request our second chairperson, Dr. Uma Shankar, sir.
Hello. Hello. Can I be listened?
Yes, we can hear you.
Yes. It is very nice to see Professor Nuzar and also
Professor and Head of Department, King George Medical University, Lucknow. Sir has done MBBS, MD from King George Medical University. He is a scientist fellow, ITRC, Lucknow from January 1989 to September 1990. Sir is in charge of histopathology, cytopathology, and molecular pathology. Sir has credited 50 articles till date. He had also given his precious time for research projects. Sir has areas of interest in histopathology, cytopathology, and molecular pathology. Now, we request you, sir and ma'am, to kindly introduce our first speaker for this session, Dr. Nusrat Hussain, ma'am. We welcome you, ma'am.
So can I start? So at the outset, I will like to thank the organizers, especially Seema, Dr. Ashutosh, and other members of the organizing. Am I audible? No?
Yes, you are. Yes, you are.
Okay. So before wasting much of time, I will, though Dr. Nusrat Hussain does not need any introduction for this August audience, but it is customary to tell something about the speaker. So I'll continue. I will tell that she has been very good. So no doubt about it. She has done MBBS from Jain Medical College, AMU, graduation from Aligarh, and then MD from KGMC. She is a professor and HOD currently at Ram Manohar Lohia Hospital, Institute of Medical Sciences, and she has served as Dean, Professor, and Director of the same institution. She also served as postdoctoral fellow in Molecular Neuro-Oncology Unit, Massachusetts General Hospital, Harvard, Boston. She has given her precious time in research work related to neuropathology, frozen sections, GI pathology, lung pathology, and so many more areas. She has more than 283 publications under her name, and not much to say, and I'll not waste anybody else's time, and I'll give the mic right directly to Dr. Nusrat. And you know, all of us love her. So, Dr. Nusrat, please. Unmute, please, Nusrat. Dr. Nusrat, please unmute.
So thank you very much for your warm introduction. It's always a pleasure to see you, whether online or otherwise. Hello, Dr. U.S. Singh, and all participants here. And thank you so much, Seema and her entire team for inviting me. And it's really a pleasure always. We are a family as the UP-PATHCON group. So being on the UP-PATHCON group always gives you extra pleasure to be speaking here. So hello to all the delegates. I have been with you since the morning and I've been listening to the presentations that you have made. I think it's really excellent that the work you've done, and I'm glad that the UP-PATHCON gave you a platform to present them. And the discussions were also wonderful. I must congratulate Ranjan and everybody else who was there as chairpersons at that point. So without much ado, let me start with the topic for today is post-chemotherapy, post-neoadjuvant chemotherapy breast cancer evaluation, the pathologist perspective. So with so much advancements in therapy and changes that are going on and the need for the reduction in the tumor size prior to operation in the interest of the prognosis of the patient, we now have a lot of patients who are coming after any form of therapy. We call it neoadjuvant chemotherapy when it is given before surgery, but also now radiation is also given to the patients. So basically, as a pathologist, you are going to expect some changes in the breast that are going to occur because the patient has undergone treatment. So the protocol basically is to do a core biopsy before.
So will you share your screen, Dr. Nusrat?
Yes, I'm sharing it.
So we can't see it.
Not able to see it? Okay.
No, it is visible. Dr. Madhumati, you go to the option, view options in the above panel and click on Dr. Nusrat's screen because two screens are simultaneously shared. Go above on the screen, view options, click on the view options, and then you will get two options, Teerthanker and Dr. Nusrat. Click on the Dr. Nusrat, then you will see the slides. Slides are very well visible. They are there.
I still can't see. I'll
Two
just see.
options. If your Zoom screen go above, it is you are viewing screen Teerthanker aa raha hoga, side by side, see view options. Click on that. Then click on that. On that scroll, there are two options, Teerthanker and Dr. Nusrat. Click on Dr. Nusrat, then you can see her screen will come. I think someone, Ashutosh.
Thank you, Dr. Vatsra. Thank you.
Yeah, I think
so maybe, you know, the organizers, can you pin the screen of the speaker, then it will show up.
Yeah. Because till now two screens were functional, so there are shared screens. One is Dr. Nusrat, another is Teerthanker. And then you can see it, Dr. Madhumati.
Sorry, I'm not still able to do it. I'm sorry.
Screen of Teerthanker is open on your screen.
Now I can see Dr. Nusrat's screen.
Yes,
okay.
Yes.
Okay, thank you.
Okay.
So basically, before they go in for a neoadjuvant therapy or an anti-HER2 therapy, whatever is part of that therapy, it's mandatory that a core biopsy is done. And in this core biopsy, an ER, PR, and HER2 estimation, or if AR or any other markers are required for the purpose of therapy, those will be done in the core biopsy. Subsequently, the patient will get the neoadjuvant chemotherapy, which may be either in the form of the paclitaxel or the docetaxel, or sometimes they also use the carbos, like the gemcitabine and others. And then the trastuzumab is given wherever you give a positive HER2, and where the endocrine markers are positive, you can give an endocrine therapy. And then subsequently, this patient comes back to you again with either a
Dr. Seema, please tell
lumpectomy or a
someone
mastectomy.
to stop the background noise.
So the patients then come back to you.
knowledge होगी तभी वो खुश कहेंगे HOD बन के बैठी है. काश तुम भी जो है HOD बनो.
May I request all the audience to please mute yourselves, please? Thank you. Thank you. So subsequently, then you get back either a lumpectomy specimen if the tumor has been downgraded. And also to mention here is that most of these neoadjuvant chemotherapies are usually given in a stage 3 disease. So the type of response that you can assess as a pathologist would be either you have a minimal or no response, get a partial response. And you can note here either the tumor shrinks entirely in size on its own, like concentrically, or you can get like focal areas in between which have responded, and then the tumor appears like a fragmented, separate fragments of tumor when you're analyzing it, or they can be a complete response where no tumor is there after therapy. So let us first go to this case number 1, which is a 49-year-old woman with a palpable mass in the right breast. Now, this was an ill-defined mass with calcifications, and let me reduce this, okay? So with calcifications, and you can see here that the lymph nodes were also enlarged in this patient. So this was the core biopsy, and you can see a pretty high-grade sort of a lesion which is present here, definitely a breast carcinoma. And this was HER2 positive, but ER and PR were negative. Those were the axillary nodes, and they were also positive. So this was a poorly differentiated breast carcinoma, and subsequently after therapy, neoadjuvant therapy, the mastectomy specimen that was received showed in the tumor a residual DCIS with no invasive cancer. You'll have to take my word for it because, of course, as I'll show you later, an extensive sectioning of that tumor bed is done, and then subsequently you have to evaluate that. And that's the node which is showing you treatment effect with fibrosis, but no residual carcinoma. Of course, this will again needs to be studied in detail. You have to take my word for it right now. So my question then to the audience would be, you can put it in the chat box, your response, as to whether you would grade this as a partial response, or whether you would call it no response, or you would call it a complete response. So as per the post-treatment staging, this would be a PIS because you've just got an in situ component, and nodal would then become 0 because none of the nodes are showing you tumor. So anybody wants to respond here? All right. So this would then go under a pathological complete response. So this is one take-home point that I want to give you today, is that even if there is DCIS which is remaining after therapy, this goes as a complete response. Now, there is always a reasoning behind things. So the take-home point here, it's a complete response, DCIS is allowed. There is always a reasoning behind things, and this is like a huge trial which was done on more than 6,000 cases of breast cancer. And it was seen here that the trend of both the cases, whether they had DCIS or they had like a complete response, the survival trend was similar. And hence, the presence of DCIS alone is taken as a complete response. The question then arises is that which are the tumors which are most likely to respond to neoadjuvant chemotherapy? So upfront, you would like to, obviously, when you're diagnosing and for the purpose of the patient would prefer to have a luminal type A tumor. But then the ones that actually respond more to therapy are the poorly differentiated ones, the hormone receptor negative ones, and the HER2 positive ones. So if you actually look at a complete response, a pathological complete response in luminal A, it usually occurs in less than 10% of tumors. Whereas in a triple negative carcinoma, which prognostically would be like a really aggressive tumor, you actually get a response, a complete response in about 20 to 45% of cases. So multiple systems of assessing residual disease in cases have been assessed, and these are like the ones which I guess we should be familiar with the names, at least for the purpose of the residents and for those who are following whichever system. So this NSAB trial was using a system where they were just putting into 3 categories, where they said a complete response, a partial response, or no response. Then the Miller-Payne system graded the response into 5, and the cutoffs here was grade 1 as no change. Less than 30%, between 30 to 90%, more than 90%, and then no change at all in the tumor status. The Chevalier method is different from the others in the sense that it gives a class 1 and a class 2. wherein complete disappearance of the tumor goes into class 1 and presence of DCIS goes into class 2. So this is the only tumor, the categorization system which puts DCIS into a separate category. The Satterloff method was good and followed for quite some time for the reason that it was taking into consideration both the tumor and the nodes. They did not use a 1, 2, 3, 4, but they used an ABCD, and their cutoffs were less than 50 and more than 50 for grading B and C. And then A, of course, was near total therapeutic effect and B was no therapeutic effect. Similarly, in the nodes also, they divided them into A, B, C, and D. This RCB system, actually is having a problem. So get my charger. Just one second, if you'll excuse me 2 minutes. Okay, sorry about that. So again, here when we compare So when we compare these systems here and the scoring in the breast, if you see, there is the correlates here with the core biopsy. An ideal situation, I would think, is that you have the core, you have the subsequent tumor, and you compare what is the change that is occurring from the core to the tumor. But only 2 of these systems actually advise you to look at the core and then compare. One of them is the Miller pane and the other one is the Pinder. The lymph nodes are included in the Chevalier and Satterloff, as we said earlier. And the Chevalier is different from the others in that it is also okay. So the Chevalier is different from the rest in that it's also using a separate category for the DCIS. The post-chemo reporting in the CAP system, I guess you've all seen it. It again categorizes, asks you to mention this particular sentence for the breast and for the lymph node separately, wherein you say whether present there. And in the lymph nodes, again, you have to mention whether the patient has got surgery or not, and subsequently to mention what the response is. We will be getting into the details later. So here I would like to, it's a pretty busy slide here, and I will try to magnify the areas that I want to show you. And so basically what you're looking at is whether there is a residual tumor or there is no residual tumor. And for that, you need to identify the tumor bed. The methodology for identifying the tumor bed, not all of us are lucky enough in India to have surgeons who are putting clips initially, but then you should learn to recognize the site of the core biopsy. And if you're able to identify the site of the core biopsy microscopically, you will be able to see whether around that core area, which was positive earlier, the tumor is present or it's not present. And then, of course, there are methodologies of gridding and cutting up, which we will get into. The residual tumor can be assessed both on gross, whether it's present on gross, and whether it's present microscopically. We need to also understand is how this tumor disappears. I think you made me the host also, so I have to admit all the people who are joining in. Can you please look into this and allow screen sharing to the other speakers instead of making them the host? Okay, so can you hear me?
Yes, ma'am, we can hear you.
Okay, sure. So coming to the gross sampling of the specimen for the breast, when you're getting small specimens, you have to submit them entirely. When they are large, different people advise differently. What we are following is the RCB method out here. And what we do is a large cross-sectional area of the largest part of the tumor taken entirely across. And we then section like grid it and section ABCD across that. Then Provisano says that you should actually full face the pre-treatment area and take one block for every centimeter. And the FDA again approves a block per centimeter of the pre-treatment tumor size that was available. So the histologically, the tumor bed, how do you identify it? It will show you fibrosis and elastosis. There will be prominent vasculature there and few or absent normal epithelial structures. So if you are seeing a normal breast parenchyma, this is probably not the tumor area and the tumor bed. Then inflammation like histiocytes and lymphocytes and giant cells can also be seen. And hemosiderin will be noted, especially around the, if you want to look for the area where the core biopsy was done. And
Ma'am, kindly please share your screen.
Microcals will be present in the area of the tumor bed. So there needs to be a standardized way in which to assess and report the amount of residual carcinoma following neoadjuvant therapy. And this is the whole purpose of the lecture, is to come to a consensus as to how we should assess these post-chemotherapy specimens. So there will be 3 points under which I'll be discussing this. One is when do you call it a complete response pathological versus residual disease, and how do you categorize that? Then the TNM staging using the AJCC, how does that change? And then the residual cancer burden as per the MD Anderson protocol, how do you get to assess that? So what you need to be in good sync with your surgeon, and there should be a proper prerequisition form for the neoadjuvant specimen, and the pre-treatment location of the tumor, preferably the location of the biopsy site, exactly where they've done it, and the previous report should be available with you.
Ma'am, sorry to interrupt you. Please kindly share your screen.
Shared. Okay, I think change the host. That's fine. Okay, doing it now. Yeah. Okay.
Thank you, ma'am.
Done. Okay, so that's the format in which you would want your report to be, your pre-treatment for the forms to be filled up, and you definitely want a location. You want to know whether deep calcifications were present, whether any clip was inserted, and whether any ink has been used for marking. The specimen, of course, as we all know, should be oriented, especially if you are looking at a lumpectomy specimen, and even mastectomies, I feel, should be oriented. And then in the post-treatment, what kind of treatment the patient has got, what is the protocol that has been followed. Those are details which you should ask for as a pathologist. So the gross identification is the most important step. And you can see here that this is a lumpectomy specimen which has been well inked. And so you have your standard colors for the different margins, and you do the colors because that helps you know exactly where. And here you're seeing that this is the tumor and the tumor bed around it. And then there's a lot of adipose tissue. This is sort of an eccentric tumor, and this is where you would want your margins also taken very properly. So again, here you can identify this is the extent of the tumor bed, and this area is actually the area where the likely viable tumor is present. So even on gross, you can make out whether the viable tumor is present or it's not. It's like, even in this specimen, you can make out here that there's a viable tumor, and the rest of this is your tumor bed. So this entire extent is the tumor bed, and likely viability is present here. Okay, so sometimes what can happen is you can have multiple tumor beds also. And, like in this specimen out here, and in between you have a gap. So the bottom line is that between, if you want to call it a multifocal lesion, then there should be at least a 1 centimeter area in between, which should be entirely tumor free and like normal breast parenchyma and not actually the tumor bed. So it is very important, if you're talking of a multifocal tumor, to actually take sections in between also and evaluate these sections very accurately to make sure that you have a breast parenchyma in between and not just a tumor bed with 2 foci of the remnant tumor. So again, a situation here where, this is again ideal, where you are able to do X-rays within the gross labs. And I've seen, like at most centers in abroad, in the US where I've seen them, they actually do a radiology within the gross lab, and then they locate where the wires are put, or if anything else has been marked there, and then those wires tell you that actually you're looking at the tumor bed. So these images also help you in defining the tumor bed. But we have found gross to be able to adequately define it too. And sometimes you can see inserts of the radiation inserts also. Sometimes they're putting these little capsules inside which give radiation. And there your grossing protocol will vary, because then you have to have radiation safety when you're taking out these lesions. So this is how you're going to take a grid of the remnant tumor or the tumor bed. You have to demarcate it, and this is how we take a complete slice of the largest area. You cut your sections on it and you make a drawing or take a photograph, and on the photograph you grid it and you mark the sections that you have taken from various sites, and then you evaluate each and every section separately, and you made the percentage tumor that is present there. This RCB system actually tells you to do either a 1, 5, 10, and then it goes by every 10% up. So 10, 20, 30, 40, so forth, up to 100. So you have to give an approximation of the cellularity like that. So initially when we started using this RCB system in our lab, I'll show you the MD Anderson website. We actually downloaded these pictures of estimate of cellularity and put them up in our lab, so that you have like a comparison visually to see that this is how the 1% or the 10% should look like. Secondly, it's also a good idea to review the core at that point and then see the cellularity in the core, and subsequently you're able to make out what kind of a decrease in cellularity has occurred. So coming to the microscopic identification of the tumor bed, which is of course the best part that we pathologists like doing. So how do you identify the tumor bed? This is a tumor bed with a complete response. You can see here, there's just fibrosis, there's some adipose tissue which is entrapped in between, some breast parenchyma which is there only at the periphery. Most of this tumor bed has got no normal parenchyma, it's just plain fibrosis. Sometimes you can get lymphoid infiltrates and minimal amount of breast parenchyma, and you can get a lot of histiocytes also. So the edge of the tumor, see, this is where you are no longer in the tumor bed. So when you're getting this normal breast parenchyma, this part will not be counted as the tumor bed. So a lot of fibrosis and elastosis you'll get. You can get sometimes sheets of histiocytes and lymphocytes there in the thing. And see here, this is an example of a very dramatic change in the cellularity. So it's a good idea to compare with the core biopsy. And then this is a mastectomy specimen where you are seeing a marked decrease here. So if I saw only this, maybe I would have said like a 20%. But now that I'm comparing this with the core, I can say that this would be like less than 10% of the tumor that is remaining here. So sometimes the other thing we need to remember is that there can be a varied response in the primary versus the lymph node. So sometimes the primary responds completely, but the lymph node continues to have the metastasis. So that is why it's very important to have lymph node as one of the parameters when you are evaluating a response post chemotherapy. Here again, this gets sometimes a little confusing, whether you're looking at sheets of histiocytes or whether you're looking at tumor cells. And in cases like these, or in cases where like these, or where you have single isolated cells, we would like to do an IHC to make sure that this is actually tumor cells. Similarly, mucinous carcinomas will, after response, will show these mucin pools only, like you get in the colonic cancers. And mentioning colonic cancers here, my personal choice is that whenever I see mucin in breast cancer, I always go in to check out whether this is metastatic or not, because primary mucinous cancers in the breast, though they occur, they are relatively less common. And you can also get signatoring cells in the breast cancer, but they are more common in the colon and in the GI sites. And hence it's important to run a 720 and to make sure that you're actually looking at the breast. If you want, you can also do GATA mammoglobin to reconfirm, but just a simple 720 panel sometimes helps, though your mucinous with positive 7 can also come from the gastric. So adding some specific markers there would also help. So this is fibrosis and foaming histiocytes, and then again mucin, and here you can see that very few cells are surviving here in the mucin, and these can be highlighted using a 7, a mammoglobin, or a GATA3. So the chemotherapy, summarizing, the chemotherapy changes that can occur can be a histiocytoid appearance, they can be a cytoplasmic vacuolization, there will be increased eosinophilia of the cells, there will be nuclear hyperchromasia, there will be decreased mitotic activity. Now this is significant because when you do the Nottingham grading, this nuclear hyperchromasia and pleomorphism is going to upgrade your nuclear grade, but the decreased mitotic activity is going to downgrade your mitosis grade. So subsequently, grading Nottingham post chemotherapy usually is not a very accurate Nottingham grading, and literature has different viewpoints there, whether you should or you should not do a Nottingham grading post chemotherapy. But as of now, we do it, but there's always a good idea to compare it with the core biopsy. So the lobular-like growth pattern can sometimes persist after the chemotherapy. Retraction artifacts also occur after chemotherapy. So distinguishing LVI versus a retraction artifact is an important issue there. Then heterogeneity can also occur because of selection by chemo. Exactly, we don't know why, but that frequently occurs there. So frequently when you're doing like your HER2 markers, etc., post chemotherapy, you sometimes get a heterogeneous expression of these markers, and that is an observation. So here we are looking at the chemotherapy change. Why are you muting me? Okay, so again, you can compare the changes in the core biopsy with the excision specimen here, and you can see very few cells are persisting, and whereas the core biopsy has got definitely the entire tumor that is present there. So the residual histiocytoid response can also occur either in the infiltrative cancer or in the ductal carcinoma. So intraductal, if you see a fair number of histiocytes within the tumor, and the tumor cells themselves are giving you a histiocytoid kind of look, then you should query whether this patient has undergone chemotherapy or not. So treated cancers can also show you metaplasia. So like you can see here, some squamoid changes. So this can also be related to chemotherapy. Very large, bizarre nuclei can be present. As I told you earlier, your Nottingham grade sometimes get kinds of upgraded as far as the nuclear grade is concerned. You get plasmic vacuolization because of the tumor. And then these isolated tumor cells will show you a lot of eosinophilia and pycnosis of the nuclei, and they might be hard to identify in the section, and consequently it's important to run your CK7 or your GATA3 and mammoglobin to identify these. A CK7 alone is usually a good one because pan-cytokeratin, I don't know, I feel very doubtful about, because pan-cytokeratin also sometimes stains histiocytes because they have phagocytosed the keratin there. And so the sensitivity of the pan-cytokeratin is a little not, the specificity is not too good. So I prefer to use a cytokeratin 7 to highlight the remnant tumor cells. And also, if your tumor is ER positive and ER is a good cell, you would have to do it subsequently in the tumor. So ER also is a good marker to highlight your tumor cells. As I said earlier, sometimes a lobular component or the LCIS may get left behind. We know we don't in the new classification now divide these up separately, but it's always good to remember the morphologies and to remember that they can coexist in the same tumor or separately, and that they may persist after the chemotherapy. So coming to the, so that was the evaluation histological of the complete response. You have to do like a grid sectioning of the entire tumor bed in one plane, and also take sections separately from different areas of the tumor. And then you evaluate every section to look for the percentage decrease. You subsequently total up the percentage decrease, take out an average, and you know how much cellularity has decreased in the tumor. You measure the size of the largest tumor, that is of the largest tumor bit that is present there. So if it is a multifocal tumor, the largest tumor area is what you will measure under the microscope. And for those residents who are here, it's like a very, very approximate thing is that if you are in LOPAR, you are looking at like 4 mm of tissue. So if you do like scanner fields, one after the other, you can approximate as to, you know, what could be the length of this tumor that you are dealing with in the highest dimension. Also, you have to understand that you have to kind of, because you've got multiple sections, you need to grid them together and measure across. So it's easier said than done, but then of course you can get both in gross and in microscopy an approximate idea of the size of the viable tumor. So coming to the tumor size measurement, as we've discussed, it can be either a contiguous tumor that is present, or sometimes you have like multiple smaller foci of scattered invasive tumor and you have one larger focus. So what you need to do is to measure this larger focus. And in the node also, the RCB system wants you to measure the largest size of the metastasis that is present there. So the node which has got the largest metastasis, you need to measure the size of that metastasis in the node. So as I said earlier, there is a problem with the histological grading, the Nottingham's grading, because there will be a decreased gland formation, there will be increased nuclear atypia, and there will be a decrease in mitosis. And hence, it is a better idea to compare with the pre-treatment core biopsy if necessary. So coming to the controversial scenarios that you can have in reporting breast cancer, the AJCC at the TNM recommends that isolated tumor cells after chemotherapy be called node negative. So if you're getting isolated tumor cells in the nodes, they will be considered as node negative, and this will be not regarded as a pathological complete response. The WHO recommends that isolated tumor cells after therapy be called as node positive. And if there is no associated fibrosis, and you got to treat this as an adjuvant setting, and you call it as node negative. So if associated fibrosis is present, then the likelihood is that there was a macrometastasis which was present there earlier, a micro or a macro metastasis present there earlier, and what you're looking at is a response, and these isolated cells form a part of that response, and hence this would be then termed as positive according to the WHO. So the lymph node status, as you know, either the sentinel lymph node is taken out or the entire lymph nodes are taken out. In our setting, we don't have a sentinel node policy, and all the auxiliary lymph nodes are received, and hence you need to section as many as they give you in a frozen section initially, and then of course section all of them when you're getting the complete resection specimen. So you need to section all of them. You measure the largest metastasis size in millimeters that is present there. And then you number the nodes with the micrometastasis, you number the nodes with the macrometastasis, and you also measure the extracellular, the extranodal extension, and you measure the extent of the extranodal extension again in millimeters. And again, there is a 2 millimeter cross there. So more than 2 extranodal extension is taken as an extensive extranodal spread. So this is how the micrometastasis looks like. So you just have very small clusters, either single or very small clusters which are present. And when you actually look at the HNE, it's kind of hard to say whether these micromets are present. So the auxiliary nodes, up to 40% of these patients, the auxiliary nodes, they convert. I'll try to go a little faster now. I think we are lacking time. And then this is how the response in the node will look like. And sometimes, you know, these tumor cells after treatment, they appear like granulomas, and you might skip them saying that these are granulomas. But if you do an IHC, these actually highlight up. So be careful if you're dealing with a node in which you are suspecting granulomas, and then make sure that these are not tumor cells. Sometimes they look like germinal centers. So if even if you're looking at these very active germinal centers, always have a high index of suspicion for presence of tumor cells, and go in for an IHC whenever you're feeling that this could be a possibility. And then finally, we look at the residual cancer burden. And this residual cancer burden is a methodology of assessing response, which actually makes life easier. It is an online site at the MD Anderson website. And there you need to actually fill in certain parameters there. So this is based on the size of the residual tumor bed. So that bed that you were sectioning in gross as the maximum area where you take a whole slice, which you were gridding, you take a full dimension of that. And then either microscopically or macroscopically, you measure the tumor size. Then in microscope, as I told you earlier in the ABCD and separate sections, you look for the individual cellularity and do a percentage cellular change. You look for the percentage of DCIS which is present in the tumor, and you look for the nodal metastasis and measure the size of the largest metastasis. And this is what the grid out there looks like. You need to fill in all these parameters here. The tumor bed size in millimeters, the tumor size in the percentage cellularity, the percentage of cancer that is in situ. Then you mention the number of positive nodes, and you mention the largest diameter, the diameter of the largest metastasis. And when you press this calculate button here, you get a number here as well as the RCB class, which is there for this tumor. And that's why it's important, and why this RCB system is good. It actually separates out very well prognostically the risk that is there for these individual categories, and it categorizes your groups into the low risk, intermediate risk, and the high risk, depending on the residual disease that is present. And that's how the 5-year survival looks like for these individual groups. And you can see here that it's worse here for the RCP3. So system, so this is what the cellularity charts look like, and you will be able to download them from the website. This is how you need to grid and do the independent area calculations. And you need to count the regional lymph nodes and to measure the size of the metastasis. So these are just some examples to show you that how you can kind of measure the tumor bed size. And so this is how you would have to go across this way, and then you'd have to go across the length. Can you see my arrow? I hope so. And then this is how you will estimate the cellularity of the different fields or the different sections that you are taking. And then you take a mean average and you take a largest focus of the tumor. Suppose for this case, it is 5 to 10%, and the largest invasive carcinoma focus is 1.3 centimeters. There is no residual DCIS, and the lymph node is not showing you any residual tumor, but it's showing you treatment effect. You fill in like that. You give the tumor bed size in 2 dimensions. You give the overall cellularity. You give the in situ disease, which will be 0% here. And then when you press calculate, you get a residual cancer burden figure, and then it also categorizes you into that tumor into an RCB subtype as to 1, 2, or 3. Again, here you can play. We played around with this. We said, let us try to fool the system. So we gave a tumor bed size here, which was like 31 millimeters by 22. We set the cellularity like 0, meaning thereby no invasive residual tumor, but we gave 4% as the in situ disease, and then no lymph nodes and no metastasis there. But you can see here that the system calculates a 0 cancer burden and gives you a pathological complete response. So this is not taking into consideration that DCIS that we have fed into the system. Further, this has stood the test of time, and of late there is a publication. It's a problem with moving the slides as well. Okay, so that's a very recent publication on this RCB system, which is now almost universally followed for prognosticating as well as subcategorizing your response. And this is another recent trial, a very large trial, which is going on different subtypes of breast cancer and their therapy. And this 928 women from this trial, when taken out, it was seen that this RCB, it consistently gives the right prognosis in the subtypes of breast cancer. Because sometimes when you look at these systems, you're like, maybe this particular subtype is getting well prognosticated, but others are not. So this paper is kind of interesting in that it tells us that this RCB system is consistently prognostic within the subtypes of the breast cancer and across investigational and control treatment. So whether you're using the radiation therapy, or whether you're using the Taxels, or whether you're using the Carbos, the prognosis and the response grading seem to match when you're using the RCB system. And finally, the biomarker testing. I mean, should we be repeating the biomarkers in post-neoadjuvant chemotherapy? So there is really no consensus per se in literature on, whether you should repeat or not, but one can reasonably decide, because we know that this was like one of the first few studies which on 83 cases said that the ER, the PR, and the HER2 status changes in 8, 18, and 13% of cases from a pre to a post. Either it can be a gain or a loss. It's not always a loss. And average, if you take in literature, almost ER changes by 13%, PR changes by 21%, and HER2 changes by 12%. This is one study which matched pre and post cases here and showed the highest change of ER at 21%, and HER2 change is the least. So we were concerned whether, this change, how much it's occurring after neoadjuvant chemotherapy, and whether it was occurring at all, even if neoadjuvant chemotherapy is not given. So and the cause of this can be either because of technical failures, or because of intratumoral heterogeneity, or maybe changes due to therapy. So we compared actually 2 groups of almost 100 cases each. one with NOCT and one without NOCT. And we can see here that even in cases which did not get NOCT, there was a discordance almost similar to that in cases which, so we really didn't have a p-value here as far as the change was concerned. So probably the change that is occurring here may be tumor heterogeneity because of technical errors. And I seriously feel that the core biopsies, because they are put immediately into formalin, and they actually have a better fixation, and you tend to get a better positivity in the core biopsies as compared to the resection specimen if they can and may tend to suffer from a cold ischemia, which basically is the time taken from to the fixation. So if you are not kind of using a protocol where, you know, as soon as you get your breast cancers, the mastectomies, you should ideally paint the fresh specimens, dry them, and then cut them up to see the tumor surface. If it's a large tumor, do a couple of series through it, and then put it into a good buffered formalin for fixation. Over fixation is also bad, so you can't leave your specimen hanging around for like 3-4 days before you cross them. So the ideal time in which you should do the processing is anywhere between 6 hours to 48 hours, max 72 hours. So that is a care that we need to take. And then see if your ER/PR and HER2 status is changing, so is your molecular subtype of the tumor. And this is just a graphic expression of, you know, how much molecular subtype can change. So if this was a luminal A in the core biopsy, post mastectomy, this has become 14, or, you know, like 4 of these cases switched to luminal B, and 1 became a triple negative case. So similar in B. So in luminal B, maximum amount of change occurred, and you can see here that a lot of them switched to luminal A, and that's understandable because your KI is going to go down. The least change that occurs is actually in the HER2 positive cases, and also in the TNBC, where, you know, some a fair number of the cases remain as such TNBC, but some of them show change, probably because of methodology issues in the detection. Okay, somebody started drawing. I think I'm going over time. So, so the retesting of markers is not required if you have an initial core biopsy which is positive, because if either of the specimen is positive, you will consider this as positive, and retesting will be required when it is either negative or equivocal core. If you have an outside biopsy or markers, we would like to recheck them out. If there is a heterogeneous distribution or you have multiple tumors, you have both left-sided and right-sided tumors, you have to do it bilaterally. And then if there is no response to therapy and targeted therapy is being given because you have a HER2 positive case and it's not responding, then you might want to retest it. And then finally, if the surgeon asks you for it, you can't say, I'm not doing it. I mean, at least that's not acceptable here. Ideally, you should be able to say that it was positive in the core. We really don't need to do it again. So finally, finishing with this case, which is case number 3. It's a 33-year-old woman with a thickening in the right breast. And on ultrasound, she had a 2.5 centimeter mass, and she also had enlarged axillary nodes, and the core biopsy was performed. So this was her initial core biopsy, and you can see here that there is definitely a carcinoma which is present. So there was a diagnosis there, and then there was lymphovascular invasion identified. She was ER/PR and HER2 positive. She underwent a neoadjuvant therapy using trastuzumab and the hormone markers, and then subsequently a mastectomy and an axillary lymph node dissection was done. And this was her. I want you to now start actively typing your diagnosis here. This is what is remnant in the tumor bed, is what we are seeing here, these areas, okay? Apart from the normal parenchyma, a higher power view of the same, and this is what you are seeing here. And when you do a D240, this is outlined by the endothelial cells. Okay, so either you use a CD31 or CD34 or a D240, but a D240 will actually pick up the lymphatics also. So that's what you'll get here. And this is the lymph node which have got the therapy effect. So what this breast has got, LVI only, and the lymph nodes have a complete therapeutic response. So the question here is that what is the PCR? Is this a complete response because the tumor is remnant only in the lymphatic channels, or should we give this as a partial response? Thought on that, and where would we put this at a staging? I mean, do we give it a PT0 and an N0? So this is one controversial scenario. The presence of lymphovascular invasion in the absence of an identifiable tumor is not to be classified as a pathological complete response. And you will mention that residual lymphovascular invasion is present here, and make a statement about that in your report. You just have to make sure that this is not retracted DCIS. So retraction, as I told you earlier, is a common artifact that can occur. And this is like the common retraction artifact that you can get in cases of post-treated cancer. And then the lymphatic invasions can be checked out by looking at the endothelium, if you can see it nicely here, or you can highlight it using an INC. So my last slide here, you can see that lymphatics are well highlighted by D240, but also please note that there's a smudgy myoepithelial cell staining with D240. So that's finally there, and thank you.
That was indeed a very wonderful session, ma'am. Thank you so much for enlightening us. Now, I request the chairperson to kindly introduce our second speaker of the session, Dr. Teerthanker Singh, sir. Good afternoon. Respected Dr. Teerthanker Singh, sir. Sir is a senior consultant on Anquist Lab, New Delhi. Sir has done graduation from Maulana Azad Medical College with specialization in pathology. Sir has 40 years of diagnostic experience of reporting hematology cases of LN Hospital, Maulana Azad Medical College Complex, and now at Onquist Laboratories for more than 5 years. Sir has established hematopathology section in the Department of Pathology, Maulana Azad Medical College in 1978, which is currently regarded as one of the premier hematology department in our country. Sir has credited 7 books of hematology and pathology. Sir had many chapters in various hematology and pathology books. Sir has credited more than 130 papers in national and international journals on hematology and pathology. Sir has held prestigious position in various Indian associations and institutions, like he was President Association of Pathologists and Microbiologists, past President of Indian Society of Hematology and Blood Transfusion, past Vice President of Indian Association of Pathologists and Microbiologists, and many more. So we are fortunate to have you with us. Kindly start the session.
Hello, good. Am I audible now?
Yes, sir, you are audible.
Okay, is the screen visible?
Yes, sir.
Okay, thank you.
Thank
Good
you, sir.
afternoon, everybody. At the outset, I would like to thank Dr. Ashutosh for inviting me to this August gathering and the UP-PATHCON annual conference. Just now, I heard a lovely lecture from Dr. Nusrat Hussain on a very, very practical aspect where new adjuvant therapy is given in carcinoma breast cases, what morphologic changes occur, and how to pick up those changes. These are beautifully illustrated. Thank you, Dr. Nusrat Hussain. It was a very, very enjoyable lecture.
Thank you, sir.
Uh, Today, I'm going to talk about plasma cell tumors, what we usually call it as multiple myeloma. But of course, there are many more disorders, and these are actually the proliferation of clonal plasma cells. And what they produce is a clonal intact immunoglobulin, but it is not always immunoglobulin. It could be a free light chain, or it could be even a free heavy chain also, something like alpha chain secretion, alpha chain disease. It could be a gamma chain disease also. But all of them, usually we call them as M-band or M protein. That is what you can see in this illustration. This black one is the M-band, which is seen on serum protein electrophoresis. Now, this is one disorder in which we know the pre-malignant condition also. That is MGUS, pre-malignant plasma cell disorder it is. So we'll talk about it later. Now, plasma cell disorders could be two types. One is reactive. Now, reactive are very, very common, and we come across in various chronic infections. And second is a neoplastic. Now, the neoplastic ones, where the WHO has given the name as plasma cell neoplasms. Now, these are neoplastic clonal proliferations with the production of M proteins. Now, what happens is here, where from the cell comes, it is a post-germinal center B cell, which becomes, there are some changes which are occurring, maybe a mutation, and it becomes proliferative, becomes neoplastic, leads to MGUS. MGUS then in turn leads to smoldering myeloma, and finally it becomes myeloma. And then some of the cases may even come into the peripheral blood, and then we label it as plasma cell leukemia. That is the progress. Now it is something like dysplasia, severe dysplasia or carcinoma in situ, and then going on to a frank carcinoma. This is something like what we come across in cervix or some other talk. What I'm going to talk about today is the newer criteria for diagnosis of multiple myeloma. That is one. If there are new criteria where they have given the cell counts, that how many plasma cells should be there, then how do we do the plasma cell count? Third thing is clonality of plasma cells, serum free light chain assay. Now this is a new thing which came up, and now it is a part of diagnosis. Then suppose we have a suspected multiple myeloma case, how do we do the workup? Then of course the peripheral smear and bone marrow findings. And then we go on to the differentiation of plasma cells. How do we differentiate? How do these plasma cells differentiate? And where we should be very, very careful in missing not a diagnosis. Pattern of marrow infiltration, cytogenetics and molecular findings, and then MGUS, smoldering multiple myeloma, and finally the Waldenstrom macroglobulinemia. Now, first of all, coming to the diagnosis of multiple myeloma. Now we know there are three for diagnosis of multiple myeloma. There were major criteria, which were 3. There were minor criteria, which were 4. And the criteria for diagnosis was 1 major plus 1 minor, or 3 minor criteria, which must include 1 and 2. One was 10 to 30% plasma cells. Rather, we used to take more than 30% major criteria as a diagnostic feature of multiple myeloma. Lytic bone lesions, and then we should have M protein, which must be present in all these cases. Now, what are the International Myeloma Working Group? Now, this is a myeloma working group which has been working for about now 25 years, and all the criteria of various gammopathies have been given by IMWG. And what we find is that these criteria have been accepted all over the world. So whenever we are reporting a case of multiple myeloma, we need to go by IMWG classification, their criteria for diagnosis of multiple myeloma. Now, what is the new definition according to them? Clonal bone marrow plasma cells, which are more than 10%. See, earlier Salman Dury said more than 30%, but they said no, they should be more than 10% plasma cells, or biopsy proven bony or extramedullary plasmacytoma. That is criteria number 1. But the plasma cells have to be clonal. Number 2, 1 or more of the following CRAB features, which I'll just tell you. The 1 or more, usually in an advanced stage we may find all the features, but there must be at least 1. And then 1 or more of the myeloma defining events. Now, what are these events? I'll tell you. So this is a new classification, new diagnostic criteria for multiple myeloma. First of all, CRAB. Now, what is CRAB? End organ damage. C is for hypercalcemia. R is for renal insufficiency. A is for anemia. And B is for the bone lesions. So CRAB, there should be at least 1 criteria of CRAB should be present, where we find hypercalcemia more than 11 milligrams, renal insufficiency with serum creatinine more than 2 milligram, anemia with hemoglobin less than 10 gram. But mind you, this anemia should be due to the multiple myeloma disease, not due to deficiency. And finally, the bone lesions, where it should be 1 or more osteolytic lesions on skeletal radiography, CT, or PET-CT. Now, suppose we have a patient where the bone marrow has less than 10% clonal plasma cells. That means it is fulfilling the criteria of clonal plasma cells, but they are not more than 10%. Then what is required is more than 1 bone lesion is required to distinguish it from solitary plasmacytoma with minimal marrow involvement. So this is the criteria which must be there to diagnose a case of multiple myeloma. Then second part was myeloma defining events. Now we also call them as biomarkers of malignancy. But myeloma defining events, now these are 3 of them. Number 1, 60% or greater clonal plasma cells on bone marrow examination. But suppose we have a bone marrow aspirate, we have a bone marrow biopsy. Aspirate shows 30% plasma cells. Biopsy shows more plasma cells. In that particular case, we should take the higher value, whether it is on aspirate or it is on biopsy. Another point we have to keep in mind is that the plasma cell distribution is not uniform in the marrow. You may find microaggregates, you may find uniformly distributed, or you may find that there are some clusters in one part of the marrow, then 6 spaces are unaffected. Again, there are foci of myeloma cells. So all those factors have to be kept in mind before we label a case as multiple myeloma. Second is free light chain ratio. Now, this part was not there earlier, but now it has become an integral part of the definition. That is a free light chain ratio of 100 or greater. That means we have 2 free light chains. One is kappa, the other one is lambda, which form part of any immunoglobulin. But since it is a clonal disease, it is a clonal plasma cells. So depending upon, it could be a kappa or it could be a lambda light chain. So suppose there is a case of kappa plasma cells or clonal plasma cells. So they are going to secrete kappa light chains. Since they secrete kappa light chains, the lambda remains the same. And they may become in hundreds or thousands milligram, resulting in a ratio of kappa over lambda is going to be more than 100. So, but the involved chain must have at least 100 milligram per liter. Now, these are the criteria for diagnosis of myeloma defining events as far as the free light chain is concerned. And then the radiographic evidence, more than one focal lesion on MRI, which is at least 5 millimeter or greater in size. Now, with all these criteria, what has happened is with these myeloma defining events, cases of smoldering multiple myeloma, which were going to myeloma in a short period of time, but they had one or two of these biomarkers or myeloma defining events. Now they are included under multiple myeloma. So the cases of multiple myeloma has increased. Cases of smoldering multiple myeloma has decreased. Now the latest thing is the presence of at least one of these markers is considered sufficient for a diagnosis of multiple myeloma, regardless of the presence or absence of symptoms or crab features. That means even if none of the crab feature is present, but we find that one of the myeloma defining events is present, that will be taken as a case of multiple myeloma. Suppose we have a case where we find that the kappa free light chain is 300 milligram. The ratio is more than 150. Plasma cells are there, but they are not greater than 60%. Lesions may or may not be there. Still, it will be labeled as a case of multiple myeloma. So these are the new myeloma defining events on the basis of which we can define a particular case as multiple myeloma. Now the question comes, plasma cell count, because for definition of multiple myeloma, plasma cells should be more than 10%. Now this is a case where we find that there are 7 or 8 plasma cells are seen in this particular field. See, the number here may be 15 or 20% in 100 cells. On the other hand, what we find is that almost all the cells with few neutrophils, the rest of the cells are all plasma cells of varied differentiation, intermediate to immature differentiation. So the count on the biopsy is higher as compared to the count on bone marrow aspirate. So for plasma cell count, we'll take the higher count into consideration in defining the multiple myeloma. How do we do the plasma cell count? Is HND sufficient? No. HND is not sufficient because well-defined plasma cells where the morphology is clear will be readily made out. However, there are some cells where if the section is thick, we may find some lymphocytes superimposed, some normoblasts superimposed, then it becomes difficult. So what is needed is, if we really want to do plasma cell count, then we must use CD38 or CD138. Now this is one CD138 slide where you can see the plasma cells are very well defined. You can count the various nuclei, which will be, of course, the total cells, and then these positive cells have to be counted, and then we calculate the percentage of a particular area, that this is the number of the plasma cells is 40%, 50%, or 60%. So the plasma cell count should be based on CD138. Now, second part is that the plasma cells should be clonal. Now, how do we make out that those are clonal plasma cells? For clonal plasma cells, these plasma cells will either be kappa positive or they will be lambda positive. Suppose they are kappa positive, as in this field. Now, kappa stain is a cytoplasmic stain. It is not a membrane stain. So you will find each plasma cells in the cytoplasm can made out that it is brown in color, and these are all kappa positive. But then if these are all kappa positive, then on lambda stain, they should all be negative. So the lambda will be negative, kappa will be positive. However, one of the ancillary or supportive evidence is CD56. Now, CD56 is a membrane stain of the plasma cells, and this is positive in neoplastic plasma cells, while it is negative in cases of reactive plasmacytosis. So for clonality to establish, what we have to do is immunophenotyping. One, by immunohistochemistry, as all of you are doing for histopathology, or you can even do on flow cytometric analysis. So the clonality of plasma cells should be established whether it is kappa or lambda restriction, either by flow or by IHC, and finally by immunofluorescence. First two methods are commonly used all over. Then bone marrow plasma cells, if they are less than 10% plasma cells, as I told you, then we must have more than one lesion on CT or on PET-CT or on radiography to distinguish it from solitary plasmacytoma. Now, that is how we establish the clonality of plasma cells on immunohistochemistry. Say this is the HE section where you can see these clusters of plasma cells. We do first thing is CD138, and you find here that there are these plasma cells. We can do the count also, but obviously it is more than 60%, as you can make out. And now we have to establish the clonality. So we do kappa. Now kappa is positive in all the plasma cells. Lambda is totally negative. So we know that these are clonal plasma cells. So it is highly suggestive of multiple myeloma. Second method is by flow cytometry. Now this is a bone marrow aspirate, and what we find on bone marrow aspirate is that CD38 positive cells we have picked up, and these CD38 positive cells, then we do with we separate them with CD38 and 138, and then these cells in multiple myeloma, 70 to 80% of the cases are CD56 positive, and then we do both cytoplasmic lambda and cytoplasmic kappa, and what we find is that the kappa is positive, lambda is negative. So the flow cytometry can also be used to establish that it is kappa or lambda. Now what happens is that most of these cases do not come with a clear-cut diagnosis of multiple myeloma. They may come with backache, they may come with anemia, they may come with chronic renal failure. So whenever they are doing the bone marrow aspirate or biopsy, they don't keep it for flow, they don't keep it for cytogenetics, or they don't keep it for FISH. So what we can do is, in all such cases, since we have the bone marrow biopsy, if taken, then on bone marrow biopsy, we can do the immunohistochemistry with CD138, kappa, lambda, CD56, and confirm that it is multiple myeloma. And then we can do even FISH from extracting the tissue out of the blocks. Then we go on to multiple myeloma. We all know that the secret M spike, which is seen, is because of the M protein, which is also called paraprotein. So here there are three types of multiple myeloma. One is the secret immunoglobulin, which is complete. That is both with light chains and heavy chains. Then there is one myeloma, which are about 20% cases, which secret only the light chains. So that means those will be the light chain myelomas. And then we have 1 to 3% cases which are non-secretive. So that means we may come across a case of multiple myeloma, which is plasma cells are there 80%, 70%, yet there is no M spike coming. That could be a case of non-secretory multiple myeloma. Now, I mentioned that serum free light chain assay. Now, that is essential for diagnosis because we may come across serum free light chains in the ratio of, normal ratio is between 1 and 2, that is kappa upon lambda. But in multiple myeloma, either kappa will be secreted or lambda will be secreted, and accordingly you will find the ratio will be more than 100. But then we should also carry out immunofixation electrophoresis. Now, what does immunofixation electrophoresis do? With immunofixation electrophoresis, we come to know whether it is IgG, IgA, or IgM, or IgD, or IgE, one of the immunoglobulins, because it separates the heavy chains also. Secondly, it gives us an idea. If it is a light chain myeloma, then we will find either kappa or lambda. And then serum protein electrophoresis is the first step we do where we find the M protein. So heavy light chain combinations will be seen. And then some cases we also do urine protein electrophoresis, and we can also do urine immunofixation electrophoresis in some cases. But keep in mind, as I mentioned, that 2% of the cases are non-secretory multiple myeloma. Now this is serum protein electrophoresis. This is the albumin, and this black one is the M band, which is being seen. Now these are this is a case of multiple myeloma. And then this is immunofixation electrophoresis. Now what you are finding in immunofixation electrophoresis is on serum protein electrophoresis, there is an M spike. Then we find this is G. That means it is mainly the gamma chain, heavy chain. There could be alpha chain also. There could be M chain also. So we have IgG myeloma, we have IgA myeloma, and there is IgM is seen in cases of Waldenstrom macroglobulinemia. And what do we find here? Lambda chain is not being secreted. It is mainly the kappa. So that means it becomes a clonal disease. So it becomes one of the neoplasms. Now, International Myeloma Working Group, as I told you, has said that it should be more than, the ratio should be more than 100 of kappa upon lambda or lambda upon kappa. That is one. And the free light chain which is produced should be more than 100 milligram per liter. So what is the normal ratio kappa lambda? 0.26 to 1.65. Now these free light chains, either kappa or lambda, that's why we call them as clonal free light chains, are produced by neoplastic plasma cells. And we find that free light chains are increased in MGUS, in 70% cases of smoldering myeloma, and in 90% cases of multiple myeloma. And therefore, the FLC ratio more than 100 is a predictor of imminent progression in smoldering myeloma to multiple myeloma. That is why this has been kept as one of the myeloma defining events. However, in certain cases of renal impairment, which does occur in cases of multiple myeloma, then we don't take the 0.26 to 1.65 as the normal. We take 0.37 to 3.1 as the normal ratio. So depending upon the light chain which is being produced, the plasma cells will also be showing you the kappa or lambda chain, depending upon what light chain is being secreted. Now, how to assess the serum free light chain assay? Now, one is the conventional free light chain assay, which is based on the polyclonal antibodies. And the binding site is one company which is giving polyclonal antibodies with fairly accurate results. Second is free light chain assay based on monoclonal antibodies against free light chain. Now, this method is better, reliable, and here we also use the latex method. Now, in this, what we find is the ratio should be more than 70 for smoldering multiple myeloma. And though in the other one, this method, polyclonal, we take a ratio of more than 100. Of course, both of them are by nephelometric method. So we must have a nephelometer to assess the serum free light chains. Now, this is just to show you that in smoldering multiple myeloma, one can have with the free light method, it is more than 100 ratio, while with the latex one, it is the 70. So this method of N-latex is better than the free light chain assays by binding site. Now suppose we have a workup for a newly suspected case of multiple myeloma. That means the patient comes to us with backache or anemia or features of chronic renal failure. So what all tests we should go for? One, of course, is the CBC. ESR is high in these cases. Peripheral blood smear we must examine in each case. We should not rely upon the report from the cell counter. Then serum protein electrophoresis, immunofixation, and serum free light chain assay. These are must. And of course, to see the degree of the disease and the kidney involvement, serum LDH, creatinine, calcium, albumin. If we are doing bone marrow aspiration biopsy, which is essential for diagnosis, then we should also do FISH, or we can do cytogenetics, looking for trisomies, and then immunohistochemistry to establish that these are clonal plasma cells, or by flow cytometry. Then, of course, for radiology, we are doing whole body CT, or we are doing PET CT in all these cases. So first of all, peripheral smear, what do we find? We find rouleau formation, that is one, as you can see here. The background staining you are seeing is pink. Now that is because of the increased globulin in all these cases of multiple myeloma. And this rouleau formation, sometimes we come across in the cell counter report that the MCV is too high and the hemoglobin is not proper, not tallying with the RBC count. That is because of the fact that these rouleaux may be counted as white cell, these may not be counted as red cell, and then you find that the red cell count is pretty low. Then the bone marrow aspirate, what we find is normocellular to hypercellular particles. But we must keep in mind one thing, and that is that this is a disease of the old age, where the marrow is already hypocellular. There is increased fat, and we may come across few plasma cells normally also. So it is very, very important to do the clonality test to see whether the plasma cells, which you can see here, are they clonal or not. And then plasma cells should be more than 10% of all the nucleated cells of the marrow. But keep in mind that these cases also have leukopenia, thrombocytopenia, and you may find hematopoiesis is suppressed in these cases. Now, these are the myeloma cells or the plasma cells, but these are larger than the usual plasma cells. There is a perinuclear half, basophilia of the cytoplasm. Nuclear chromatin, you are finding some nucleoli. Now, normal plasma cells do not have nucleoli. Such cells, we label them as immature plasma cells. Now, this is a case where you are finding about 70% of the plasma cells are present. And then you find variation in the size of the nuclei. We may also come across pleomorphic plasma cells. Then we find that there is derangements in the immunoglobulin secretions. You find Russell bodies. Now, this is a grape cell or a mott cell. You find that there are intracytoplasmic immunoglobulin inclusions in the plasma cells. We may also come across intranuclear pink inclusions, what we call as Dutcher bodies. Then we find crystalline inclusions, as you can see here. Fine crystalline inclusions are present in the plasma cells. These are called thesaurocytes, large flaming cells, pycnotic nuclei. And then we have flame cells, like flame cells we have in thyrotoxicosis. Here you find that the peripheral part is red and flaming. Now, this is suggestive of that the patient probably is a case of IgA myeloma. Sometimes in the bone marrow aspirate or biopsy, what we come across a large number of these macrophages. And sometimes we may miss the accompanying plasma cells. The disease, or it is a neoplasm of the plasma cells. Because of the rapid turnover of these plasma cells, these macrophages are increased and they phagocytose the lipid material. Of course, you can confirm by doing the CD68. These are the pseudo-Gaucher cells, and these are the fats or the sphingolipids are engulfed by the macrophages. So we have done up to bone marrow findings. Now we go on to the differentiation of the plasma cells. Now this has been divided into 4 types. First is the mature type, or what we call as plasmacytic type. You can see that these are all mature plasma cells, sheets of them on a bone marrow biopsy, indicating it is a mature type of plasma cell. Here you find immature type. We label a case as immature type when the cells are larger, nucleus is eccentric, but the nucleoli are prominent in almost every cell. So this is the immature type. Don't think that immature plasma cells cannot occur. In multiple myeloma, we do come across them. And this is on bone marrow biopsy. Again, you find eccentric nuclei, prominent nucleoli. That is a feature of immature type. Then we have the intermediate type, where these are neither mature nor immature. They're larger than mature, but they don't have nucleoli. So this is the intermediate type, same on the bone marrow biopsy. And finally, we have the plasmablastic type of myeloma. This is one which is really a challenge, because what we find here in plasmablastic is that the nuclei are not eccentric. Nuclei are central. Keep in mind, the nuclei are central. Basophilic cytoplasm, sometimes they are mistaken for M6 erythroleukemia. Sometimes these are mistaken for megaloblast. And sometimes we don't know what is the nature, maybe a case of acute leukemia. So we keep on putting up all sorts of markers on flow, also on immunohistochemistry, and we miss putting up CD138, which will clinch the diagnosis that it is a plasmablastic type of myeloma. The Keel and other workers from Mayo Clinic say that if such plasma blasts are more than 3% in the bone marrow, these cases have a worse prognosis. And then we have the pleomorphic type, where sometimes a case is labeled as metastatic carcinoma. Look at this anaplasia of these plasma cells. Both on the aspirate, the size varies, the nuclear characteristics vary, and some of them are multinucleated, giant cells, and they look like at times megakaryocytes also. So this is a pleomorphic type of multiple myeloma. Now, when should we do a refined biopsy? You suspect multiple myeloma because you don't know, the marrow may be hypocellular. If it is hypocellular, then aspirate is going to be inadequate, both for diagnosis and for flow. Suppose a patient is associated with fibrosis, like in this particular case, you find there is tremendous fibrosis, you attempt an aspirate, it comes out to be a dry tap on bone marrow aspirate. If you have taken the biopsy, then you are seeing these atypical cells, put up CD138 and the diagnosis will be there. Suppose there is associated amyloid, you will miss it both on aspirate. So what is needed is again a biopsy, the pattern of marrow infiltration, and then immunohistochemistry. You can do immunohistochemistry to establish the clonality. And finally, how much is the hemopoietic reserve? Is there any hemopoietic reserve or not? So what we find is the infiltration patterns. Now you find that plasma cells are distributed interstitially in between the hemopoietic cells. They are forming nodules in some cases, so nodular type. Diffuse type, where the total marrow is replaced by these sheets and sheets of plasma cells. Such cases are easy to diagnose. And then you find a mixed pattern. There are some nodules also. There is an interstitial pattern also. And these plasma cells are distributed in the bone marrow. And finally, the amyloid-associated multiple myeloma. If you have got a biopsy, you'll be able to see the pink material, put up Congo red, examine under polarized light. Bone marrow fibrosis. Now, fibrosis is seen in 25 to 30% of the cases of multiple myeloma. What you are seeing here are streaming of the cells. The cells are pulled up because of the increased reticulin and the fibrosis which occurs. But then, even the plasma cell nature may not be clearly visible. So put up CD138. Bone marrow necrosis, about 10% of the plasma cell neoplasms. The more aggressive neoplasm, the more chances of necrosis, where you cannot make a diagnosis unless there is some part where the cells are wiped. So what is the role of immunohistochemistry? To demonstrate the clonality by anti-kappa and anti-lambda, for identification and quantification, as I told you, by CD38 or CD138, And then, of course, you have the prognostic markers. So this is a case of multiple myeloma with fibrosis, and CD138 came out to be positive, though there was extensive fibrosis. Kappa is negative, lambda is positive. So it is a clonal plasma cell disease. It is a lambda positive. So lambda chain restriction, multiple myeloma. Now on bone marrow examination, what are the various prognostic parameters? If there is a diffuse marrow pattern, worse prognosis. Plasmablastic, worse prognosis. Plasma cell labeling index, angiogenesis, more angiogenesis is indicative of disease progression. Then, of course, we always do nowadays cytogenetic and molecular. And what we find is, if there is T1114, good prognosis. And if you find intermediate prognosis, then it is usually 414. 614 again has a good prognosis. So if you are doing these cytogenetics and molecular studies, you are able to confirm the prognosis of these patients. Staging is now done by stage 1, stage 2, and stage 3. In stage 1, what we find is the beta-2 microglobulin is less than 3.5%. High risk cytogenetics is not there. Serum LDH is normal, and the albumin is high. Here we find the beta-2 microglobulin is more than 5.5, and high risk cytogenetics like 414, 1416, deletion 17p, these are present. And then plasma cell leukemia. Now, plasma cell leukemia, we label a case as plasma cell leukemia when we find that more than 20% of the differential count, there are plasma cells in the peripheral blood. As you can see here in this particular field, there are 4 plasma cells in the peripheral smear, and the absolute count is more than 2000. Now, usually these cases have diffuse infiltration or a high tumor load. But what we find is, I told you that CD56 is usually positive, but here in cases of plasma cell leukemia, the CD56 is usually negative, and that is why the cells come into the peripheral blood. So then we go on to MGUS and smoldering multiple myeloma. Now, initially I told you that the disease begins as MGUS, then goes on to smoldering myeloma. And the various, there are 2 types. Basically, nowadays we have 3 types of gammopathies. One is IgA and IgG secretion, which is the commonest. Second is the IgM, which is a Waldenstrom macroglobulinemia. And finally, we have the light chain MGUS or light chain multiple myeloma. Now, MGUS and smoldering myeloma, if we see, MGUS progresses on to multiple myeloma, 0.6 to 3% of the diagnosed cases of MGUS. However, the prevalence of smoldering multiple myeloma going on to multiple myeloma is higher. It is about 10%. Now, what is MGUS? First thing is that it is a disease of the old age and present in about 2% population. And what are the criteria for diagnosis is that clonal bone marrow plasma cells for myeloma we said is more than 10%, but for this is less than 10%. CRAB is the feature of myeloma, but here it is absence of CRAB. M protein we said is essential. Here we find the M protein or the non-IgM type is less than 3 grams. So what are the various types which it could be? It could be IgG MGUS, it could be IgM MGUS, so light chain MGUS can also be. Now, light chain MGUS is because there is a production of the light chain, so the FLC ratio or the free light chain ratio is disturbed. There is increased level of appropriate free light chain, and there is an absence of end organ damage, which I told you that the CRAB, that is not there, and the bone marrow plasma cells are less than 10%. Now, what is more important is smoldering multiple myeloma. And this is a stage which is intermediate between MGUS and multiple myeloma. Risk of progression is very high. That is 10% per year. And there are 2 subtypes. One is low rate progression, one is a high rate progression. Now, what has happened is that all those cases are the borderline smoldering multiple myeloma, in which one of the biomarkers of malignancy, which I told you that more than 60% plasma cells, that is number one, or there is free light chain ratio is more than 100, or there is a more than one lesion on PET CT. All of them will now be grouped under multiple myeloma rather than smoldering multiple myeloma. There are two criteria only for diagnosis. One is that the plasma cells should be clonal, but they could be between 10 to 60%. Monoclonal protein, IgG or IgA, is more than 3 grams. In AMGUS, it is less than 3 grams, but here it is more than 3 grams per liter. And then absence of myeloma defining event. The moment myeloma defining event, any one of them is there, it becomes a case of multiple myeloma. This is what we find on bone marrow biopsy. You find a cluster of plasma cells, or what we call as micro aggregates of plasma cells. Rest of the marrow by and large is normal, though of course you are seeing few plasma cells here and there. And you do CD138, which will confirm that these are plasma cells, and then put up kappa, lambda, they will be clonal, either kappa or lambda positive. But then we have to differentiate it from reactive plasmacytosis, then plasmablastic lymphomas, and also from Waldenstrom macroglobulinemia. Now, the reactive plasmacytosis, there are multiple causes: infections, metastasis, sarcoid, cirrhosis. And then we always find, how do you differentiate otherwise, is that this is a capillary. In the lower one, you find this is a capillary, and all these plasma cells are gathered around this pericapillary. So the distribution of reactive plasmacytosis is pericapillary or perivascular, and it is usually less than 10%, but always does not exceed 20%. That is one. Plasma blasts are not encountered in cases of reactive plasmacytosis. Immature plasma cells are not encountered in these cases. And if you do, now what is the confirmatory test is, you do kappa and lambda. The moment you do kappa and lambda, reactive plasmacytes, some of them will show you kappa, some of them will show you lambda. So confirming a polyclonal nature of these plasma cells. Finally, a word about Waldenstrom macroglobulinemia. Now, here we find that this is also known as lymphoplasmacytic lymphoma. Now, when we see the WHO classification, it is one of the types of lymphoma which is there. But once lymphoplasmacytic lymphoma is associated with M protein secretion or with IgM secretion, it becomes a case of Waldenstrom macroglobulinemia. And also, this is associated with mid-88 cytogenetic abnormality, which is characteristic, or rather it is a marker of Waldenstrom macroglobulinemia now. So what do we find in this? M spike, number one, and then we find that there is a M spike is of IgM, and then it is clonal only kappa. The clinical features are because of the fact that the patient has hyperviscosity, peripheral neuropathy, hemolytic anemia, vasculitis. And of course, these cells are three types of cells we come across. On morphology, what you find is three types of cells, as I said, lymphocytes, that is number one. So it could be mistaken for any lymphocytic lymphoma. Second, we find plasmacytoid lymphocytes, as you can see here. It is neither a plasma cell nor a lymphocyte, so plasmacytoid lymphocytes. And third is you come across plasma cell. So this is one lymphoma where, or a Waldenstrom macroglobulinemia, where you find three types of cells: lymphocytes, plasmacytoid lymphocyte, as well as plasma cells. Now this is on bone marrow biopsy. Diffuse replacement, some C-blue histocytes are seen in between, but what you find is majority of them are lymphocytes, few plasma cells are seen. Now this is HE, and then you find that these cells are CD20 positive, the lymphocytes, and then you find these are PAX5 positive, the lymphocyte, and then CD138 positive, these are the plasma cells. But all of them are clonal. If all of them are either kappa, all of them are or lambda. That means the lymphocytes, plasmacytoid lymphocytes, and the plasma cells are either kappa or lambda. A word about AL amyloidosis, because nowadays you are coming across large number of cases of AL amyloidosis where the plasma cell clone produces monoclonal light chain, and there is presence of heart failure, nephrotic syndrome, hepatomegaly, peripheral neuropathy, and then you find macroglossia, as you can see in this case. You find a periorbital purpura, and some mandibular glands are enlarged. Now, what is happening here is that there is an amyloid deposit also in the abdominal fat and bone marrow. So we may pick up this amyloid either on the bone marrow, refined biopsy by doing Congo red and then examining under polarized light, or what you find is that you can do a subcutaneous aspirate and in the abdomen from the abdominal fat and demonstrate the presence of amyloidosis. So AL amyloidosis may go on to multiple myeloma. So all cases, but here we don't find that the plasma cells are increased to that extent. Usually they are less than 20% we come across. Now this is to show you in the macroglossia, there is a myeloid deposit. In the kidney, there is a myeloid deposit from another case. And this is, you find green apple, green birefringence on polarizing light. Then a word about monoclonal gammopathy of renal significance, a new entity which has come up thanks to Dr. Sethi in USA. And what we find is that there is a monoclonal immunoglobulin present in the plasma or urine, but we must exclude multiple myeloma, smoldering myeloma, Waldenstrom macroglobulinemia, and so on. Now, these cases do not respond well to immunosuppressive therapy. That is one. Second, there is a high risk of recurrence in these cases. So what we find here is that there is a light chain proximal tubulopathy, now which is dangerous, and there are crystal storing histiocytes. And it is a, then last word is non-malignant monoclonal gammopathy. And this is a monoclonal gammopathy of clinical significance, where there is a small B cell clone, small monoclonal protein, but it causes serious and even life-threatening diseases. The organs affected are kidney, nerve, and skin. So the take-home message is that multiple myeloma is a clonal proliferation of plasma cells. So we must demonstrate that the plasma cells are clonal by kappa lambda. That is essential. M protein production is an integral part of the disease. So is free light chain. So the free light chain ratio of more than 100 is essential for diagnosis of multiple myeloma. And most of the cases will also show a scrab, which is the evidence of organ damage. Thank you very much. Any?
That was such a wonderful session, sir. Thank you so much for enlightening us. We are fortunate to have you, sir. Now there is an announcement. The souvenir has been. Thank you so much, sir.
Thank you.
Are you making an announcement?
Yes.
Yes, ma'am. But just a minute, ma'am.
Okay.
So
that was excellent, Teerthanker sir. It was excellent talk. And what to say, I have heard you so many times. It was excellent. And both the speakers were excellent, Dr. Nusrat as well as Dr. Tejinder Singh. And thanks to the organizers from the chairpersons.
Thank you. Thank you, Dr. Goel, and thank you, Mr. Singh.
And seeing you after such a long time, sir. It was a pleasure hearing you.
Thank you so much, Dr. Goel. Thank you.
Now there is an announcement. The souvenir has been uploaded on the website, so the delegates can download from there. Now I request our chairperson to kindly introduce our third speaker of the day, Dr. Madhu Kumar ma'am. We welcome you, ma'am.
मधु कुमार
अच्छा वो भी है
Hello, Dr. Professor Madhu Kumar. Madhu Kumar is working in our Department of Pathology, and she is looking after the histopathology, different systemic surgical pathology. She is a very good orator, and we wish her all the best. Please start the lecture.
Okay, thank you. I'm audible? I'm
Yes, you
audible?
are. Yes, you are.
Thank you, sir. Thank you very much for the for organizers for giving me this opportunity to present case in this platform. And just while we all heard the Teerthanker Singh sir and Nuzhat ma'am for a wonderful talk. Thank you, ma'am and sir. And this is a case study. This is a case study of 46-year-old lady presented with.
Sorry to interrupt you, ma'am. Ma'am, kindly share your screen, please.
Okay, okay. Ananya? Now screen is visible?
No, ma'am.
Screen is visible. Madhu, I see your screen.
Screen is visible?
Madhu's screen is visible. Yes, I can see.
Yes,
I can see your screen.
Slide is visible, ma'am?
Yes, yes. Yes,
Yes,
it is
ma'am.
very well visible.
Yes, ma'am. Ma'am, this is a 46-year-old lady presented with history of breast lump that was gradually increasing in size during 1 year duration. On the physical examination, a hard non-tender lump of size 4 into 3 centimeter was noted in the left lower quadrant of breast. There is no previous medical or surgical history available. On her X-ray chest and USG was normal, and clinically this is a suspected case of breast carcinoma. Sonography and final aspiration cytology was advised. Sonography showed ill-defined, moderate size, irregular space occupying lesion in the left lower quadrant of breast at 5 o'clock position. The
Sorry to interrupt you, ma'am. Ma'am. Ma'am, we are not able to see your screen. We are able to see you, but not your screen.
Okay.
Computer screen. Your computer screen, ma'am.
Just a minute, please.
Yes, ma'am.
I think always there is a confusion because of there are two screens. One is Teerthanker and Madhu Kumar. If you click on Madhu Kumar, because I am able to see Madhu's screen.
Still,
and if you select
I'm also
Teerthanker,
not
then you
able to
won't be
see.
able to see Madhu's screen.
I'm also not able to see Dr. Patsla. Now I can see.
Again, madam, you have to select from.
No, now I can see. Now I can
Yes,
see.
ma'am. Now we can see.
Yes, yes, you have to select from that, Madhu's. Because I can see her screen very well from the very beginning.
Ma'am, I'm audible?
Yes, ma'am.
When I start?
Yes, ma'am. Sure, ma'am.
Sonography of the patient showed the ill-defined, moderate size, irregular space occupying lesion in the left lower quadrant of breast at 5 o'clock position. And the lesion was irregular in outline, fine calcification, and increased vascularity was also noted, along with the few axillary lymph node was also seen. The FNA smear showed this is a hypercellular smears. The tumor cells are arranged in small seeds, clusters, as well as at some places there is a ill-defined glandular structures also seen in the hemorrhagic background. And the individual tumor cells are mild to moderately pleomorphic. The individual tumor cells are round to oval nucleus with abundant granular cytoplasm. At this place, you can see the mitotic figure are also seen. So on the basis of the cytomorphology, we give the diagnosis of the interductal carcinoma breast. And we also received a modified radical mastectomy specimen along with the axillary nodes, labeled 2 lymph node and interpectoral lymph node. The entire breast was measuring 12 into 11 into 7 centimeter in size, along with the axillary tail, axillary lymph node, labeled 2 and interpectoral lymph node. On cutting, there is a 3 into 2 into 1 4 centimeter size, ill-defined, poorly circumscribed, solid, homogeneous growth, and at some places there is a pinpoint hemorrhagic area are also seen. And the microscopically, the tumor arranged in a organoid pattern or in nesting pattern, and these tumors are arranged in a compact pattern, and the nesting pattern are separated by thick or thin fibrous stroma, and it also invading the numerous blood vessels in between the tumor. And this is the high power view. You can see the round to oval nucleus with abundant cytoplasm and separated by a thin fibrous stroma. And in this picture, you can see the round to oval nucleus, vesicular nuclear chromatin, or fine to speckled chromatin with the abundant granular cytoplasm. And here you can see the fair number of mitotic figures are also seen with the vesicular or fine chromatin. And here you can see the multiple foci of the ductal carcinoma in situ. And the lymph node also showed the metastatic deposit. And this is the lymphoid tissue. You can see the lymphoid follicle, and this lymph node is infiltrated by the tumor cell, solid organoid pattern of the tumor cells. And here you can see the numerous angiovascular invasion, and this is the blood vessels. You can you can see the blood vessels is lined by the endothelial lining, and tumor is invaded by the vessel is invaded by the tumor cells. So what is the differential diagnosis or the provisional diagnosis? The resident, please write your provisional diagnosis in the chat box. So on the basis of the histomorphology and FNAC, obviously the first diagnosis is infiltrating breast carcinoma, and with the abundance of the cytoplasm, eccentric nucleus, plasmacytoid-like cells. That was the second DD is myoepithelial carcinoma. And because of the some fine speckled vesicular chromatin, some salt pepper-like chromatin. So third diagnosis is a neuroendocrine carcinoma. It could be primary or secondary. So we applied the immunohistochemical stains, synaptophysin, chromogranin, NSC, GCD, P15, ER-PR, HER2/neu, and P63. You can see the synaptophysin, chromogranin, NSC, and GCTP was diffusely positive in the tumors, and ER-PR, HER2/neu, and P63 was negative. and the Ki67 was markedly raised in the tumor cells. So on the basis of the cytomorphology and histomorphology, this is a case of primary neuroendocrine breast carcinoma, which metastasizes to the axillary lymph node. So the primary neuroendocrine carcinoma of breast are rare subtype of breast cancer, first recognized by Fetter and Hartman in 1963. However, classification of neuroendocrine breast carcinoma together with clinical and prognostic analysis was done by two American pathologists, Antonio Kubila and James Woodruff, in 1977. Primary breast neuroendocrine carcinoma are rare histologic type and representing less than 0.1% of all breast cancer. In 2003, WHO defined mammary neuroendocrine carcinoma as tumor with more than 50% neoplastic cells expressing at least two neuroendocrine markers. The major changes are listed in 2019 WHO classification of breast tumors in the fifth edition, which is the update of fourth edition of breast tumor classification published in 2012. Breast tumors with neuroendocrine differentiation show features similar to the neuroendocrine tumor of other organs in lungs, GIT, and in hepatobiliary system also. Recently, 2019 WHO classification organized in sequence from benign epithelial proliferation, precursors, benign neoplasm, in situ invasive carcinoma breast, followed by mesenchymal and hematolymphoid neoplasm and genetic tumor syndrome. This is the table. You can see the some changes from 2000 to 2019 classification. Initially, the mitotic count expressed in the per 10 high power field, but in 2019, the mitotic count given as a per square millimeter. And there is a change in the newer classification of breast related to the neuroendocrine tumor. This article is published in the histopathology journal, and the neuroendocrine neoplasm in the 2019 WHO classification, there are the true primary neoplasm. These are the type as a neuroendocrine tumor and a small and large cell neuroendocrine carcinoma, with the neuroendocrine differentiation overridden by morphological tumor type. In the NST, breast carcinomas, mucinous breast carcinomas, and solid papillary breast carcinomas. And there is a lot of evolution of histological grading for neuroendocrine neoplasm based on mitotic count and Ki67 labeling index by the classification and the years. The grading of neuroendocrine tumors are only and only based on the mitotic count and the Ki67. The are grade accordingly grade 1, 2, 3. If the mitotic count is less than 2 per 2 square millimeter, grade 1, 2 to 20 per square millimeter, grade 2, and more than 3, more than 20 per 2 square millimeter mitotic count. The mitotic Ki67, if less than 3, graded as a grade 1, and grade 2 graded as a grade 3 to 20, and in grade 3 the Ki67 is more than 2%. And the neuroendocrine tumors are the well differentiated tumors, and the neuroendocrine carcinomas are the poorly differentiated carcinomas, and again subclassified as a small cell and large cell type on the morphology of the tumor cells. And the update in the neuroendocrine tumors, the well-differentiated neuroendocrine tumors, grade 1 are called as a carcinoid-like tumor, and grade 2 are the atypical carcinoid-like tumors. The many breast tumors that display varying degree of neuroendocrine differentiation along with recognized entity, such as in the hypercellular mucinous carcinomas, solid papillary carcinoma, both in situ and invasive forms. Among the neuroendocrine markers, the NSE was positive in approximately all cases, with variable expression of either synaptophysin and chromogranin. About more than 50% of low or intermediate grade neuroendocrine tumors expresses chromogranin, and only 16% expresses synaptophysin in the studies. The Zinkoglu et al. found synaptophysin positivity in 91% and chromogranin in 40% of the cases. Neuroendocrine differentiation arises from the divergent differentiation of neoplastic stem cells into epithelial and endocrine cell line during early carcinogenesis. Neuroendocrine differentiation has been demonstrated in up to 30% of invasive ductal carcinoma and is most frequently found in mucinous carcinomas. And in primary neuroendocrine carcinoma of breast, more than 50% of cell population show neuroendocrine differentiation. Breast carcinoma not otherwise specified with focal endocrine differentiation revealed by immunohistochemical expression in the scatter cell. In the primary neuroendocrine carcinoma, the tumor cell shows the 50% population cell showed the immunohistochemical positivity, but in the neuroendocrine differentiation, the ISC showed positive in the scattered tumor cells. And initially these tumors are called as argyrophilic tumors, breast carcinoid, or endocrine carcinoma, but now classified as a neuroendocrine differentiation or primary neuroendocrine breast carcinomas. And these tumors are usually seen in the elderly women around 6th or 7th decade of the life, but as reported in the literature. And the treatment of patient is depend on the location of the tumor, staging of tumor, and receptors of the patient. And treatment mostly is surgical, and the indication for chemotherapy and radiotherapy are same as far as other breast cancers. And the differential diagnosis is metastatic neuroendocrine tumors, which account for 1 to 2% of metastasis to breast. Distinction of primary from metastatic neuroendocrine tumor is critical to avoid the misdiagnosis. Primary neuroendocrine tumors are associated with the DCIS. Nuclear atypia pleomorphism is also noted, and that favors the primary neuroendocrine tumor of the breast. And mostly the presented with the retroareolar and upper quadrant of the breast, and this patient was presented with the lower quadrant of breast. Size varies from 1 to 14 centimeter, but this tumor in this case was 3.5 centimeter. And generally these tumors are present in the postmenopausal woman, and in this study this case was present, this patient was 46 years of the age, and ERPR HER2/neu was variable in the numerous studies, but in this study this case was triple negative, and among the neuroendocrine marker NSE was positive in all cases with the expression of either synapto or chromogranin. In the present study, the NSE, synaptophysin, chromogranin, all three markers was diffusely positive in the tumor cells. So a take-home message is the one thing should always kept in mind to exclude metastatic neuroendocrine tumor, and always search for primary in lung, GIT, and pancreas. On the basis of clinical history, physical examination, histomorphology, immunohistochemistry to achieve the final diagnosis. And histopathology and ISC is the only way to exclude all the differential diagnosis and achieve their correct diagnosis, facilitating a correct prognostic information and the treatment. And these are my references. Thank you.
Thank you so much, ma'am, for your wonderful session. Now the house is open for the discussion.
I think this was quite an elaborately described case, so we can move further if no questions. And because it was very well presented and all detailed discussion has been written.
Okay, ma'am.
So let us move on to the next case.
Yes, ma'am.
Nice, Madhu. Nice. It was a good presentation.
Thank you, ma'am. Thank you. Thank you.
Now I request to extend and project our confidence and appraise towards the guest speakers and session chairperson, we would like to present a memento followed by the certificate of appreciation. Certificate of appreciation for Dr. Madhumati Goyal, ma'am. Please accept it, ma'am.
Thank you so much. Thank you so much.
Certificate of appreciation for Dr. Uma Shankar Sangh, sir. Sir, kindly accept it, please. Certificate of appreciation for Dr. Madhu Kumar, ma'am. Ma'am, kindly accept it, please.
Thank you very much. Thank you.
Certificate of appreciation for Dr. Tejinder Singh, sir. Sir, kindly accept it, please. Certificate of appreciation for Dr. Nusrat Hussain, ma'am. Ma'am, kindly accept it, please.
And I just wanted to tell you that I have received the memento and the certificate physically also. Thank you so much. And thank you all the organizers. Thank
you so much, ma'am. Now, moving forward for the second session of the day. Now, moving forward for the second session of the day, first to chair this session, I would like to introduce our first chairperson, Dr. R.K. Gupta, sir. We welcome you, sir. Sir has done MBBS MD from KGMC Lucknow. Sir was a lecturer, reader and professor of pathology, MLB Medical College, Jhansi, Professor and HOD Pathology, Dean and Director, Sanjay Gandhi Postgraduate Institute of Medical Sciences. Sir was awarded several honors, awards and prizes for academic excellence by national scientific bodies. Areas of academic interest are renal pathology, transplantation pathology, and pathology of opportunistic infection. Sir was active member in more than 150 in peer-reputed national and international journals, including invited reviews. Sir was a Vice President, IAPM 1996, National President, IAPM 2003, and Vice President, ISOT, 2 terms of 3 years each. Founder President, Indian Society of Renal and Transplantation Pathology, 2005 to 2007. We welcome you, sir. Our next chairperson for this session is Dr. Shamoli Datta, ma'am. We welcome you, ma'am. Ma'am is Principal and Dean of Teerthanker Medical College, Moradabad. She did her MBBS and MD from Givaji University, Gwalior. Ma'am worked as a professor, head of the Department of Pathology, and also worked as a medical superintendent at Teerthanker Mahaveer University. Ma'am have a number of publications under her name in different national and international journals. Her area of interest is histopathology. Ma'am have more than 30 years of experience in teaching. Ma'am has undergone all the essential training in medical education, starting from basic course to CISP according to NMC. We welcome you, ma'am. Now, we request you, sir and ma'am, to kindly introduce our first speaker for this session, Dr. Anurag Gupta, sir. We welcome you, sir.
Thank you.
मेरा ऑडियो क्यों नहीं शुरू हो रहा है?
सेशन चेयर हैं कौन?
मैंने अनम्यूट तो कर दिए।
टू अनम्यूट आ रहा है, वो करें ना। मैम वीडियो नहीं कैसे ऑन होगी?
I welcome Dr. Anurag Gupta.
We are waiting for your interesting talk. Please start your.
Yeah, sure, ma'am. Thank you, ma'am. And thank you, organizing Chairperson Dr. Seema and her team for nicely organizing this conference and for their kind invitation to deliver this talk. So today I have recorded my talk. Actually, I'm going to share it with you. So I will be there throughout the session. Good evening, everyone. So today I'm going to discuss about 6 to 7 interesting cases of head and neck cytopathology. As we all know that head and neck lesions are quite common in day-to-day cytopathology practice. We frequently deal with many organs which are located in the head and neck region. For example, we have salivary glands, we have thyroid and other significant organs. And besides that, there could be bone lesions or lesions involving various sinuses or sometimes scalp. So it is an important part from cytopathology practice point of view. So today I'm going to discuss around 7 cases of head and neck cytopathology. So I will start with case number 1, who was an 8-year-old boy presented with right intra-auricular swelling for around 8 months without any history of pain, fever, or any other systemic symptoms. On examination, the swelling was measuring around 5 into 4 centimeter, and it was firm, mobile, and non-tender in origin. So you can see in this picture that the swelling was characteristically located at an intra-auricular region. As we all know that this is a classical site of parotid, and it was even confirmed on ultrasound. And we all know that the swelling in the parotid can exceed from post-auricular to pre-auricular region, and it may also involve intra-auricular region, depending upon the site of the parotid gland, which is involved by the tumor or some other lesions. So we did FNAC passes. So what we got on FNAC, a round cell tumor. It was comprising of typically round cells, which were arranged in loosely cohesive clusters, and most of them were lying singly. So there were 2 types of cells, few with the pale chromatin, having abundant or moderate amount of homocytoplasm, and the other population was relatively with the darker nuclei, and there was hint of rosetting as well at places. So on searching other areas, we could find few mitosis as well, though it was not frequently seen. And chromatin was uniform, granular, with inconspicuous nuclei. In the center, you can see some rosettes or acini-like structures which were present at places or at some foci of different areas. So we also prepared cell block from the aspirate, and you can easily identify these small round cells arranged in sheets, and some are arranged around vessels, forming rosette-like structures. So what could be differential when we have this kind of picture? Though it is uncommon for parotid to have this kind of lesion, but suppose if we have this kind of picture, we should think about malignant round cell tumor. So there is a list of differentials which fall under this category of malignant round cell tumor. On the basis of the differential, we apply a panel of ISC markers on cell block. So there was focal weak positivity for pancytokeratin, and synaptophysin was also weakly positive, showing some granular positivity in the cytoplasm. Guanidine, CD99, and Fly1 was strongly and diffusely positive. However, other stains, particularly LC and Desmin, were negative. So on the basis of all these markers, we could easily make the diagnosis of extraskeletal Ewing's sarcoma. parotid origin. So when we went through the literature, we could find only few single case reports. So in 2020, this case was reported as a single case report of extraskeletal avic sarcoma in parotid gland. And they also reviewed literature and they could find only 4 or 5 cases of Ewing sarcoma of salivary gland origin. And most of these cases presented in younger age group with maximum age of 20 years. As we all know, Ewing sarcomas are usually seen under 20 years of age. So how do we identify Ewing sarcoma on morphology alone? Though it is not a difficult diagnosis, its presentation is unusual, involving salivary gland, parotid gland, but otherwise it is not a difficult diagnosis on cytology alone, because it is characterized by dual population of cells, one with pale chromatin or light chromatin and the other one having darker chromatin. And there could be singly scattered cells or loosely cohesive clusters, as we had in our case as well. And these tumors are also characterized by intracytoplasmic vacuoles due to presence of glycogen, and there could be a hint of rosette formation around vascular channels. However, whenever we have this kind of picture in a parotid gland, we should think about other round cell tumor as well, especially if we talk about this age group. We can have different tumors in our mind, for example, metastatic neuroblastoma. However, neuroblastomas usually present with smaller cells having high NC ratio with less amount of cytoplasm and frequent homocyte rosettes. However, the difference, the subcellular component depends on the differentiation of the tumor. Sometimes we can have primary rhabdomyosarcoma of the parotid as well. However, rhabdomyosarcoma, though they are considered as round cell tumor, but there is more pleomorphism as compared to conventional or classical round cell tumor. And the rhabdomyoblasts, which if they are present in the rhabdomyosarcoma, they usually present with the dense eosinophilic cytoplasm with eccentric nuclei and prominent nuclei. And most of the time, there is some hint of spindling as well as presence of multinucleated cells as well. So all these features are there, which help us to differentiate rhabdomyosarcoma from other malignant round cell tumors. This age may also present with non-Hodgkin's lymphoma, especially the blastic lymphoma, for example, Burkitt's lymphoma, or sometimes lymphoblastic lymphoma, and not uncommonly diffuse large B-cell lymphomas. And if we are dealing with a case of non-Hodgkin's lymphoma, though it falls into small round cell tumor, but we can find presence of lymphoglandular bodies frequently, and we can use the panels of markers LCS positive, and this way we can differentiate non-Hodgkin lymphoma from other malignant round cell tumor. But if we consider older age group, we should also take small cell carcinoma, especially metastatic type, into consideration. However, this malignancy presents with coarser chromatin, indistinct to prominent nucleoli sometimes, and with frequent mitosis and apoptosis. So this looks more bad as compared to other malignant round cell tumors. So it should not be considered in young age group, especially under 20. Besides the tumors of non-salivary gland origin, we should think about some salivary gland origin tumors as well, especially the basaloid group of the tumors, where we consider few neoplasm, for example, cellular pleomorphic adenoma or solid variant of adenoid cystic carcinoma. Besides, there could be basal cell adenoma or basal cell tumors and epithelial myoepithelial carcinomas. So they can also have some resemblance with malignant round cell tumors, especially when they have scattered basaloid cells along with loosely cohesive clusters. However, we should carefully look for presence of mesenchymal matrix, hyaline or fibrillary in nature. If we are able to find matrix with basaloid cells or round cell type component, we should think about salivary gland tumors over other non-salivary gland tumors. Coming to the next case, a 63-year-old female presented with a pain in right hypochondrium for 7 months, with complaint of weakness, nausea, and loss of appetite for around 2 months. Patient was anicteric. Most of the liver function tests were within normal limit, except there was mild increase in serum alkaline phosphatase and serum CA 19.9. So when we went through the MRI scan, there was a huge mass with maximum dimension of 19.7 centimeter. So the tumor was so huge that it was involving almost whole of the region. So on MRI, radiologists suggested the diagnosis of meningoendothelioma, and they performed guided FNAC, and they sent unstained smears to us, to the pathology department. So we had no other history of the patient except the presence of liver mass. So when we went through the smears, we were surprised to see these kind of structures. These balls fully covered by some basaloid cells. It appears that something is embedded within the matrix, and they were separate from each other with beautiful boundaries, strict boundaries, and there were some bare nuclei in the background. So we went ahead, looked for some other areas. So we could easily find this kind of material, these 3-dimensional hyaline globules, or which are also considered as gumballs like appearance, with basaloid nuclei, which were round to oval with some angulation, uniform chromatin, but hyperchromatic, with absence of any mitosis, and many bare nuclei in the background. So on going through some other areas, we could find some punched out appearance, especially in these globules. The basaloid cells which were lining these globules were showing some fenestrations. So this pattern is known as cribriform pattern, with presence of some unremarkable hepatocytes. So presence of unremarkable hepatocytes was another clue in favor of metastatic tumor. So after thinking around 15 to 20 minutes, so the diagnosis which came to our mind was a metastasis from some unusual site, which is not frequently seen in the liver, that is salivary. Because most of the time, whenever we are dealing with the liver malignancies, especially metastatic tumors, most of the cases, they come from the GIT. They are classical adenocarcinoma with presence of columnar cells, and sometimes we are having presence of mucin as well. So there was nothing like that. So we called the patient and we asked him to visit the department, and we examined the patient. So what we found on examination, there was a right submandibular swelling, which was asymptomatic, and it was present since 2 years. And patient gave history of a previous FNAC, which was unremarkable. However, we were curious to know the exact pathology of this submandibular swelling. So we repeated FNAC in our department. So we surprised to see the aspirate because it was classical of adenoid cystic carcinoma. So you can again see here the basaloid cells, oval to round with angulation, some tubules-like structures, and again hyaline globules or gumballs, which were lined by basaloid cells. And there was some hint of cribriforming as well. So though it is a classical case, we are not required to use any specific stain or IC on these kind of cases. But if we are dealing with a solid variant of cribriform, adenoid cystic carcinoma, in that case, we may require some ISC. But due to some curiosity, we prepared cell block and we applied some ISC on the cell block. As we all know that adenoid cystic carcinoma is biphenotypic in origin. It has both epithelial and myoepithelial component. So it gives positive staining for both types of markers, that is myoepithelial and epithelial. So we applied for various ISC on cell block including some myoepithelial markers and some epithelial markers. So it showed positivity for various myoepithelial markers, for example, P63, S100, SME, and it was diffusely positive for CK. As we know that adenoid cystic carcinoma frequently show positivity for CD117, though it is not specific for adenoid cystic carcinoma and can be seen in other tumors as well. For example, few cases of pleomorphic adenoma or epithelial myoepithelial carcinoma. So we used some specific stain as well. So recently, it is known that these tumors present with a specific translocation, that is translocation between 6 and 9 chromosome, that is MIB versus NFIB gene. And now we have markers for this, surrogate marker for this particular translocation, MIB. So we used this ISC for this tumor and it was diffusely positive. So it gives more strong positivity to the myoepithelial. So this way we confirmed our diagnosis as metastatic adenoid cystic carcinoma. So we published this case in as a Enigma portal case in Cytopathology journal. So I'm presenting one more case, similar case, but with primary diagnosis in a salivary treatment, especially the minor salivary treatment. So we had a case of 31-year-old male who presented with right palatal swelling for 4 months. So you can see this bluish discoloration in the right side of the palate. This part is bulging as compared to the left side of the palate. So we performed FNAC from this area. CT scan also shows some mass lesion lying above palate and infiltrating palate. So when we performed FNAC, we had similar picture as we had in our previous case, comprising of hyperchromatic basaloid cells with round to oval nuclei, absence of mitosis, inconspicuous nucleoli, and we can see the architecture of this tumor. There were, some trabeculae, some tubule-like pattern interconnecting tubules. So when we went through some other areas, we could also find numerous gumballs or these hyaline globules with the presence of basaloid cells around them, and many bare nuclei in the background. So there were more and more number of these hyaline globules in some of the areas with fair number of bare nuclei in the background. So when you have this kind of material, which is easily found sometimes, the diagnosis is not difficult in adenoid cystic carcinoma. So whenever we are dealing with a classical adenoid cystic carcinoma, we are not required to differentiate it from other basaloid tumors. And even IC is not required, and this diagnosis is straightforward. Whatever the site, we should think about this tumor because though they are indolent, but they can metastasize even after 10 years of diagnosis. So on metachromatic stain, you can beautifully identify these globules lined by or cupped by basaloid cells. And this globule is giving a syncytium-like pattern. So this kind of pattern is very common. So this is the beauty of cytology, where we have three-dimensional structures with syncytium-like pattern, which is easily identified in adenoid cystic carcinoma. So this material looks greenish in color on PEP stain, pink in color on H&E, and magenta color or purple color on MGG stain. So it depends on the stain which you are using in your lab. So you should able to identify these globules easily depending upon the stains you are using in your lab. So we performed again the same ISC with strong positivity for MIB and CD117. So this was a case of adenoid cystic carcinoma of minor salivary gland involving palate. So if we talk about secondaries of liver, so most of the time we are dealing with adenocarcinoma, metastatic adenocarcinoma with primary arising in the GI tract, most frequently in the colorectal. reason. And second to this, there could be pancreatic cancers or some neuroendocrine tumors. Sometimes we are dealing with small cell lung carcinoma. It is even much more common than other tumors. Sometimes even melanoma or germ cell tumors could be seen in the liver presenting as metastatic disease. So radiologically, if we have multiple lesions, so it is an indicator of metastasis. And when there is solitary lesion, we should think about hepatocellular carcinoma or other primary of the liver. So when we talk about adenoid cystic carcinoma, how frequently this malignancy involve other organs? So most commonly it is involving lung, followed by bone, brain, and then liver. So as I told you, it is an indolent malignancy which may persist for years without any symptoms, especially when it is involving submandibular gland, because submandibular gland doesn't have any major nerve, because these tumors have tendency to involve nerve frequently. So when they involve parotid gland, they are more symptomatic and they are easily diagnosed at early stage, but it doesn't happen with the submandibular gland. So in our case, the patient did not notice his primary due to asymptomatic behavior of the primary, and then patient presented with liver metastasis after many years. So what could be various differentials of basaloid tumor in liver? There are various basaloid salivary gland malignancies which can have some mimicry with the adenoid cystic carcinoma. First of all, first one is polymorphous low-grade adenocarcinoma. However, this malignancy has some papilloid clusters, and the material, the hyaline globules, though they are there, they are less in amount and they are smaller in size as compared to adenoid cystic carcinoma. And then if you have any doubt, you can use ISC, which is not showing adenoid cystic marker, particularly MIB and CD117. Now this malignancy is known as polymorphous adenocarcinoma because it is no more considered as low grade. Then coming to the basal cell carcinoma, they are again having indolent course and presenting in the 6th to 7th decade of the life, and most frequently involving parotid gland, and they can also metastasize. However, again the hyaline material is less as compared to the less in amount as compared to the adenoid cystic carcinoma, and the cell is otherwise basaloid. Then coming to the epithelial myoepithelial carcinoma, so it is biphenotypic, having both epithelial and myoepithelial component, but in this particular tumor, myoepithelial component is showing clear cell change frequently. So we can easily demarcate biphenotypic nature of this tumor on morphology alone, and these are less common as compared to other neoplasm. So they can be differentiated on the basis of morphology sometimes. However, when we are dealing with solid variant of adenoid cystic carcinoma, we cannot delineate other differentials from adenoid cystic carcinoma on morphology alone. We are signing out these tumors only as basaloid malignancy or basaloid tumors with malignant potential. Coming to the next case, case number 4, which belongs to a 27-year-old male who presented with a progressively enlarging left thyroid nodule with normal thyroid profile, and the size was around 2.5 into 1.5 centimeter with presence of cervical lymph. So it was not very big in size. We aspirated the swelling. So what we found on cytopathology, on scanner view, we could see that star-like structure was there comprising of many or multiple papillae, which are lined by columnar cells or elongated cells having fibrovascular course. So going to other areas, we could see that the lining cells are not single layered, rather there is stratification of nuclei. Then we went ahead on other areas and we increased the magnification. We used oil magnification. So on oil magnification, it was quite clear that there is nuclear stratification lining these papillae. Even on MGG staining, we could see papillae with nuclear stratification around them. On oil magnification, we could identify some palisading cells or picket fence cells showing columnar configuration. And some of the nuclei, though only few of them had nuclear groove as well, and very occasionally only few nuclei show intranuclear groove. So we prepared cell block because we were not sure whether it is primary or some other secondary tumor metastasizing to thyroid gland. We applied some specific ISC. So this tumor was strongly positive for thyroglobulin and TTF1. However, it was negative for CDX2 and BRAF ISC. So on the basis of morphology and ISC, we made the diagnosis of columnar cell variant of PTC. Why it is important to differentiate this particular variant from other variants, as we all know, there are multiple or many variants of papillary thyroid carcinoma. So this, luckily, this case was followed by excision, and we could again confirm our finding on histology with presence of columnar cells lining these papillae, the nuclear stratification and cytoplasmic vacuolation, supranuclear or intranuclear vacuolation. So there are a few review articles who have beautifully described various different variants of papillary thyroid carcinoma and their approach in cytology on the basis of capsule, pattern of stroma, and the cell morphology. And why these different variants of PTC are important to know. And why are they important if we are able to differentiate them on cytology? There are more than 10 types of papillary thyroid carcinoma, and few of them, around 5 of them, are aggressive clinically, and columnar cell variant is one. So what are these aggressive subtypes of PTC? Tall cell variant, which is characterized by tall cells with height and width ratio of 3:1. Columnar cell variant, which is characterized by nuclear stratification and hyperchromasia instead of clearing of nuclei, and with less features of nuclear features of papillary thyroid carcinoma as compared to other variants. Then coming to the Hobnail variant, which is characterized by micropapillae, which are lined by the cells with the reverse polarity of the nuclei, which are projected and bulging through the inner surface. And if this population is more than 30% of all neoplastic cells, showing some Hobnailing, it is known as Hobnail variant of papillary thyroid carcinoma. Diffuse sclerosing variant of the papillary thyroid carcinoma is characterized by 3-dimensional clusters of follicle with some Hobnailing again. However, these tumors are characterized by frequent or fair number of semoma bodies along this squamous differentiation. Then coming to the solid variant, which is again an aggressive variant of papillary thyroid carcinoma, which presents with solid or trabecular growth pattern. However, this tumor doesn't show papillary or follicular formation with absence of colloid and necrosis. But these tumors frequently present with nuclear features of papillary thyroid carcinoma. So they are easy to identify if we are sure about absence of papillary or follicular architecture. So all these variants are aggressive variants, and they frequently present with various mutations, specifically BRAF mutation, which is frequently associated with these aggressive tumors. If we talk about columnar cell variant, this tumor is confused with the metastatic tumors, metastatic adenocarcinoma, specifically GI tract, due to nuclear stratification and due to presence of some nuclear and supranuclear vacuolation. This may be confused with the secretory endometrium or endometrial carcinoma metastasizing to thyroid. and around 50% of these tumors, they present with CDX2 expression. However, in our tumor, CDX2 was negative, and they also present frequently, around 1/3 of them, with BRAF 600E mutation, which can be confirmed by the ISC, though it was again negative in our case. Case number 5, a 42-year-old woman presented with a right thyroid nodule for 2 months of 3 into 2.5 centimeter, which was accompanied by right submandibular swelling, which was relatively older, having around 8-year history and measuring around 5 into 3 centimeters. So there was double swelling or dual swelling side by side, one in the thyroid and one in the submandibular region. But clinically, patient was suspected to have thyroid malignancy with submandibular metastasis. On ultrasonography, submandibular swelling could not be correlated with the submandibular gland because it was separate from the submandibular gland. However, it was having hypervascularity, which was confirmed on Doppler. So we did FNAC from both the sides. FNA from thyroid showed colloid goiter. However, aspirate from submandibular swelling showed moderate to highly cellular smears with follicular arrangement of the cells. On going high power, we could further confirm the presence of follicles, nuclear enlargement, nuclear overlapping, ill-defined to well-defined cytoplasmic boundary, and some of the cells showed eccentric location of the nuclei. On Pap stain, there were same findings with stipple chromatin, and some of the nuclei also show prominent nucleoli. And there was some abrupt enlargement of the nuclei as well. So we could find occasional intranuclear infusion as well, and cytoplasm of few of these cells showed pink granularity. So on the basis of these features, we were in difficulty whether it is primary of thyroid or some other neoplasm. So we thought about neuroendocrine tumor as well, specifically paraganglioma, and we had 1 or 2 extra unstained smears. We applied chromogranulin staining, which was diffusely and strongly positive, and we confirmed our diagnosis of paraganglioma. Because this tumor was having very long history of around 8 years, which is not practically common with the metastatic malignancy if primary is there in the thyroid. So this was one of the clues in favor of paraganglioma. And on thyroid FNAC, there was nothing like any well-differentiated malignancy. So we considered this diagnosis. So what are paragangliomas? These are the neoplasm which arises from clusters of neuroendocrine cells in association with sympathetic and parasympathetic nervous system. These tumors include pheochromocytoma, carotid body tumor, and other extra-adrenal paragangliomas. And they have widespread distribution because there are many single case reports in series of cases which have shown involvement of various organs, including thyroid, with paragangliomas. So they can have their presence at various sites and may involve many organs in our body. But they create lots of problems, especially when they are associated with or they are in close relation with the thyroid, because it has much resemblance with the thyroid malignancies, especially follicular neoplasm due to their follicular architecture, which is frequently seen with paraganglioma, and due to presence of intranuclear infusions or sometimes some papillary configuration. They are also confused with papillary thyroid carcinoma. However, optically clear nuclei, and there are some other features of papillary thyroid carcinoma and presence of some colloid. They help us to differentiate papillary thyroid carcinoma from paragangliomas. Then, due to presence of plasmacytoid appearance and presence of stipple chromatin being granules and inclusions, and sometimes abrupt pleomorphism and anisonucleosis, these paragangliomas can also be confused with metastatic medullary thyroid carcinoma. However, if we can prepare cell block, we can do some ISC, particularly calcitonin and TTF1, which is frequently seen with medullary thyroid carcinoma and may help us to differentiate paraganglioma from medullary thyroid carcinoma. And sometimes some metastatic malignancies, adenocarcinomas, may also be confused with paraganglioma. However, metastatic adenocarcinoma have very bad-looking nuclei sometimes. Even well-differentiated adenocarcinoma can have coarse chromatin, prominent nuclei, and sometimes some other degenerative changes like necrosis could be there. And these all features may help us to differentiate metastatic adenocarcinoma from paragangliomas. So the take-home message is, whenever we have this kind of tumor at some unusual location or in basically relation with some other vital organs, we should consider paraganglioma as one of the differentials, and especially we should look for chromatin carefully and other features which are frequently seen with paragangliomas, and then we can reach to the diagnosis easily. Coming to the case number 6, which is a case of 58-year-old male who presented with a left maxillary and palatine swelling for 3 months history. And the patient also presented with history of nose bleeding and recent tooth extraction. CT scan also showed a huge mass in the maxillary sinus, showing some signs of aggressiveness, destroying some nearby structures, ethmoidal bone, orbital plate, and pterygopalatine fossa with destruction of little border of maxillary bone. So it was very aggressive clinically. So we could easily find some bulging in the palatal area and bulging in the maxillary region. And there was presence of one cervical lymph node as well, left-sided. So we performed FLHC from all those bulges. And what we found basically again a round cell tumor. However, this round cell tumor is different from the previous one that was evil sarcoma, having some uniform morphology, but here we can easily delineate pleomorphism. So some of the nuclei are smaller, other are larger. Their chromatin is not very stable. It's fragile, showing some melting and tangling. So this tumor definitely looks aggressive on cytology as well. Background is hemorrhagic, and there is indiscernible cytoplasm as well. Many bare nuclei and some inflammation is associated with this tumor also. So you can easily look for the type of chromatin they are showing here, which is definitely fragile and showing melting and tangles of chromatin, very coarse chromatin, and you can see some gland-like arrangement as well, acini or gland-like arrangement. On Pap stain, you can see the chromatin is coarse with clear number of mitosis and apoptosis, few eccentric nuclei, binucleation, and some hint of spindling. So one of the aspirate also showed good indication of spindling, and chromatin is definitely coarse in this smear as well. So we were confused, though we could see that it looks like a round cell tumor with some aggressive features. However, we could not confirm whether it is carcinoma, sarcoma, or lymphoma. So we prepared cell block, and we could find some vascular structures which were lined by cells, and there was some peritheliomatosis pattern seen in the cell block. We used battery of panels, IC markers, including CK, which was weakly positive. However, to my surprise, Vimentin was negative with positive internal control. P63 was negative again. There was weak positivity for CD99, for synaptophysin, and there was maintained INI1, weak positivity for FLI1, and definitely there was strong positivity for desmin myelin. So we thought about alveolar rhabdomyosarcoma, however, we could not see any alveolar arrangement. We thought about solid variant of alveolar rhabdomyosarcoma. However, we also put a possibility of, SNUC, sinonasal undifferentiated carcinoma with rhabdomyomatous differentiation. However, we went through some papers which have claimed that there could be rhabdomyosarcomatous differentiation in SNUC, but it is only focal. But in our case, there was diffuse and a strong positivity for desmin and myelin. So we put alveolar rhabdomyosarcoma over SNUC in our case. So this case was followed with the biopsy, and the biopsy showed intact mucosa with some mucosal solid tumor having around 2 oval component and many vascular structures which were lined by these cells. So there was definitely some rosetting or perivascular arrangement of these nests, some geographic necrosis, spindling. So all these features were there. However, alveolar structures were missing. So again, we confirmed this case as alveolar, solid variant of alveolar rhabdomyosarcoma, because ISC again showed almost the same profile which we had on cell block, including some new markers, some more markers like P16 diffusely positive, CK7 though it was negative with internal control showing positivity, Vimentin was again negative, and again desmin and myelin was diffusely and strongly positive. So we went through the literature and we could find some beautiful papers by Lester, D.R. Thompson. It was a very good review article about a round cell tumor of sinonasal tract. So they have put many carcinomas and some non-carcinomatous tumor as presenting as round cell tumor in the sinonasal tract. So there is a long list of these tumors, like including melanoma, rhabdomyosarcoma, nut carcinoma, neuroendocrine carcinoma, and small B1 tumors, carcinomas, deficient carcinomas, then lymphomas, olfactory neuroblastoma, even sarcoma, and pituitary adenomas. So it's a long list why these tumors are different and why it is important to differentiate from each other. Because around 30-40% of these tumors are having very poor prognosis, and patient may die within 2 years of the diagnosis. That's why it is important to differentiate them from each other. But suppose if we are dealing with a case of even sarcoma, which can have a good prognosis, even rhabdomyosarcoma are doing better than SNUC, and nut carcinoma are again very bad prognostically. Neuroendocrine carcinoma could be better than other tumors. So depending upon their aggressiveness, they are differentiated clinically. So they have also presented, their nuclear features, cytomorphological features, and even their ISC have been discussed in the paper. So we have also tried to use these markers in our cell block as well as on the biopsy block. And most of these markers were, either focally positive or negative, and they were all in favor of rhabdomyosarcoma. But I could not understand why the Vimentin was negative in rhabdomyosarcoma. So this is still a question for me. So what is the pitfall of alveolar rhabdomyosarcoma? Though it is positive for myelin and desmin, but there could be aberrant expression of various other non-rhabdomyosarcomatous markers, like neuroendocrine markers, some cytokeratins, and there could be positivity for CD99, and they can also show positivity for some lymphoma markers as well. So we should be mentally prepared for this whenever we are dealing with such a round cell tumor and with the aberrant expression of various markers, including some rhabdomyosarcoma markers, we should think about solid variant of alveolar rhabdomyosarcoma in such cases. And they have shown that rhabdomyosarcoma positivity for P16 and Fly1 as well, which are otherwise considered positive in other tumors. And the same group also presented one research articles having 52 cases of alveolar rhabdomyosarcoma, where they studied for epithelial immunoreactivity, and they frequently seen reactivity for cytokeratin and even for the synaptophysin in their article. So it was an interesting case. Though we could not perform molecular studies, otherwise this is the specific translocation, that is FOXO1 versus PAX3 or PAX7, which is usually seen in around 70 to 80% cases of alveolar rhabdomyosarcoma. If we are able to find this translocation, this is of diagnostic importance. Coming to the last case, which belongs to a 19-year-old young boy who presented with right parotid swelling again, with very good morphology, showing some glandular or nesting pattern with the colloidal background, proteinaceous background, and with frequent papillary structures in other areas. Cells were relatively larger in size as compared to the basaloid tumor, so we put this tumor into oncocytoid category, and we have a long list of oncocytoid tumors which are presenting as salivary gland tumors. On going higher magnification, we could see that there was uniform granular chromatin or vesicular chromatin with prominent nuclei and with moderate to abundant amount of vacuolated cytoplasm. So there was some clue of mucin as well. And what was unique for us, the background on MGG stain, which was metachromatic, just like we have in the thyroid, with presence of colloid, with moderate to abundant vacuolated cytoplasm. So many of papillae show fibrovascular pores with more vacuolation or more clearing of the cytoplasm. So again, the cell block was prepared, and it showed a similar picture with presence of papillary architecture and abundant clear cytoplasm with some cystic areas. Going higher, it shows papillae, vacuolated cytoplasm, more vacuolation or clearing of the cytoplasm. So if we have this kind of morphology in a parotid gland or salivary gland FNAC, we should think about oncocytoid neoplasm, particularly actinic cell carcinoma or sometimes mucoepidermoid carcinoma. But believe me, these neoplasm are different from the rest of the other neoplasm of parotid or any other salivary gland. So we had a suspicion of something uncommon seen in the parotid or other salivary gland, that is secretory carcinoma. So we used some specific stains for secretory carcinoma. S-100 and hemoglobin was diffusely positive in this case. So we confirmed our diagnosis as secretory carcinoma or memory analog secretory carcinoma, previously known. And the patient was operated, and incision was sent to the department with similar picture, frequent cystic, microcystic areas filled with secretions, vacuolated cytoplasm, and this kind of papillae were also present on biopsy. So we used a panel for actinic cell carcinoma and some other differentials covering all those common tumors which are differentials. So again, DO1 was negative, S-100 was diffusely positive, hemoglobin was again strongly and diffusely positive. So it's an entity which is rare in the salivary gland tumors, and it shares an histological and genetic profile with a similarly rare malignancy breast secretory carcinoma. So we had one more case of secretory carcinoma with some difference from the previous case. This particular tumor had, lymphocytic infiltration in the background. Sometimes these tumors, including other oncocytoid tumors, may have lymphocytic background. So it is not uncommon. And this tumor was mistakenly diagnosed as Borden's tumor rather than secretory carcinoma. So you should keep in your mind that whenever you are dealing with such tumors showing papillary, glandular, or solid architecture with oncocytoid cells having abundant vacuolated cytoplasm and prominent nucleoli, and in particular the background which is colloid-like, then you should think about secretory carcinoma, and you should prepare cell block. You should use the specific ISC for confirmation. So all these tumors are basically put under differentials when we are dealing with secretory carcinoma, including pleomorphic adenoma with oncocytic features. But believe me, these tumors are not like a secretory carcinoma. You can easily identify secretory carcinoma once you go through 1, 2, or 3 cases. This much experience is sufficient to diagnose these cases on morphology alone. And actinic cell carcinoma is particularly put under, differentials, and literature particularly favors actinic cell carcinoma in the first differential of secretory carcinoma, and we should always use TOP1 as one of the markers to differentiate actinic cell carcinoma from secretory carcinoma. Besides primaries of salivary gland, you should also think about some secondary metastatic tumors, specifically from kidney, and we can also use some kidney markers to differentiate these salivary gland tumors from other metastatic tumors. And this particular tumor, if we have any problem with the diagnosis, it has specific translocation, which is frequently seen in the secretory carcinoma, that is ETV6 NTRK fusion, which can be confirmed by doing FISH. So this was all about my presentation. I would suggest to go into detail of history, presentation, and we should try to prepare cell block wherever it is possible, because it is always there that we can have multiple differentials in our mind. But if we have proper history, adequate history, and if we examine patient carefully and we use ISC panel very carefully on cell block, we can reach our diagnosis without any problem. So thank you so much for patient listening. If you have any query, please. Thank you.
Thank you so much. Thank you so much, sir, for this knowledgeable lecture. Thank you so much for this informative talk. Now, we request our chairperson to kindly introduce our second speaker for this session, Dr. Atul Gupta, sir. We welcome you, sir. Sir,
Dr. Atul Gupta needs no introduction in this region. We all are aware of his interesting talks. Now we shall be hearing his presentation. Please proceed.
Good evening, everybody. Thank you so much. I think I must apologize right at the outset because of the delay which I have engendered. And lots of thanks are due. Number one, I hope I am audible. Hello, I hope I am audible.
Yes, sir, you are audible.
Yes, thank you so much. Thank you so much. Well, lots of thanks to the organizers for allowing me to rant and rave for the next 45 minutes. To my teacher, Dr. Dilip Das, who taught me FNAC in a workshop. My patients who have allowed me to proceed ahead, and to all of those who have helped in the preparation of this PPT. So I proceed ahead now, straight for the jugular. Yeah. Yeah, so that's the first case. And you can see that this lady has a rather large lump in the right hypochondrium. And she had an ultrasound also. And one can see that this is a large mass in the liver. In fact, she had two masses. And which were aspirated. And prior to that, she had an ultrasound report of a mass liver, which I'll not encumber you with. And this is the aspirate. And firstly, I must say that this was an aspirate done by a sonologist. And often the smears are suboptimal. I just gave the smears out, had a look at them under the naked eye, and selected two of them. And they were all deadly hemorrhagic. But this one, under the microscope, showed a few areas of necrosis. And necrosis triggers off a thought process. One, is it coagulative necrosis or is it caseous necrosis? Here I can't see the outline, the ghost outlines of the cells, so it appeared to be caseous, reminiscent of tuberculosis. But then amidst the sea of blood, we could get some other cells. And this is a cellular aggregate, clearly epithelial, the cells sticking around. And it appears to be a carcinoma clearly, and the cells seem to be forming some luminal structures, so reminiscent of an adenocarcinoma, which is usual in the liver. And then we scrutinized the slides. We checked the slides under the microscope, unstained slides, not the stained ones. And in one of these, we hit the jackpot, and we stained it. And what is it now? I think my talk is basically directed towards the junior people. Dr. Anurag has done the potpourri. He has dished out all the puris, and it's now time for me to dish out the pan. Okay, so please, there will be very little IHC, etc. And see, this is clearly a large cell lymphoma. My purpose in showing you this slide are two or three purposes. One, this is a large cell lymphoma, the dispersed cell population. They are large cells, more than twice the diameter of a small lymphocyte, fair amount of cytoplasm, some cytoplasmic vacuoles, and that's fine. So this could also be a granulocytic sarcoma, remember. Large cell lymphoma, granulocytic sarcoma, they look alike. Mitotic activity is seen, and lot of apoptotic debris is also seen. Now, this, remember that in a lymph node at least, if you see a lot of coagulative necrotic debris, the first thing we think about is a lymphoma. The second is a metastatic carcinoma. Lymphomas usually non-Hodgkin lymphomas. And so this was a case of large cell lymphoma with extensive necrosis in the liver. And initially tuberculosis was concerned. Metastatic carcinoma looked quite likely, in fact adenocarcinoma, but careful selection led to a diagnosis of large cell lymphoma, and the difference in outcome, difference in therapy would be huge, because lymphoma would be treated by chemotherapy and metastatic carcinoma means that it's over and out. So the lessons we learn is that extensive necrosis could be due to tumor, could be due to inflammation, for example tuberculosis. Number two, that extensive coagulative necrosis favors lymphoma over carcinoma. And finally, select slides carefully for staining. May scrutinize under the microscope the unstained smears if it helps, rather than staining one score slides and finding only one slide useful. Next case. This showed a 50-year-old female, and we can see that the right cervical nodes, lower ones, a fair bunch, and you can see one needle mark from a large node and an other mark from a smaller node. Do please remember that large nodes flatter only to deceive. The yield is generally quite dismal because they undergo secondary changes, which means necrosis occurs, fibrosis occurs, and both of them hamper aspiration. The smaller nodes are to be chosen if possible. And this was the aspirate. And what do we see here? We see a dispersed cell population. Now, dispersed cell populations generally lead us to think about hematolymphoid neoplasms, melanomas also, medullary carcinoma also, but generally by and large, most carcinomas give us aggregates of cells. In fact, and under higher power, we can see the detail of the cell doesn't really conform to any particular type of lymphoma, though dispersal is good. But when you diagnose lymphoma, you must be able to classify it. If you can't classify a lymphoma, be careful in calling it a lymphoma. And so the diagnosis, well, this patient had been aspirated previously somewhere almost 4 months back, and it was diagnosed as a lymphoma, probably of large cell type. The second aspirate, which was less cellular, which we had conducted, it shows clear-cut cellular aggregates. And I think it is quite obvious now that these cellular aggregates belong to a carcinoma and not to a lymphoma. And in fact, we had intracytoplasmic mucin also. And X-ray test showed a right hilar mass, which is quite obvious here. So it was a primary from the lung. So the lessons are that it looked like a non-Hodgkin lymphoma, went on to become adenocarcinoma. Remember that primary tumors from certain sites, adenocarcinomas, may give rise to a dispersed cell pattern. And this includes breast, especially lobular carcinomas, stomach signet ring cell carcinomas, and sometimes the lung. Whenever we see dispersal, please do not call it a hematolymphoid lesion stat. The cells must also look hematolymphoid. And another lesson which was a corollary is that two cellular aspirates may also pose problems which can be solved by some dilute aspirates. Sometimes the staining itself is a problem also in very cellular aspirates. And I move ahead straight to the third case. Now, dispersed cell population. Most of the cells do not appear to show any cytoplasm. They appear to be bare nuclei. We see a starry sky macrophage, tingible body macrophage, and lots of apoptotic debris again. So impression at this level, it could be a lymphoma. Clinical data 76 may left upper cervical lymph node solitary. Next slide shows two things. One, the cells were grouped, at least some of them. There are lymphoglandular bodies reinforcing the impression of lymphoma, and reinforcing again is a cell with intact cytoplasm, looks blastic with a notched nucleus. The discordant feature is the presence of these cell aggregates which make us think of carcinoma. So it's 50-50. Another area again showing very distinct aggregation of cells. Finally, we have another area where there is very little doubt about the epithelial nature of this malignancy. The earlier lymphoglandular bodies and blast-like cells notwithstanding. Another thing I would also like to see, and this aggregate shows you some luminal formation, looks like an adenocarcinoma. Just remember that in the upper aerodigestive tract, especially the nasopharynx, oropharynx, base of tongue, you tend to get very poorly differentiated squamous carcinomas, and there often one tends to get this sort of a picture wherein luminal formation is apparent. Other thing is that there are lots of apoptotic bodies. Do remember that only a few lymphomas have a lot of apoptotic bodies. Anaplastic large cell lymphoma, Burkitt's lymphoma are two which come to my mind. Immunoblastic lymphomas. If you find something which looks like a lymphoma and has abundant apoptotic bodies, it must conform to one of these three. Otherwise, the possibility of carcinoma mimicking lymphoma would be reinforced. And this patient we correlated clinically. It was a solitary node, so unlikely to be a lymphoma. CT scan revealed something in the epiglottis. The arrow is there and it shows us a marked thickening of the epiglottis. So probably that was the primary. So the lessons from this slide are that bare nuclei may hoodwink us into believing it is a lymphoma. Therefore, diagnose lymphoma only on intact cells. Lymphoglandular bodies are really not conclusive of lymphoid tissue. And small cell anaplastic carcinomas are notorious for giving rise to structures which mimic lymphoglandular bodies. Apoptotic bodies are found only in few lymphomas, the types which I have just enumerated. And cohesion is uncommon in lymphomas, must finally correlate clinically, otherwise one can land in great trouble. Next case, and this was a subject who had generalized lymphadenopathy, a 55-year-old male into 4 months. Left cervical lymph nodes were aspirated. So what do we see here? A very cellular aspirate, rather remarkable monotony of the cells, fairly coarsely clumped chromatin. So these things favor a lymphoma. Because of the chromatin clumping, it is likely to be low grade, probably a small lymphocytic lymphoma, maybe. Next field shows us 3 arrows. Now, the blue arrow shows you a clump of cells, which are the predominant cells here. And these have very coarsely clumped chromatin like a plasma cell, negligible cytoplasm. These are the dominant cells. If all the cells would have been like this, it would have been easy to make a diagnosis of small lymphocytic lymphoma. Remember that this exaggerated clumping of chromatin is fairly characteristic but not absolutely conclusive of a SLL or CLL. Additionally, we find something which might make us think of a reactive node. One is the cell at the center, black arrow. This is slightly larger. The chromatin is clumped, though not to that extent, shows a distinct nucleolus and slightly more cytoplasm. This is a pro-lymphocyte characteristic description. And the orange arrow is at the base is pointing towards 3 cells which are clearly blastic, have not only nucleoli, but also a dispersed chromatin. And they are quite large. So these are blastic cells. In the context of a small lymphocytic lymphoma, the black arrow points towards a prolymphocyte, the orange arrow towards a paraimmunoblast. Now, presence of a dominance of small lymphoid cells along with a few large lymphoid cells may make us think of a reactive follicular hyperplasia. Please correlate clinically. This person has a generalized adenopathy of at least 4 months duration. Remember, low-grade lymphomas are high-stage affairs, and since they are rather indolent, the history is also pretty long. And these prolymphocytes and paraimmunoblasts are those cells which we find in the follicular growth, pseudofollicular growth centers in a SLL. So, a lymphoma with small cells, we have a list of differential diagnoses. One is SLL, and its first cousin, lymphoplasmacytic lymphoma, in which a few cells show plasmacytoid differentiation and plasma cells, few of them. Follicular lymphoma looks just like that because it has a predominance of small cells, but a few large lymphoid cells, as we saw in the previous case. The distinction would rest on the fact that the nuclei are cleaved. The small cells have cleaved nuclei in a follicular lymphoma. Mantle cell lymphoma also has cleaved nuclei. Unlike a follicular lymphoma, there is a total paucity of the larger lymphoid cells. It is monotonously small lymphoid. Marginal zone, there is a mixture of cells, including plasma cells, including some cells which appear monocytoid. And these 3 I am just going to forego. These are the red. These are all T cell lesions. Lastly, lymphoblastic is not a small one, it's intermediate size, but the difference between small and intermediate is not spectacular, so it might be constituted to be a small cell thing. In fact, it was culled out from poorly differentiated lymphocytic lymphoma category in 1974. So it was included in the lymphocytic category previously. And remember that lymphoblastic lymphomas show abundant mitosis, which is missing in all the white entities which I have listed. So the diagnosis was a small lymphocytic lymphoma, probably mimicking a reactive follicular hyperplasia to some extent. So we went for the blood smear. Remember, whenever you have a patient with generalized adenopathy, please draw blood smears. They can work, they can give you very useful data. Flow cytometry जैसा ही काम कर सकते हैं. And you see here in this field, there are half a dozen lymphocytes. So lymphocytosis, there is a smudge cell also towards the base. That means that it is a neoplastic lymphocytosis. Another area showing 3 lymphocytes and the clumping of the chromatin characteristic for small lymphocytic lymphomas, and 2 smudge cells now here in this field can be seen. So I think anyone who looks at hematology would be able to make a diagnosis of CLL on the blood smear. Remember that small lymphocytic lymphomas on lymph nodes, most of them will have involvement of the blood smear. They are in fact CLLs. Whereas for lymphoblastic lymphomas, the reverse is true. So this was our diagnosis. And again, emphasizing that blood smear examination can provide critical evidence. And this is a 58-year-old female, again generalized lymphadenopathy, hepatosplenomegaly. So clinically, this is a low-grade lymphoma because it is high stage. Let us have a look. Cells are again small, monotonous small cells, hardly any large cells, but the the monotony is interrupted by the presence of these are the histiocytes, starry sky histiocytes. So that is an additional feature which we got in this case. Mitotic activity is really not discernible at this far, monotonous with starry sky macrophages. Now remember that small cell lymphomas do not usually have starry sky macrophages. SLL did not have one. Lymphoblastic lymphomas can have this appearance, starry sky macrophages, because there is a high turnover. In mantle cell lymphoma, remember the turnover, despite not being very high, so some mitosis are seen, does give rise to these and some blood vessels also. Let us zoom under high power. And you have 2 things here. One, there is an arrow which is pointing towards the mitosis. Now, mantle cell lymphomas generally have significant but not outrageous mitotic activity. And the circle is pointing towards many cells with notched or grooved nuclei. And this is not a feature of small lymphocytic lymphoma. It can be a feature of low-grade follicular center cell lymphomas. However, there we would have some larger lymphoid cells too, at least some. Here, larger lymphoid cells are conspicuous by their absence. So this appears to be a clear-cut case of a mantle cell lymphoma. One can do the immunos and the molecular markers, cyclin D1. So that's it. So that was our diagnosis. Now, this is a picture from a very old case, and it shows us 3 types of cells. One, this is a small lymphocyte, normal residual small lymphocyte. The dominant cell population is slightly larger. They are again included in the category of small lymphoid cells, but you can see that the chromatin is a wee clumped but less clumped, and nice buttocks. Rather, I must say grotesque. So notching of the nuclei, angulation of the nuclei, this is characteristic of centrocytes. Were these cells not admixed with these 3 larger cells, nucleated blast-like cells, we could have called it a mantle cell lymphoma. But admixture of these 3 larger cells immediately puts us on the track of a low-grade follicular lymphoma, or maybe a reactive follicular hyperplasia. However, in a reactive follicular hyperplasia, so much notching would really not fit in. So this is a low-grade follicular lymphoma. That is the picture in aspirate, and they can pose a lot of problems in the differential diagnosis from a reactive follicular hyperplasia. Again, if you have a problem in differential diagnosis, take a blood smear. You might be lucky. Remember that follicular lymphomas spill with significant frequency into the blood smear, and you get cells which are known as buttock cells or lymphosarcoma cells about 50 years back. You can see this nice notching which was there. It has been amplified, in fact. It's almost a complete cut. And this red square, it shows us red cells. Now, these are the normal red cells with the central pallor. But observe that at least 3 cells are very significantly smaller, almost half the size or 2/3, and they're lacking a central pallor. So these are spherocytes, and they're not only confined to this area, they are dime a dozen here, here. This is a fragmented cell with which is a spherocyte again. So there is spherocytosis also, and spherocytosis, remember, is a feature of autoimmune hemolysis, and autoimmune hemolysis occurs in a significant minority of hematolymphoid neoplasms, especially Hodgkin's lymphoma and chronic lymphocytic leukemia, but also in other lymphomas. So we have almost got a clear-cut diagnosis. Flow cytometry need not be done, I suspect, in such a case. So this is a low-grade follicular lymphoma. And the lessons are that when the cell population is mixed, as it was in this case, reactive follicular hyperplasia may be a consideration, but low-grade follicular lymphomas are very high-stage affairs. Generalized adenopathy, splenomegaly, long duration. So even if you render a diagnosis or wrong diagnosis of reactive follicular hyperplasia, not much harm would be done because the clinician would immediately throw that out of the window. And the follicular lymphomas are usually high stage. That's what, and examining the peripheral blood smear, I say again and again and again, for those who do a lot of lymph node FNACs, it would be prudent to spend some time, if it has not already been done in hematology. It will pay massive dividends. Next case was a 21-year-old female, right posterior cervical lymph nodes, 3 in number, measuring 1 centimeter. So it's a trivial lymphadenopathy, 10 days onset, and she was febrile for the first 3 days. So classically it is reactive. May not do an FNAC, but the problem is that sometimes the patient's attendants or the patients themselves, they are very anxious because someone in the family had lymph nodes and was found to be malignant. And this is what we got in the aspirate: dominance of small lymphocytes clearly, but right at the center you get 3 large cells, blastic cells, a fair amount of deep blue cytoplasm and a HOF to boot. So these are all immunoblasts. So small cells, large cells, suspicion of reactive was already there, a plasma cell also. So this is an immunoblastic and plasma cellular reaction in a reactive lymph node, and you should think in terms of viral lymphadenitis at this juncture. Remember also that this lady is 21-year-old female, and must consider the kissing disease, infectious mononucleosis, for which appropriate serology can be ordered. Monospot test was ordered, was found to be negative, but we have gone ahead with Epstein-Barr virus serology, and results are awaited. Must tell you that most of the cases, Dr. Fayaz told me at about a month back, so most of the cases have been culled during this time. Follow-up might be a bit deficient. And this was a blood smear. So to those who are familiar with blood smears, this is a usual small lymphocyte. These two are downy cells. Abundance of lymphocytes, some molding by the adjoining red cells. Nucleus does not have the features of a monocyte as far as the chromatin goes. Move ahead rapidly to the next case. And this was a 5-year-old female, left cervical lymph nodes. She also had axillary lymph nodes. The left cervical lymph nodes were quite abundant, though not too large. And spleen was also just palpable. So if this is a hematolymphoid malignancy, as it is likely to be, this is a very high stage affair. And do remember I said that low-grade lymphomas are high stage. And low-grade lymphomas, secondly, do not occur in children, virtually unheard of. So there was a paradox. And this was the aspirate, very busy aspirate, full of cells. Also, if we have a look at the mitosis, so we've got fair amount of mitotic activity. 1, 2, 3, and I think couple at the side, which is not visible. The cells are rather monotonous and they do not appear large. For comparison, let us have this L-shaped area enclosed by the black bracket. It shows us 3 cells which look like small lymphocytes. So that is the size of a small lymphocyte, to be contrasted with the black rectangle at the upper right part, and you have 3 lymphoblasts. Observe that the lymphocytes versus lymphoblasts, they're only about twice the diameter of the small lymphocytes, not larger, totally deficient in cytoplasm. Nucleoli 1 to 2, not more. And in fact, there are many cells with such similar chromatin but deficient in nucleoli. Remember that lymphoblasts L1, ALL, what we used to read, do not have conspicuous nucleoli. They have a grainy chromatin which is very well brought about in this black area. And the red rectangle is shown because here you have a mixture of both the cell types. So mitotically active, not large, it's intermediate or small, call it whatever you like. But the moment you see this, think in terms of a lymphoblastic lymphoma. Must also emphasize that most lymphoblastic lymphomas, though not all, occur between in adolescents and young adults, 10 to 25 years of age. They are high stage, like anaplastic large cell lymphomas, which also is fairly high stage, despite being high grade. And about 75% of cases have a mediastinal mass, because this is the precursor TALL, and the mediastinal mass can be responsible for severe embarrassment, respiratory, etc. And it can be an oncologic emergency. In fact, if you delay the diagnosis by a couple of days, you might lose the patient. And it's important to pick up this from other NHLs because the therapy is not R-CHOP, not lymphoma therapy. It is ALL therapy to which they respond. So next field shows you almost the same thing. The proportion of blasts is higher, much higher. Do remember that we call it a lymphoblastic lymphoma, but there are 3 cell types: small lymphocytes, lots of prolymphocytes, and lymphoblasts. Additional feature is that most of them have convoluted nuclei, not most of the cells, but nearly all the cases. And the convoluted nuclei might be few, and this is one at the center. The black arrow is pointing towards this. The black arrow in the upper field is also pointing towards the nuclear convolution, right? So this is a fairly common pediatric lymphoma. In fact, in my practice, it would be the commonest pediatric follicular lymphoma. And remember that there are others also. Anaplastic large cell, Burkitt also occurs. Some centroblastics also occur in this age group. And because of the rather small size of the cells, one might be confronted with reactive follicular hyperplasia. However, there's too much uniformity for a reactive follicular hyperplasia. Now, these are the pediatric lymphomas which I have shown. Hodgkin's is important. Lymphoblastic is there. ALCL is, it's like an eyesore. It speaks from the smear alone. Burkitt's has the same size as lymphoblastic, but is different because it is a very basophilic, greater amount of cytoplasm and cytoplasmic vacuoles. So we can make a diagnosis. So I'll proceed to the next case. I'm skipping most of the Hodgkin's, in fact, for the simple reason that it will engulf a lot of time. So if we have time, maybe at the end I might, but probably I'll skip that. And this is a child with right cervical lymph nodes, middle and lower, fairly bulky, individualized, long duration. And this is the aspirate. Remember that most of the cells are small lymphocytes, no blasts virtually. And this is a characteristic mirror image cell. Have a look at the nuclear chromatin. Apart from the mirror image, the nuclear chromatin is fine reticular. You can also see this bluish nucleolus here. And so this makes it a Reed-Sternberg cell. Reed-Sternberg cell in an appropriate background spells Hodgkin. It's important to understand that the mere presence of Sternberg-Reed cells does not lead to a diagnosis of Hodgkin's. It has to be there in a proper context. And this is the mononuclear cell. Hodgkin cell or atypical mononuclear cell has the same significance as a Sternberg-Reed cell. Now, problems abound with Hodgkin. I must say that only 25% of cases, or even maybe less, have the sort of picture which I showed you. The problems are that number one, juicy lymph nodes yield is deficient because there is fibrosis, necrosis. So often you feel short-changed. Granulomas may be present, misleading you into a diagnosis of tuberculosis. We bank on the presence of a reactive background which includes eosinophils. And I have always found that eosinophils are underrepresented in the aspirates and they have to be searched almost like an OR rod. And HRS cells, the Reed-Sternberg cells, Sternberg-Reed cells, may also be sparse quantitatively, that is, and qualitatively, often they have bare nuclei, which compounds the problem. The nucleoli may not be very conspicuous, at least under MGG. Hence, to ferret out these RS cells, one must embark on a committed search, and for that the background has to be appropriate. You look for AFB carefully, you spend half an hour only when you feel that this is likely to yield a positivity because you have a caseous background or a purulent background. Then so here clinical background is something which leads you to Hodgkin, and the clinical background is that the lymphadenopathy is low stage, localized, bulky, usually commonly one side of the neck, and long duration. Patients which look like Hodgkin cytologically of the history of 1 month, just throw that diagnosis out of the window because you are possibly overdiagnosing Epstein-Barr virus or other viral lymphadenopathy. So history is generally in several months, if not years. One case I had, which I have clipped, had a history of 6 years. And remember that HRS cells are not specific. They acquire specificity only when they are present in the appropriate background. And if you have too many Sternberg-Reed-like cells, that also is a red flag. It could be an anaplastic large cell lymphoma. It could be anaplastic carcinoma, pleomorphic sarcoma. So next case, 20-year-old female with right posterior cervical lymph nodes, upper as well as middle. Right. So I think all of you, I have made the correct diagnosis. Sternberg-Reed cell at the center, bare nucleus though, right? Lots of lymphocytes in the background, histiocytes. Next, reinforces what we saw. Cell yield is not abundant, which is common with Hodgkin's. But let's have a look at this. This is a group of cells, and that means that these cells are epithelial. If they are group, they won't be lymphoid cells. Okay. So this was a metastatic carcinoma. Remember that metastatic undifferentiated nasopharyngeal carcinomas may mimic lymphoma, especially because the primary is commonly not obvious. It is clinically occult, and this lymph node histology shows us what? Lymphoid background coupled with these aggregates of cells sticking together. So these are all epithelial cells. That's it. The syncytial-like appearance, washed out nuclei with very prominent nucleoli, modest amount of cytoplasm, and again, less spectacular syncytial aggregate of cells in a lymphoid background. And this was the immunohistochemistry on this case, showed positivity for cytokeratin, and P63 was positive, implying some degree of squamous differentiation, as is usual in a nasopharyngeal primary. And yes, Epstein-Barr virus positivity which is again quite characteristic of nasopharyngeal carcinoma. So this was a diagnosis in this case. This was another case who presented to a nephrologist with leg swelling and a sarca, facial swelling also. And he had a workup and appeared to be nephrotic. Serum albumin 2.47. Remember, for nephrotic syndrome, less than 3 qualifies. And this child had lymph nodes, which were not very obvious, but there was a bunch, not very large. And we aspirated and we got Hodgkin, clear-cut Hodgkin. This was about 4 or 5 days back. And so just to remind us that uncommon presentations can be there. Remember, Hodgkin's can occasionally give rise to a type secondary mesangiocapillary or membranoproliferative glomerulonephritis. And this was a 57-year-old male, right upper cervical lymph node, 1.5 centimeters, localized lymphadenopathy. We move to this field. What do we see? Right at the center, this looks something like a Sternberg reed cell. This question mark and a eosinophil, lots of lymphocytes in the background, looks like Hodgkin, right? Additionally, we have a granuloma now. Nice granuloma here, along with the Sternberg reed cell. So what does this spell? Remember, granulomas are common in Hodgkin. But for diagnosing Hodgkin, have a look at the background. This background here shows black arrows pointing towards a blast cell, which is unusual. There is also a mitosis here. Careful. Next field shows us a nice Sternberg reed cell sticking out. Red arrows are pointing towards blast-like cells here, large lymphoid cells. So not a Hodgkin, definitely. Additionally, we have the black arrow pointing towards small lymphoid cells which have cloven nuclei. And so this is a Lennart lymphoma. Lennart lymphoma is a peripheral T-cell lymphoma. It's an uncommon type, has an abundance of epithelioid histiocytes, and the small lymphoid cells often have cloven nuclei, and there is some admixture of large lymphoid cells too. And this was next case was a 70-year-old female with left cervical lymph node for the last 9 months. Abundance of Reed-Sternberg-like cells. So far, so good. Hodgkin's has only 1 to 10% at the most neoplastic cells. The rest is a reactive population, and here almost 25 to 50% are neoplastic. So this can be anything but a Hodgkin. And additionally, we get a mitotic figure at the center. So things to watch out for. Same case, another field, lots of RS-like cells, and in addition, you have cells with some embryoid nuclei. That's another embryo, one embryo, this one, 2 embryos. So anaplastic large cell-like morphology. Could be an anaplastic large cell lymphoma, but some other lymphomas can also show you similar morphology, provided you exclude anaplastic carcinoma and pleomorphic sarcoma. So ALCL will require some workup. And this is a 40, this was an interesting case, a 40-year-old female with cervical lymph nodes. She had pancytopenia, she had fever, and she had bulky abdominal nodes also. And she was quite unwell. She was slipping, in fact. The clinician had a suspicion of tuberculosis, and we aspirated. And one can see lots of lymphoid cells. But additionally, apart from that, we have fair numbers of histiocytes which are interspersed, right? And here is a small aggregate of histiocytes. So maybe some sort of histiocytosis. And yes, if you are suspecting tuberculosis, well, we here have a giant cell too, though not classically Langerhans type of giant cell. And the histiocytes again are catching your eye at the bottom center. Yes. Okay. Proceed ahead. This field shows you a classical granuloma too. So now the goose is cooked. Histiocytes at the lower right. group of histiocytes, non-epithelioid, and of course lymphocytes elsewhere. This field shows us what? Two eosinophils, red arrows for eosinophils. So eosinophils are not usually part of a background of tuberculosis. Is it Hodgkin? Hodgkin can have lots of histiocytes, but black arrow is pointing towards the nucleus. This is a histiocytic cell. What do we see? We see a curved groove clearly, longitudinal groove. If you just follow this, this is a grooved nucleus. Plasma cell, few, and this field we have done with, and that's another field showing some phagocytosis, the black circles, and she had pancytopenia, remember, and this could be an explanation for the pancytopenia. Group of histiocytes, again longitudinal grooving of the nucleus can be made out. Yes, two black arrows, very nice grooved contorted nuclei. Again, the red arrow on the left shows you an oblique groove and a longitudinal groove, the red arrow on the right, the coffee bean type of nucleus. That's it. Other cells also have a contorted nuclei. So these features are classical for a Langerhans cell histiocytosis. Remember that Langerhans cell histiocytosis usually has several giant cells and eosinophils, but it is the bad type of Langerhans cell histiocytosis which show a predominance of these histiocytic cells with a deficiency of eosinophils, because otherwise the eosinophils catch your eye and lead you to a correct diagnosis, but here they are lacking. And this patient was referred to a corporate hospital in Delhi who did a lymph node biopsy and returned a diagnosis of necrotizing granulomatous lymphadenitis favoring tuberculosis. She was put on anti-tuberculous therapy for 2 months without any benefit. In fact, there was significant deterioration of her condition, and the patient's attendants left Delhi for Jaipur, where a biopsy was again undertaken, and this time the morphology suggested the possibility of Langerhans cell histiocytosis with immunohistochemistry. CD1A, S100, CD45 was suggested. I couldn't get hold of the immunohistochemistry, but I suspect strongly that it was done, because then she was admitted and given chemotherapy with the diagnosis of multi-system LCH. And so this was a multi-system LCH. Now, this was a case who on CT scan, she showed multiple, had multiple heterogeneous enhancing nodal masses, bulky, retroperitoneal and mesenteric, and we got ultrasound guided FNAC. And it showed clearly, I think by now it's clear to everyone, that this appears to be a large cell lymphoma, lots of lymphoglandular bodies at the base here everywhere. And this is a small lymphocyte. And for comparison, and these cells are at least twice the size. And so a diagnosis of large cell lymphoma was suspected. Point to be noted is that large cell lymphoma and granulocytic sarcoma, myeloid leukemic infiltrates, they look exactly alike. So pointed search should be made for eosinophilic precursors because they light up the cytoplasm. But it is not invariably that one can get them. So this was diagnosed as a malignant hematolymphoid neoplasm consistent with large cell lymphoma. If granulocytic sarcoma, if acute leukemia can be excluded. She had a blood smear done. I'm sorry for it's not a very good quality one, but you can see that there is a neutrophil here, and in this field alone there are at least 3 immature cells, and they do show the presence of cytoplasmic granules. So this indeed was a granulocytic sarcoma, another nucleolated cell with cytoplasmic granules. So that's it, and I thank you so much for the patient hearing. I don't know whether it has been patient or impatient, but I'm grateful to you all.
Thank you, Dr. Gupta, for your wonderful, crisp presentation. And I think you made diagnosis quite clear for the budding pathologist and the pathologist equally, senior ones equally. It was a wonderful talk, which we enjoyed.
Thank you so much. I'm fairly sure that the senior pathologists would have felt that it is spoon feeding, but I think it is mainly the junior pathologists who feel that lymph node is a Pandora's box and they get lost.
No, sir. When things are well explained, everybody enjoys that.
Thank you.
I request Dr. R.K. Gupta sir, to please introduce Dr. Pradyuman. Next one is.
Thank you so much, sir, for your informative talk. Now, I request our chairperson to kindly introduce our third speaker for this session, Dr. Bharti Ramnani, ma'am. We welcome you, ma'am.
Let's start.
Yes, sure, ma'am.
Yeah, ma'am, we will be lucky to hear you now.
Good evening, everyone. I'm Dr. Bharti Ramnani. I'm a consultant histopathologist in Dr. L.H. Hiranandani Hospital and Holy Spirit Hospital, Mumbai. So I'll just have one case and I hope everybody can hang on for just 10 minutes. I'll start sharing my screen.
Okay, ma'am.
So my case is a mesenteric mass with a very unusual presentation. This was a 31-year-old male who came into emergency with complaints of para-umbilical colicky abdominal pain since 10 days. On physical examination, abdomen was distended. A mass was palpated in the mid-abdomen. CT scan showed a huge heterogeneously enhancing mass in the mid-abdominal mesentery, which was about the size.
Sorry for interruption, ma'am. Ma'am, your screen is not visible.
Oh, I started. 1 second. Is it visible now?
Yes, ma'am, it is visible.
Okay.
Thank you, ma'am. Thank you, ma'am.
So this was a 31-year-old male who came with para-umbilical colicky pain since 10 days, and CT showed a huge heterogeneously enhancing mass in the mid-abdominal mesentery, which was about 24 centimeters in the largest dimension. The tumor markers were all within normal limits, and clinically the suspicion was GIST. Exploratory laparotomy was performed. This is the gross findings of the specimen which we received. This was a large nodular mass, about 24 centimeters in size, and the outer surface was nodular and congested. This is the cut section showing large areas of necrosis in the center, and the rest of the solid areas were forming multiple whitish and grayish nodules, and there were multiple necrotic areas. This is the low power of the specimen, showing the tumor, which is a spindle cells arranged in fascicles and storiform pattern. This is the higher part, again showing spindle cells with vesicular nuclei, prominent nuclear membranes, and the cell membranes were indistinct, forming a kind of syncytial pattern. There were also intermixed some lymphocytes and occasional eosinophils with the spindle cells. So now the diagnosis we considered was the mitosis was very scant, very occasional mitosis were seen, but necrosis was there, not much pleomorphism. So the diagnosis of low-grade spindle cell tumor, the differentials considered were gastrointestinal stromal tumor, leiomyoma, inflammatory myofibroblastic tumor, because there was some inflammatory cells component to the spindle cells, and a sarcomatoid carcinoma. So we did a panel of IHC2 considering all these differential diagnoses, and the results of IHC were as follows. We can see here that the Vimentin was diffuse and strong positive. However, c-KIT, SMA, desmin, calpanin,
ALK and CK were all negative, hence ruling out the possibility of GIST and an inflammatory myofibroblastic tumor in a leiomyoma or a sarcomatoid carcinoma. What we did get was patchy S100 positivity, as we can see in this photograph. These are the S100 positive staining cells. CD34 was negative, highlighting only the blood vessels. And this was the Ki, which was low, around 5 to 7%. So now what next? So considering S100 positivity and also the intermixed component of lymphocytes, which were present throughout the tumor and mixed with the spindle cells, we considered adding the immunohistochemistry for CD21, CD35, CD23, and CD68, and all of which were positive. So diagnosis, the final diagnosis made was extranodal follicular dendritic cell sarcoma of the mesentery. Now, this patient was given chemotherapy and radiation. However, tumor recurrence was noted after a year, and patient presented with multiple nodules of bowel wall and omentum. After 3 years, PET scan showed multiple recurrent nodules adherent to the diaphragmatic surface. No surgical intervention was done after the tumor recurrence, and patient is now on palliative chemotherapy. Now, etiology and other clinical features of extranodal follicular dendritic cell sarcomas. These are intermediate grade malignant tumors of follicular dendritic cells. FDCS was first described in 1986 in a lymph node by Monda et al. However, although the occurrence of extranodal FDCS has been noted since 1994, it is often misdiagnosed because in routine IHC panels, we do not include markers for follicular dendritic cells in case of an undifferentiated neoplasm or a spindle cell tumor. The nodal sites, the most common nodal site is cervical, followed by axillary or supraclavicular lymph nodes. The extranodal involvement includes a wide variety of sites, including head and neck, gastrointestinal tract, liver, and spleen. It usually presents as a painless mass and has an indolent clinical course. However, local recurrence is quite common, as was present in our case. Metastasis to the lung, liver, or lymph nodes has also been noted, although rare. There is no optimal therapeutic option for follicular dendritic cell sarcomas. Localized follicular dendritic cell sarcomas are treated by surgical resection with or without adjuvant chemotherapy and radiation. Morphological findings I have already mentioned. In our case, spindle to oval shaped cells in sheaths, fascicles, or whorls, and the tumor cells exhibit plump eosinophilic cytoplasm, ill-defined cell borders, elongated or rounded nuclei, and vesicular chromatin pattern. The characteristic feature is also a mixture of lymphocytes and occasionally other inflammatory cells, including eosinophils and neutrophils. The immunohistochemistry cluster is a highly sensitive and specific marker for FDCS. Other markers include CXCL13, CD21, CD23, 35, odoplanin, CD68 and FASN have variable staining, and Claudin-4. Prognostic factors which are poor prognostic factors which predict recurrence are size of the tumor more than 6 centimeter, nuclear pleomorphism, increased mitotic rate, necrosis, and intra-abdominal location. Differential diagnosis for FDCS are interdigitating dendritic cell sarcoma. These are usually positive for S100, diffuse positive, but they are negative for all other markers of follicular dendritic cells, including CD21, CD23, and CD35. The second differential diagnosis is Langerhans cell histiocytosis. The Langerhans cells are positive for CD1A and Langerhans. Kaposi sarcoma can also be a differential diagnosis. Their atypical spindle cells form slit-like vascular spaces containing red blood cells, but the tumor is positive for HHV8. And clinical history of HIV is also important in this case. Spindle cell thymoma comes in the differential diagnosis if the location is anterior mediastinum. However, the thymomas are positive for keratin, AE1 and AE3. Inflammatory myofibroblastic tumor is also a differential, which is considered because it contains spindle myofibroblasts and fibroblasts with bland nuclei. It is positive for ALK1 and SMA, and other spindle cell tumors, according to the location, are considered as a differential diagnosis. So now the main thing which I wanted to highlight with this case is that we do not consider extranodal follicular dendritic cell sarcomas at unusual locations. Like in our case, it was in the mesentery and it is easily missed. There are many case reports which have been missed on the initial workup, and they have been diagnosed on when the tumor recurs and the IFC for FDCs is performed later on. This is a review of extranodal follicular dendritic cell sarcoma, which is a case series of 54 cases over a period of 14 years, just to get an overview that the rarity of extranodal follicular dendritic cell sarcomas. And this has been conducted by Dr. Ramandeep Kaur and Dr. Jay Mehta and Dr. Anita Borges. These are other references for extranodal follicular dendritic cell sarcomas of other regions, which include head and neck region and abdomen. Thank you for your patient hearing. I'll be happy to answer any questions.
Thank you, Dr. Bharti, for an interesting case presentation. And such cases are really a big help to postgrads and also practicing clinical histopathologists. Thank you very much for your informative talk.
Pleasure. I'm glad to be participating in this.
You've taken a time to spare your time for our conference. We are thankful to you for that.
Thank you. Thank you, ma'am.
Thank you so much, ma'am, for this informative session. Now, the house is open for discussion. Now, I request Dr. R.K. Gupta, sir, to kindly conclude the session. Thank you, sir. Well, indeed, it was a very good presentation. Now, to extend and project our confidence and appraise towards the guest speakers and session chairperson, we would like to present the memento followed by certificate of appreciation. Now, the certificate of appreciation. Now, the certificate of appreciation for Dr. R.K. Gupta, sir. Thank you, sir. Kindly accept it, sir. Now, the certificate of appreciation for Dr. Shyamali Datta, ma'am. Thank you, ma'am. Kindly accept it, ma'am. Now, the certificate of appreciation for Dr. Anurag Gupta, sir. Kindly accept it, sir. Now, the certificate of appreciation for Dr. Atul Gupta, sir. Thank you, sir. Kindly accept the certificate.
Thank you.
Now, the certificate of appreciation for Dr. Bharti Ramnani, ma'am. Thank you, ma'am. Kindly accept the certificate. With this, day 1 is ending. Tomorrow, we will be again meeting on Zoom at 11 o'clock with the same ID. Till then, stay safe and stay happy. Thank you. Bye-bye, everyone.